we have is on a valvular heart disease. Repeatedly asked valvular heart disease questions are mainly about aortic stenosis and mitral stenosis. Apart from that, heart failure, the constrictive pericarditis, cardiac tamponade, these are important topics from cardiology, and emerging topics include pulmonary embolism. Okay, so we'll start with the first question, that is on the aortic stenosis. The question might go like this: discuss the etiology, clinical features, diagnosis and management of aortic stenosis. Now, any valvular heart disease question, the first thing you should do is put a neat image depicting the position of the valve. Where is that valve position, between which chambers, and also mention the normal size of that valve. If possible, if you have a fair idea, mention in cardiac cycle where exactly this valve opens and where exactly this valve closes, and then start the discussion on the rest part that is asked in the question. If you don't remember, fair enough, at least put a sketch and mention where exactly the valve is located. So let us begin by discussing 2-3 minutes on the basic aortic valve anatomy, and then we will talk about aortic valve stenosis. So as we know, aortic valve is a valve positioned between the left ventricle. So if this is my left ventricle, this is my left atrium, and this is aorta, then the aortic valve is positioned between the left ventricle and aorta. The exact site of its location is called the root of aorta. So this part of the aorta, the initial part of the aorta, we call it as a root of aorta, and aortic valve is situated in the root of aorta. So first point to note, this is my aortic valve. This part where it is located is called as aortic root or root of aorta. And its objective, the reason why aortic valve is there is to allow the unidirectional flow of blood from left ventricle to aorta and not allow the blood to flow back from aorta to left ventricle. Now, its normal opened size. So just like any other valve, the aortic valve is made of a connective tissue ring. It is made of a connective tissue ring, and that connective tissue ring we call it as annulus. So it has an annulus or a connective tissue ring, and to that connective tissue ring the cusps or valve leaflets are attached. So examiners would be interested to know whether you know how many leaflets are present in a valve. So make it a point that you do write about the number of cusps present. So this part of the aortic valve is called as annulus. Annulus is a connective tissue ring which helps the cusps to hold on to the wall of the aorta. And then there are 3 cusps. We can number them as 1, 2, 3, or you can also call them as the right, left and non-coronary cusps. So these 1, 2, 3 are the cusps or leaflets. So aortic valve is a 3 leaflet or 3 cusped valve. Okay, and its normal orifice size when open. The normal orifice size is usually 3 to 4 centimeters square, and whenever the opening is less than 2.6 centimeters square, we will call it as aortic stenosis. We will call it as aortic stenosis. Okay, now what is the function of the aortic valve? As I just told you, the aortic valve should allow the movement of blood from left ventricle to aorta. So now one of you should tell me, when the movement of blood happens between left ventricle to aorta, is it during systole or is it during diastole? I'm discussing a little more on the valvular heart disease because this is not only going to be your theory question, but this is also going to be the questions that the teachers are going to discuss in your case presentation. So for a final prop student, of course, you need to know basic valvular heart diseases, right? So the blood moves from left ventricle to aorta during systole. Systole, we eject the blood. During diastole, we fill the ventricle. During systole, we eject the blood from the ventricle. So blood moves, yes, absolutely right. So if the opening of this aortic valve is narrow, is it going to disturb the diastole or is it going to affect the systole? Of course, the blood is moving during the systole. So if the opening is narrow, it is going to disturb the systole. So simple words, we can think of aortic stenosis as a problem of systole. The problem of systole. Okay, this much is clear. So with this basic introduction, we are talking about aortic valve stenosis. Normal opening is 3 to 4 centimeters square, less than 2.6. We are considering it as stenosis. And this stenosis is going to affect the systole of the cardiac cycle because during systole, the blood moves from left ventricle to aorta. Okay. Now let us talk about the causes. Why this aortic stenosis happens? The causes wise, it is better if you mention the most common cause than the other causes. So the most common cause for aortic stenosis is age-related degeneration of the aortic valve. Just now I told you that the aortic valve is inserted into the root of aorta. And because it is in the root of aorta, it is not exactly in the left ventricle, it is in the aorta. The atherosclerosis that develops in the aorta also encroaches upon the aortic valve cusps. And the atherosclerosis of the cusps makes them get calcified. It's a natural aging process. And because of the calcification, the valve cusp becomes stiff and they find it difficult to open. In simple words, we will call it as age-related degeneration. More technical terms, we can say the problem begins with atherosclerosis. The problem starts with atherosclerosis of the aortic valve that eventually leads to calcification. And once there is calcification, you can call that stage as well as the aortic sclerosis. And once it starts creating the obstruction to flow of blood from left ventricle to aorta, we will call it as aortic stenosis. So this is a process, age-related degeneration. That also means that most of the patients of aortic stenosis are going to be elderly, not your middle-aged or young individuals. But we do see some young patients presenting with aortic stenosis. So in that case, what could be the cause? The most common cause in young individuals. The most common cause in young individuals is going to be having congenital. We just learned that there are 3 cusps in the aortic valve, but some people are born with only 2. We will call that condition as congenital bicuspid aortic valve. And congenital bicuspid aortic valve is the most common cause for the aortic stenosis in young individuals. So if you see someone in their 20s, 30s or 40s presenting with AS, it is most likely because of congenital bicuspid aortic valve. But if I see someone in their 70s or 80s presenting with aortic stenosis, it is most likely because of age-related degeneration. Congenital bicuspid aortic valve, usually abbreviated as BAV. If you can remember, also mention the most common cause, because it is congenital or inherited. Of course, mutations may be responsible. There are so many mutations responsible, but among them, the most common mutation responsible for this congenital bicuspid aortic valve is mutation in a gene called as Notch1. This is an important MCQ point as well for the MCQ based exams. Apart from this, various other conditions are considered as risk factors for aortic stenosis. You don't have to write it in a theory paper, but for your MCQ knowledge or for your bedside discussion, you should know. We just learned that atherosclerosis is the root cause. That is where the problem of aortic stenosis starts. Atherosclerosis eventually leads to calcification of the valve, and then you have aortic stenosis. So anything that increases the risk of atherosclerosis increases the risk of aortic stenosis. Smoking, yes. Diabetes, yes. Dyslipidemia, yes. Sedentary lifestyle, yes. So all the conditions that increase the risk of atherosclerosis are risk factors for aortic stenosis. Okay. Now these are the common causes you need to write. Now after the causes, let us say someone he started aging, and because of aging he has developed aortic stenosis. What symptoms he is going to present with? Just to make sure we understand symptoms well, let me begin with the pathophysiology. Exactly what happens when there is aortic stenosis. We just learned that the problem is mainly systolic. In the systole, the blood moves from left ventricle to aorta, but if the opening is narrow, the movement will be hindered. So let us say someone has developed aortic stenosis. Now, if someone develops aortic stenosis, I will find it difficult to eject the blood from left ventricle to aorta. So the amount of blood I eject from the ventricle to aorta in one systole, what do we call that amount as? The amount of blood ejected by left ventricle to aorta in one systolic contraction. We call that as stroke volume. And don't you think the stroke volume is partially dependent on the opening of the aortic valve? If the valve is not completely open, will I be able to get a good amount of blood pushed out from the ventricle to aorta? No, the opening becomes a limiting factor. Smaller the opening, less amount of blood get ejected to aorta. So can I say aortic stenosis leads to decrease in stroke volume? Yes, perfectly right. We will have decrease in the stroke volume because of this aortic stenosis. So the first pathophysiological change we might notice is decrease in the stroke volume. Aortic stenosis leads to decreased stroke volume. Will it lead to some symptoms? If the stroke volume decreased, will it lead to some symptom? Yes. Stroke volume is very much necessary to perfuse the organs for their normal functioning. If stroke volume is less, the brain may not get sufficient blood supply, your muscles may not get sufficient blood supply. Because muscles are not getting sufficient blood supply, patient loses his effort tolerance. They start getting fatigued easily. So fatigue is one of the symptom I can expect because of decreased stroke volume. Second, if brain does not get sufficient blood supply, I may go through episodes of syncope or syncope, as you would like to call it. So we can get fatigue and syncope. Well, we do expect hypotension, because please remember, your systolic BP is directly proportionate to stroke volume. Higher the stroke volume, higher is your systolic BP expected. But once the stroke volume starts decreasing, the systolic BP starts decreasing, but body has a counter regulatory mechanism, that is renin, angiotensin, aldosterone system, that will correct the BP. So most of the patients of aortic stenosis may not have hypotension at the time of presentation. Why they don't have hypotension? Because though we are dependent on stroke volume for regulating the BP, we have a counter regulatory system, that is RAS, which can elevate it. So you need not always have hypotension, but the RAS may not elevate the stroke volume perfectly. So because of that, you will continue to experience fatigue and syncope. So that is one set of symptoms. The problem is not over just because I got fatigue and syncope. Aortic stenosis is not all about fatigue and syncope. We can have other problems. What other problems? If I did not eject sufficient blood, if I start struggling to eject the sufficient blood, do you think left ventricle should keep quiet? Don't you think left ventricle would put more effort to try to eject the blood out into the aorta? The amount of work that left ventricle starts doing to push the blood through this narrow opening starts increasing, right? The workload on the left ventricle is increased. Now, can anybody tell me what kind of workload is this? What kind of workload is this? See, because in cardiology, we have two types of workload. One is called as afterload. The other one is called as preload. See, let us say this is my ventricle. Okay. It has to eject the blood up. Okay. Now, in this ventricle, I have 200 ml of water. So if I want to push this out, I need to do some X amount of work. But next time I add 400 ml. Do I need to do the same amount of work to eject the blood up, or I need to put more effort now? Earlier it was 200 ml. So to push 200 ml up, I had to put X amount of effort. Now it is 400 ml. I need to put 2x effort. So the amount of blood that is present in the ventricle before I start the systole is an important determinant of the work done by the ventricle, right? The more blood in the ventricle, more is the work that ventricle needs to do. Now this volume, we call it as end diastolic volume, because this much of blood is there at the end of diastole and we are about to start the systole. And this is there before I started the systole. So we will call this as preload. It is there before I started the systole. End diastolic volume is equal to preload. More the volume, more effort ventricle needs to eject. But once the ventricle start the process of ejection, do you think aorta is welcoming the blood? It's like, okay, de do mujhe blood, I need blood. No, it's a closed tube, right? If I have to blow air into the atmosphere, like imagine this is my ventricle, my mouth is ventricle, I'm blowing air into the atmosphere. I don't encounter much resistance. But what if I have a small tube and I try to blow air into that? I have to put more effort, right? Because the tube is going to resist the entry of air into that tube. Similarly, when left ventricle is ejecting the blood into the aorta, it is not ejecting into the free atmosphere. It is ejecting into a closed tube. Aorta is a tube. So aorta gives some resistance to that ejection. And ventricle's effort has to overcome that resistance. So more the resistance aorta gives, more effort ventricle has to put. So that resistance, we will call it as afterload, right? So for those who don't know, let me write some key terms that might help you for revision. So the first term is end diastolic volume, the amount of blood present in the ventricle at the end of diastole before I start the systole, and that is also called as preload. More it is, more the work done by the ventricle. Second, resistance by aorta and its branches for ejection of blood. For ejection of blood by left ventricle, we will call that as afterload. Now, normal circumstances, aortic valve opens completely. It is not contributing to this resistance. Only resistance comes from the aorta. This valve completely opens, so any resistance that comes, it only comes from the aorta. But now that the valve opening is narrow, don't you think it is resisting? And to overcome that resistance, ventricle has to do more work, right? So what is increase in aortic stenosis? We have increase in the afterload, the resistance for the ejection of blood, increase in the afterload. So aortic stenosis leads to increased afterload. Now you may be thinking why sir is stressing so much of the physiology terms, right? You will understand when we discuss little more about the pathophysiology. Now to overcome this resistance or increased afterload, ventricle does more work. And the nature of the muscle is that ventricle is muscle. Nature of the muscle is that more the work it does, more it grows. So it is going to develop a hypertrophy, left ventricular hypertrophy. But the left ventricular hypertrophy is of two types. The first type, we will call it as concentric, and the second type, we will call it as eccentric. So what is concentric hypertrophy? In concentric hypertrophy, if say, let us say this is the left ventricle and aorta I'm looking at, this is normal size left ventricle, let us say. In concentric hypertrophy, the muscle mass gets added inside the ventricle. The outer dimension of the ventricle doesn't change much. It is as it is. If I look from outside, this chamber of the ventricle looks of same size, but inside the thickness is increased. We will call that as concentric hypertrophy. In eccentric hypertrophy, the muscle mass gets added outside. So if this is the ventricle we are looking at, the muscle mass gets added outside. In both the cases, thickness of the left ventricular muscle mass is increased. But in concentric, the outer dimension of the ventricle is not changed. In eccentric, the outer dimension is changed. It appears big. So increased preload leads to, you should note that increased preload results in eccentric hypertrophy. Preload means end diastolic volume. So if I have more volume inside the ventricle, to keep that volume, I need space, right? So is it a wise decision for the nature to put the muscle mass inside if the volume of blood inside the ventricle is already high? So I don't want to compromise the cavity size. I will add the muscle outside. This is what we call as eccentric hypertrophy, because here the main problem was volume increase in the ventricle. But when the resistance by aorta or its branches increases, I don't have a volume problem. So then I can add the muscle inside. So generally when there is increase in the afterload, increased afterload leads to concentric hypertrophy. So now tell me, in aortic stenosis, what kind of left ventricular hypertrophy we are expecting? This is concentric hypertrophy, left ventricular hypertrophy. This is eccentric left ventricular hypertrophy. Yes. So in the aortic stenosis, because we have the afterload increase, the resistance by the narrow aortic opening increased, we develop concentric LVH. And what will happen to the volume of the ventricle if I develop concentric? It becomes small, and that will create problems for us. So that was very good. So it is going to result in concentric left ventricular hypertrophy. So it will create two problems for us. Number one, you have concentric left ventricular hypertrophy. Now the muscle mass is increased. Don't you think it needs more blood supply to survive? More the muscle mass, it needs more blood supply. So there is increased myocardial oxygen demand. Now this large bulky ventricle needs more blood supply. But then blood to the heart's muscle comes from where? Coronary arteries. And coronary arteries originate from where? Coronary arteries originate from the aorta. So if I'm not pushing sufficient blood into the aorta, do you think I'm pushing sufficient blood into the coronary arteries? No. So the decreased stroke volume also means that there is decreased coronary flow. There is decreased coronary flow. So on one side, there is less blood supply to the blood vessels because of low stroke volume. and on the other side, the heart's muscle wants more blood supply. So there is a clear mismatch between the demand of the myocardium and what coronaries are able to provide. And what symptom this can lead to? There is a demand supply mismatch. And what symptom we can expect because of this? Yes, the muscle will suffer through ischemia. And what is the symptom of ischemia? Chest pain, which is called as angina. So angina is one more symptom that we can expect because of the aortic stenosis. So syncope is one, angina is another. What else this concentric LVH can lead to? Now we just learned that concentric LVH means the left ventricular volume is reduced. And because of that, when I want to fill the blood into the left ventricle, right? Don't you think I will have difficulty to fill this ventricle? Because again, here Boyle's law comes into picture. Boyle's law says volume and pressure are inversely related. Volume and pressure are inversely related. So if the volume of the ventricle is reduced, what happens to the pressure inside the ventricle? Pressure inside the ventricle increased. And yesterday I told you that the fluids move from high pressure to low pressure zone. So already ventricular pressure, normally let us say this is ventricular pressure. Now I developed concentric LVH, ventricular pressure increased this much. Now to fill this ventricle, the pressure in the left atria has to go above that of the left ventricle. So left atrial pressure will increase. If left atrial pressure increases, we just learned yesterday as well that if pressure in the left atrium increases, eventually the pressure in the if the left atrial pressure increases, because left ventricular pressure became high by its volume decrease. Now to fill that, left atrial pressure has to go above that of the LV. So now to fill the blood from pulmonary vein to left atrium, the pulmonary vein pressure has to increase above that of the left atrium. And to move the blood from the pulmonary capillaries to pulmonary veins, the pulmonary capillary pressure has to increase above that of the pulmonary veins. So the problem, whenever it starts in the left side of the heart, eventually reaches the lungs. Here it will cause congestion of the pulmonary capillaries because of rising pressure, and that congestion will lead to a symptom which we call it as dyspnea or shortness of breath. So every time you talk about or write about left heart disease, one standard symptom you can write with eyes closed, that is shortness of breath or dyspnea. This also applies to mitral stenosis. If I have mitral stenosis, this opening is narrow, left atrial pressure increases, then pulmonary vein pressure increases, pulmonary capillary pressure increases, you have shortness of breath. So one symptom that you can write for all left-sided conditions is dyspnea, because left-sided conditions always lead to congestion in the lungs. Mitral stenosis, mitral regurgitation, aortic stenosis, aortic regurgitation, and left heart failure. For all of them, dyspnea is going to be standard symptom. Similarly, if I have a problem on the right side of the heart, the pressure will build up in the right atrium that will lead to raised JVP, ascites, hepatomegaly. So those symptoms you can write for all right heart disease with eyes closed. Okay, clear? So now in the aortic stenosis, we are expecting the concentric LVH will result in increase in left atrial pressure. In a theory exam, you don't have to write step by step saying that left atrial pressure increase leads to pulmonary vein pressure increase, pulmonary vein pressure leads to increase in the pulmonary capillary pressure. You can just mention the left atrial pressure will lead to pulmonary congestion. Congestion of blood in the pulmonary capillaries. That's pulmonary congestion. And that can lead to a symptom, we call it as dyspnea or shortness of breath. So as we see here, we are expecting three symptoms, which you can remember with a simple mnemonic ASD, angina, syncope, and dyspnea. Right? ASD. So now that you know the pathophysiology, it's easy for us to write down the symptoms or clinical features. So symptoms or clinical features of aortic stenosis are angina, syncope, dyspnea. The mnemonic is ASD. And the reason I want you to remember it as ASD, because you can also say, sir, I can also remember it as SAD. When you have aortic stenosis, you become SAD. Fair enough, but ASD is the ideal way to remember it because that is the sequence of appearance of symptoms. The earliest to appear, earliest symptom is angina, and late symptom is dyspnea. So that's why if you have a patient of aortic stenosis for bedside discussion, case presentation, and the teacher asks which symptom suggests that aortic stenosis is very severe, you should mention dyspnea, because dyspnea appears quite late. Angina is the earliest symptom. Okay, so these are the clinical features. The mnemonic to remember it is ASD. So let me summarize what we have discussed so far. If there's a question on valvular heart disease, make sure you write at least 2-3 lines about the valve anatomy. That pleases the examiner, that he will know that you're not giving a mugged up information, but rather you're giving a core clinical concepts. Okay, so then he will definitely give you half or 1 mark more. Then start with the causes. When we are talking about aortic stenosis, you have to remember only 2 causes for the theory exam. The most common cause overall is age-related degeneration, but in young individuals, it is congenital bicuspid aortic valve. In terms of pathophysiology, the narrow opening of the aortic valve results in restriction of movement of blood from left ventricle to aorta that happens during systole. So because of that, the stroke volume is less. Low stroke volume leads to syncope. And on the other hand, the narrow opening also creates more burden on the left ventricle to push. That increased burden is increased afterload, and increased afterload results in concentric LVH. The concentric LVH means that the more the muscle mass, more is the blood supply demand, which cannot be met because of low stroke volume. So we end up with angina as a symptom. Second, with the concentric LVH, the left ventricular volume decreased, and by Boyle's law, anytime volume decreases, the pressure increases. So once the LV pressure is high, left atrial pressure has to be higher than that to fill it. So eventually, every chamber behind it in the hierarchy starts developing increase in the pressure. It reaches the lungs, and in the lungs, it causes pulmonary congestion, whose symptom manifests as dyspnea or shortness of breath, giving rise to these 3 standard symptoms of ASD: angina, syncope, dyspnea. Angina is earliest, dyspnea is last symptom to appear. Okay. Apart from that, you can expect one more manifestation in patients with aortic stenosis, which is called as Heyde syndrome. What is this Heyde syndrome? It's a triad of 3 manifestations. The first one is calcific aortic stenosis, which is the most common cause. Means age-related degeneration leads to calcification of the aortic valve, and that causes stenosis. Young individuals, it is bicuspid aortic valve. But this Heyde syndrome is seen in patients with age-related aortic stenosis. Calcification of the aortic valve results in something called as acquired von Willebrand disease. Von Willebrand disease. Now you may be wondering, what is this acquired von Willebrand disease? So you may be knowing that there is a factor called as von Willebrand factor. This factor is present in the subendothelial space. So if this is a blood vessel, the innermost lining is endothelium, and just behind the endothelium we have these von Willebrand factors, which acts as platelet receptors. Every time there is injury to the endothelium, the von Willebrand factors get exposed, and because platelets have the receptors to bind to these von Willebrand factors, they will come and bind. That is how we achieve the platelet adhesion. The von Willebrand factor is responsible for the platelet adhesion whenever there is injury to the blood vessel, and that helps us preventing the blood loss. But then in the calcific aortic stenosis, what happens is the von Willebrand factor, which is in circulation, when it is passing through the aortic valve, it hits that calcified aortic valve. And when it hits the calcified aortic valve, it gets fragmented, because von Willebrand factor is a large molecular weight protein. And when it hits the calcified aortic valve, it gets broken down into tiny fragments. And those fragments are inactive. So you're producing the von Willebrand factor. You don't have any genetic problem, but that von Willebrand factor is getting destroyed by the calcified aortic valve, and every ml of blood has to pass through the left ventricle. So most of the synthesized von Willebrand factor is getting exposed to aortic valve, and it is getting broken down. So it is getting inactivated. So this condition we will call it as acquired von Willebrand disease. And many of us may have some arteriovenous malformations in the GIT, where micro injuries keep happening, but the platelet adhesion prevents further blood loss. But now that I have acquired von Willebrand disease, I may not be able to prevent bleeding in those GIT areas, and I end up developing gastrointestinal tract bleed. So when these 3 things come together, we call it as Heyde syndrome. Not seen in all aortic stenosis patients, but at least few of them may develop it, right? So ASD plus Heyde syndrome. This is all you need to write about clinical features. Now coming to the examination findings. So be it your bedside discussion or be it theory paper, for all valvular heart diseases, the assessors are expecting 3 information. on examination. Number one, you should be able to mention what is happening to pulse and blood pressure in each valvular heart disease case, because in some cases the pulse pressure becomes wide, in some cases the pulse becomes feeble, and there are some named findings. Second thing they're expecting is you should mention what is happening to the apex beat on examination. This is commonly asked in your bedside discussion. Third thing is murmur, right? So first let us talk about the BP. In aortic stenosis, we expect the BP to be low. Why we are expecting the BP to be low? Because the stroke volume is low. But then, as I have already told you, the RAS counters it and you will end up getting normal BP. It is because the low BP is countered by the renin-angiotensin-aldosterone system. Some patients may have relatively lower systolic BP. You are not going to get them to have a fully elevated systolic BP. You may get on the lower side of the normal. When it comes to pulse, remember, when you are palpating for the pulse comes and hits your finger, right? How forcefully it hits, that is dependent on the stroke volume. The peak of the pulse, if I have to put a waveform of the pulse, it has a peak, right? This peak depends on the stroke volume. It is directly proportionate to stroke volume. So lesser the stroke volume, peak becomes smaller. Further less the stroke volume, peak becomes smaller. So pulse, that small peak of the pulse is called as anacrotic pulse. Anacrotic pulse. It is nothing but a small amplitude or small peak pulse. In mild to moderate aortic stenosis. Mild to moderate aortic stenosis. Yes, the common day-to-day conversation for this small amplitude pulse is feeble pulse. The technical term is either you can call it as pulsus parvus or anacrotic pulse. It is also called as anacrotic pulse or pulsus parvus. Parvus means small. Amplitude is small. Then one more thing you have to remember, when I'm ejecting the blood from left ventricle to aorta, and that ejected blood volume is deciding the peak of the pulse. The more I eject, more I push into the aorta, I will get a stronger pulse. The rate of ejection also matters. Means the peak of the pulse depends on the volume, but the rate of ejection decides after how much time the pulse started, the peak will be hit. Means, let me give you a picture so that you can understand. Let us say I get the peak of the pulse normally like this. This is a normal pulse, normal peak. So from the beginning of the pulse, peak is achieved at this timeline, right? This much time is taken for me to reach the peak. Now, I developed aortic stenosis. Let us say it is mild. So then my peak becomes smaller, but peak comes at the regular time. But if I have severe aortic stenosis, I'm ejecting the blood into the aorta very slow. So then my peak becomes smaller and peak comes late. So it is small as well as peak has appeared late. So this kind of pulse is called as pulsus parvus et tardus. Parvus means small. Tardus means slow. So peak is small and peak appears late or appears slowly. It is called as pulsus parvus et tardus. This is something that during bedside discussion, you teachers are very much fond to ask if you have a case of aortic stenosis. They will ask what is pulsus parvus et tardus. So you can say it's a small amplitude, late peaking pulse. Small amplitude, late peaking pulse. Amplitude is small and the peak appears late. Pulsus parvus et tardus. This is encountered in severe aortic stenosis patients. In severe AS patients. Okay, I'll explain again. So basically, when we see, pulse is what? Pulse is a pressure wave that travels through the aorta and its branches. And who is the reason for this pressure wave to appear? It is the left ventricle ejecting the blood. So when left ventricle ejects some amount of blood, let us say I started a systole and from the left ventricle I ejected the blood into the aorta. So suddenly pushing the blood into the aorta triggers a pressure wave. That pressure wave travels along the aorta and its branches, and that is what we are feeling as the pulse. So if I eject more blood, I will have more stronger pressure wave triggered. So I will have more forceful pulse. So when I measure this pulse in terms of pressure, I get a wave somewhat like this. Then it has a peak. The peak depends on the volume of blood ejected into the aorta, and we call that volume as stroke volume. So the peak, how tall the peak is, depends on the stroke volume. In aortic stenosis, stroke volume is less, so peak becomes smaller. Second, after I start the systole, when will I reach this peak? Whether I will take, like, let us say I have taken X amount of time to reach this peak, right? This is the peak. To reach the peak, from the beginning to this peak point, let us say I have taken X amount of time. But if I have severe aortic stenosis, the blood that is coming into the aorta is very slow because the opening is small. So it takes more time for me to reach the peak. So the peak will not appear on the regular time. The peak will become small as such, plus it will appear late. So it has taken now X plus this Y amount of extra time. So the peak now is small and late. That small peak late pulse is what we call as pulsus parvus et tardus. Parvus means, remember, small. Tardus means slow. If you have just completed your second year, you might know that you come across side effects of some antipsychotic drugs called as tardive dyskinesia. Dyskinesia means abnormal movements. Tardive means slow. So those patients have slow abnormal movements. The word tardive or tardus refers to slow. So peak appears very slow and it is also very small. That's the meaning of pulsus parvus et tardus, and that is seen in severe aortic stenosis patients. Okay. So after this, let us also talk about the auscultation findings. We will go to the examination, Nurse Shakib. There we will discuss about the ECG findings as well. Okay. Now on auscultation, we are going to get, I forgot to mention about the apex beat, because this is what routinely we ask in the bedside discussion. What is expected in pulse, what is expected in BP, and what is expected in apex beat. So apex beat generally gets shifted. What is apex beat? Apex beat is the only part of cardiac contraction that can be felt externally. Means if I'm examining an individual, let us say this is a person that I'm examining. This is where his heart is located. Right, this is right ventricle. This side is left ventricle. I have the arch of aorta here. Now right ventricle is contracting, left ventricle is contracting, but I can't see it, right? I can't see it. The only thing that may be visible and felt is the tip of left ventricle. Tip of the left ventricle contracting. That point of maximal impulse which can be seen is called as apex beat. Why is this important? Because when it comes to cardiovascular diseases, it helps us to understand whether there is change in the size of the ventricle. So if left ventricle develops, let us say, eccentric hypertrophy, what will happen to the tip of the left ventricle? It will get displaced, right? The more the muscle mass added outside, the tip will get displaced more, right? So can I say that if I have eccentric LVH, apex beat gets displaced? Yes. And what if I dilate the left ventricle, like in dilated cardiomyopathy? So if left ventricle dilates, apex beat gets displaced. So apex beat with respect to cardiovascular problem gets displaced when there is dilatation of the ventricle or eccentric hypertrophy of the ventricle. But should the tip be displaced if I have concentric hypertrophy, like if I am adding muscle inwards? I'm not adding anything outside. The muscle is added inside only. So will the tip be displaced? No, right? So apex beat in aortic stenosis is not expected to be displaced. So in your bedside discussion, your teachers will ask, I have a patient of aortic stenosis, but apex beat is displaced. What does that indicate? It indicates that in addition to the concentric hypertrophy that is expected in AS, patient might have developed the left ventricular dilatation. Why dilatation can happen? It can happen when AS is combined with AR. So patient may be having AS plus AR. This is the answer that they are expecting. If you say, sir, it is probably LV may be dilated, because I don't expect the apex beat to be displaced in pure isolated aortic stenosis. But if he has aortic stenosis, but indeed he also has displaced apex beat, one possibility is left ventricle may be dilated, and that makes me think of the possibility of presence of an additional aortic regurgitation as well. Okay. So apex speed is expected to be undisplaced because there is concentric hypertrophy, not eccentric hypertrophy. Okay, now comes the main part, auscultation. Of course, it's an valvular heart disease, so we are expecting to hear a murmur. So now, can any of you tell me what kind of murmur are we expecting? And if you are a beginner, second year or third year student, can you tell me what is a murmur? What is a murmur? So normally what happens is, in cardiac cycle, the closure of the valves makes sound. The mitral valve closure, when it closes, and the tricuspid valve closure makes a sound, we call it as S1. And aortic valve closure and pulmonic valve closure makes a sound, we call it as S2. So S1 and S2 are because of the closure of the valves. If the valve is normal, when it opens, it makes no noise. Opening is noiseless if it is normal valve. Okay. Then when blood moves from one chamber to other chamber, the movement is called as a laminar flow. Now, what do I mean by laminar flow? Let us say I'm looking at a pipe and I'm seeing how the particles of a fluid move in that. So if the particles of fluid move smoothly without much collision with other particles, then it is called as laminar flow. So when there is laminar flow, it doesn't create much turbulence, so you don't have much of noise created. You can imagine a river that you see in the summer. Little bit of water is there and it is slowly flowing. When you stand on the bank of the river, you don't get any noise. It's a calm thing, right? Evening, you can, like, in front of that river, you can imagine you are praying to God. Some aarti is being played in the background. Such a serene, calm environment. Because during that time, the flow is laminar. The water particles are not colliding much with each other. That's why there is no noise. But you go to the same river bank during the monsoon season, when there is literally floods everywhere. You will hear the river roaring far away, maybe 100, 200 meters away from the river itself. You start hearing the sound of the water, right? Because during that time, the flow through the river is turbulent. You can see literally waves getting created in the river. So if I make this flow turbulent, then the fluid molecules start colliding with each other, and that is called as turbulent flow. Then turbulent flow produces the sound. So normally movement of blood between chambers of the heart is laminar. So that's why the movement of blood does not make any noise. When I start moving the blood from left atrium to left ventricle, no sound produced. When I eject the blood from left ventricle to aorta, no sound produced, because this movement is laminar. But the moment I make the opening small, the movement is no longer going to be laminar. It becomes turbulent, because the particles that are supposed to exit straight, now they have to make all complex paths to exit this opening. So the movement becomes turbulent, and that turbulent flow of blood makes the noise. And this noise is what we call as murmur. So murmur is the sound produced by turbulent flow of blood. How can I make the flow turbulent? Either make the passage narrow or increase the flow. See, I just gave you an example of a river. During summer, we don't hear the blood, the water flowing through the river, because it is laminar. What changed during the monsoon? The flow increased. So either increase the flow or make the passage narrow. Like on the river, put a dam and have only a small gate. And then you stand on the other side of the dam, and then when water flows, you can clearly hear, because water came laminar, but once the dam is put, the opening is now narrow. After this, there is a turbulent flow. So that turbulent flow, you can hear that roaring sound of water coming from the dam, you can hear, right? Same thing happens in the heart. The normal flow is laminar, but if I increase the flow or make the passage narrow, I start creating the turbulent flow, and that turbulent flow is murmur. So you can understand one thing very clearly, that a murmur in a valvular heart disease is heard in that phase of cardiac cycle during which the blood flows through that valve. So now tell me, the blood flows through aortic valve during systole or diastole? Blood flows through aortic valve during systole or diastole? The basic concept of cardiac cycle is that in the diastole, we fill the ventricle. The ventricle receives the blood in diastole, and in systole, it ejects. So blood is moving between mitral valve and left ventricle during diastole. I fill the blood. Now whatever filled blood, we call it as end diastolic volume. Now I want to eject it during systole. Absolutely right. So the blood moves from left ventricle to aorta during systole, and if the opening is narrow, while moving, it will create the turbulence, and you hear that turbulent flow as murmur. So the murmur is going to be systolic murmur. It's not going to be a diastolic murmur, right? So at least this much you can understand. If I had a mitral stenosis, blood moves during diastole, so I would have had a diastolic murmur. So MS is diastolic murmur, but AS is going to be systolic murmur. The minimum thing you're expected to mention to your teacher is that you're expecting a systolic murmur, but more detailed explanation is expected if you want more marks. Okay. So let me tell you exactly how the murmur sounds like and looks like. Okay. So let us say that this is what I'm representing as cardiac cycle. So let me say this is S1, this is S2. Again, I will have S1 and the cycle continues. So in the cardiac cycle, when we hear externally, between S1 and S2, we have ventricular systole. And between S2 and S1, we have the diastole. So I'm going to hear murmur in this region or in the second region. Of course, systolic murmur means I'm going to hear it in this region, right? Okay. Now let me take you through how exactly we do systole so that you can understand this murmur as well and you will not forget it ever again. So whatever blood I transfer from the left atrium, let us say I had some amount of blood in the left atrium, I transferred it to the ventricle during diastole, and at the end of the diastole, whatever blood I have in my ventricle, this volume we call it as end diastolic volume, right? Normally in a resting condition, it is around 120 to 125 ml. That's normal, but it can vary depending on our status. If I'm doing workout, if I'm stressed, the values change. In a resting condition, it is around 120 ml. Okay. Now this blood is the burden on the heart. More it is, more work heart needs to do. That's why we have called this also as preload. Now I want to eject this blood into the aorta. To eject this, I have to contract the left ventricle because fluid moves from high pressure to low pressure zone. And I want to increase the pressure in the ventricle more than aorta. So if I have to increase the pressure, how can I increase? Boyle's law. What it said, pressure and volume are inversely related. So if I have to increase the pressure, I have to decrease the volume. That is how the contraction of the left ventricle happens. So if I contract the left ventricle, volume decreased. And if volume decreased, pressure increased. Once the pressure increases, the blood moves from left ventricle to aorta, right? And for this contraction, I need an electrical signal, and that will come from SA node. Once the SA node's electrical signal starts traveling through the ventricle, it produces QRS complex. So your QRS complex that you see on the ECG is responsible for this ventricle's contraction, and that contraction is responsible for the movement of blood from left ventricle to aorta, right? That is what is going to happen in the systole. Okay, fair. Now exactly how the cardiac cycle inside the systole is broken is, first, I will have the aortic valve closed. I have blood in the ventricle, we call it as end diastolic volume, and the ventricle starts contracting. Because there is no mechanism to pull and open the aortic valve. The aortic valve has to open because of high pressure in the ventricle. So first I have to elevate the pressure in the ventricle. This pressure pushes and opens the aortic valve. During that period, when the valve was closed but ventricle was contracting, will I hear a murmur? Let us say, if can anybody answer this? So I just filled the ventricle, diastole is over, I have end diastolic volume. Now the responsibility is on me to push this to aorta. So I start contracting because SA node has given me an electrical impulse in the form of QRS, so that is helping me contract. I start contracting. At this point of time, the aortic valve is still closed. For it to open, I have to have high LV pressure, and that will open the gate. So till the valve is open, there is no movement of blood. If there is no movement of blood, is there any turbulence? No. No turbulence means no murmur. And this phase of cardiac cycle where ventricle is contracting to open the aortic valve, we will call that as isovolumetric contraction. So first phase of systole is going to be isovolumetric contraction. During isovolumetric contraction, the aortic valve is not open, so blood is not moving from left ventricle to aorta, so no murmur. Okay, fair. Now at the end of isovolumetric contraction, I have sufficient high left ventricular pressure, and that pressure makes the aortic valve open. Normally only closure makes a sound, opening does not make the sound. But this time this valve is calcified, stiff. While opening, it may make a sound. I have to give a name to it. So can anybody tell me what name I should give to it? If a valve which is stenosed, while opening it makes a sound. So just imagine a door. Normally when you close the door, shut the door, it makes a noise, right? Thud you hear. If the valve or the door is not tight, opening does not make much noise. Same applies to aortic valve or all the valves as such. Normally only closure makes a noise, but if it is stenosed or stiff or tight, while opening also it makes a noise. Like your regular door, while opening, if it is tight, it makes chirr noise. Exactly, that's what is happening with the aortic valve as well. While opening, it is making a noise now because it is stiff and stenosed. It's not usual flexible valve. That sound we will call it as click. So you might have heard about this ejection click. So after the isovolumetric contraction, the opening of the aortic valve makes a noise, and I'm going to call this noise as the click. Sutapa and Kalyan, very good. So this noise that I'm going to hear here will be called as a click, or you can also call it as an ejection click, because after this the valve is open now and the blood starts moving. The blood starts moving from left ventricle to aorta now. Okay. Now again remember the mitral stenosis. If I have mitral stenosis, there also opening of the valve may make a sound if it is stiff. That sound we will call it as snap or opening snap. Here we are going to call it as ejection click or simply click. Why that is called snap and this is called click? So remember, in systole the pressures in the chambers is quite high. So the noise that I hear when the aortic valve opens is loud. But in the diastole the pressures are low. So the noise that opening makes is low. So it is comparable to, this is what we call, chutki is snap. Click is what we make from the throat. That is click. So this is more loud, right? So systolic sounds of the valves that open in systole, if they are making a noise, they make much loud noise. So we will compare it to click. But the diastolic opening valves, when they open in diastole, they make less noise. So we'll call it as snap. Snap is not as loud as click. Okay. So I heard a click. After that, the blood started moving from left ventricle to aorta. Now I will start hearing the murmur. Now the murmur intensity also is not going to remain same throughout the systole. The intensity first increases and then decreases, because when we eject the blood, we have two phases of ejection. First one is called as rapid ejection and then delayed or slow ejection. So in rapid ejection, the movement of blood from left ventricle to aorta is with increasing velocity. During slow ejection, the velocity goes on decreasing. So more the velocity, more the turbulence, more the turbulence, more the intensity of the murmur. Decreasing velocity means decreasing turbulence, decreasing intensity of the murmur. So during rapid ejection, the murmur intensity goes on increasing. It goes on increasing, and then during delayed or slow ejection, the murmur velocity goes on decreasing. So it creates a murmur which is kind of diamond shaped, right? So first phase was rapid ejection where the murmur intensity was increasing, and then delayed or slow ejection where it was decreasing. So this is the murmur that we are going to hear. So if you have a patient or if you encounter a patient anytime in near future in your hospital, pay attention, listen to the murmur closely, and you will be able to identify that the murmur starts becoming a little louder and then the loudness starts dropping. So it has a peak and then the peak starts receding. Now tell me, what kind of systolic murmur is it? Should I call it as pan-systolic murmur? When I say pan, it means it is running throughout the systole, from this end of systole to that end, means from S1 all the way to S2. Then you can call it as pan. Is it running from S1 all the way to S2? No. Can I call it as early systolic? It is not heard in the early part of the systole, right? So then what should I call it as? If it was only heard in the slow ejection part, maybe I would have called it as late systolic. I can't call it either. So either I have to call, because it's somewhere in the middle of the systole it is starting, either I have to call it as mid systolic, or more technical term is we can call it as ejection systolic. Why am I calling it as ejection systolic? Because the murmur is heard throughout ejection, because ejection is where the blood is moving, right? In the ejection, the blood is moving. In isovolumetric contraction, the valve was closed, blood was not moving. First rapid ejection after isovolumetric contraction, then slow ejection. So in rapid ejection, murmur intensity increase, slow ejection decrease. So I heard the murmur throughout ejection. That's why we can also call it as ejection systolic murmur. Now in the murmur, the teachers expect you to give a description of this increasing intensity and decreasing intensity. The technical term would be crescendo, decrescendo. So what you should write is, you get a murmur. Please write this picture that gives a very clear idea to the examiner that you know about the murmur, and then mention you get this ejection systolic. If you want, you can also write it as mid systolic. Ejection systolic, crescendo, decrescendo murmur. So it is systolic but not pan, ejection, and its intensity goes on increasing and decreasing. Ejection systolic, crescendo, decrescendo murmur. In the theory exam, you don't have to write best heard in, but in a practical, they will ask where you will hear the aortic stenosis murmur best. So you know that for every valve, there is a representative area where the murmur is best heard. So can anybody tell me where is the aortic area situated on the chest? And it's not wrong, if you have time, do put a small picture or image to represent the area of auscultation for the aortic valve. Where is the aortic area situated? Yes, the aortic area is situated in the right second intercostal space. So if this is right, this is left. So on the right second intercostal space, cardiopulmonary, very good. So on the right second intercostal space, we have the aortic area. So some of you may be wondering, so why is it on the right? Why is it? The valve is of the left side of the heart, right? Aortic valve is between left ventricle and aorta, but why its area is on the right? So please remember, when I create the sound, because of the turbulence, the sound travels in the direction of jet of blood. So if this is where my heart is situated, this is my left ventricle, okay, and this is the aorta that is coming out from it, and this is where the aortic valve is. So the direction of jet of blood is towards right. So when I eject the blood from left ventricle to aorta, the direction is towards right. So the sound propagates more towards the right. So that's why right second intercostal space is the aortic area. The pulmonic area is on the left. The pulmonic valve is on the right side of the heart, but the direction of jet of blood is towards left. So that's why the pulmonic area is in the left second intercostal space. So best heard in right second intercostal space, right second intercostal space. Another thing you have to mention is whether the murmur is best heard in inspiration or expiration. That's a very, very important point that they will ask in your case presentation. So again, a simple rule, we just learned that murmur is the sound produced by turbulent flow of blood. More the flow, more the turbulence, more is the intensity of the murmur, or more is the loudness of the murmur. It's as simple as that. Now in heart's cardiac cycle, the right side of the heart receives more blood during inspiration and left side of the heart receives more blood during expiration. Now you may ask why. Ideally, both the sides of the heart should get equal amount of blood, but then things change because of respiration. How do I do respiration? Even our respiration is related to Boyle's law. Like, whole physiology is based on physics. If you have understood physics very well, then the medicine starts becoming quite easy. How do I breathe? It's all based on the two laws that we discussed yesterday also. Fluid and air moves from high pressure to low pressure zone. In the atmosphere, there is air. I want this air to go into my lungs. Can I increase the atmospheric pressure? No. God has not given me the control, right? So all I can do is I can decrease the pressure in my lungs lower than that of the atmosphere. If I do that, then the air from the atmosphere, because now atmospheric pressure is higher than the lungs, so air from the atmosphere will come into my lungs. But how will I decrease the pressure in the lungs? I will apply the Boyle's law. I will increase the whole thorax volume. If I increase the volume of the thorax, the pressure inside the thorax decreased. So all the structures inside the thorax, pressure in them will also decrease. Means inside the lung, the pressure will decrease. And because of that, the air from the atmosphere will come into the lungs. Right? Now, how will I do expiration? The pressure in the lungs has to be more than the atmospheric pressure. So whatever lungs that had expanded during inspiration will recoil. If the lungs recoil, the volume of the lungs decreased. Volume decrease means pressure increased. So once the pressure in the lungs becomes more than atmospheric pressure, the air will leave the lungs and go to the atmosphere. That is our expiration. Right? As simple as that. But because I decrease the pressure in the whole thorax, not just the lungs during inspiration, the pressure in the right side of the heart will also get decreased. And because of that, the blood from inferior and superior vena cava will get into the right side of the heart more easily. Like if the whole thorax pressure is negative, more blood will flow into the right atrium through the veins. So that's why increase in the right sided blood flow happens during inspiration. Okay. Now this extra blood that came to the right side of the heart will pass the lungs and reach the left side of the heart during expiration. So left side of the heart gets more blood during expiration and the right side of the heart gets more blood during inspiration. So that's why if I had pulmonary stenosis or tricuspid stenosis or any of the right valvular pathologies, the flow is more during inspiration. So murmurs of right side of the heart will be heard better during inspiration. But murmurs of the left side of the heart, because left side of the heart gets that extra blood during expiration, they will be heard better in expiration. So this you can write for all left-sided conditions. Means mitral stenosis, mitral regurgitation, aortic stenosis, aortic regurgitation, murmur is best heard in expiration. Pulmonic stenosis, pulmonic regurgitation, tricuspid stenosis, tricuspid regurgitation, murmur is best heard in inspiration. So here we should write, because it is a left-sided heart pathology, we will be writing best heard in right second intercostal space with patient's breath held in inspiration. Sorry, breath held in expiration. Breath held in expiration. Okay. Bolt, I will talk about the pulses paradoxes as well. Okay. Breath held in expiration. Now, one last thing that bedside discussion, the teachers might expect you during the bedside discussion is what should be the position of the patient for you to be able to hear the murmur. In the theory paper, of course, they are not going to expect all this. As long as you mention that it is a ejection, systolic, crescendo, decrescendo murmur, they are going to give you the marks and move forward. But in the bedside discussion, they are very judgmental because you are right in front of them. They are asking you more. What should be the position? So while auscultating, bringing the valve closer to the stethoscope makes it more easier for us to hear the murmur. So aortic valve, that area, how can I bring it closer to the stethoscope? By asking the patient sitting and leaning forward. You can apply this to both pulmonic as well as aortic valve. Patient sitting and leaning forward brings the valve closer to the auscultating stethoscope and makes the murmur more clearly audible. But for mitral valve, mitral area is in the apex, the tip of the left ventricle that we say, that location is called as apex. Mitral area is apex. So there I have to turn the patient to left lateral decubitus and then I will be able to hear the murmur better. Why is this important? Because in the bedside discussion, if the teacher asks you, show me how do you auscultate for aortic stenosis murmur, he is not expecting you to identify the murmur. As an undergraduate student, you're not expected to be able to recognize a murmur. If you recognize, that's a brownie point, but you're not expected to. What as an examiner I'm assessing is whether you know the methods correctly. So if I tell you to auscultate an aortic stenosis murmur and the patient is lying on the bed and you just put a stethoscope, I know that you don't know anything about auscultation. And that will be a negative mark for you. But if you ask the patient to sit, lean forward, ask him to take a breath and then exhale and then hold the breath and then you place the stethoscope, I know the methods are right. Whether you recognize the murmur or not, just let me check the speed. Okay, I think some of you might be facing the internet issue, but my speed shows good. Okay, so I'm getting a quite good speed of 300 Mbps. So at that speed, it should not be lacking from my end. Either the server issue or your device may be having an issue. Okay, fair. So I was telling you about, okay, good. So we were discussing about this murmur, and I think Sutapa had asked why breath we should be examining in expiration for the left side of the heart. So left side of the heart gets more blood supply during expiration, right during inspiration. So that's why if it is a right heart valve pathology, pulmonary valve or tricuspid valve, you better hear it in inspiration. If it is left, you better hear it in expiration. Okay, so now that the examination findings are completed, this is what you're expected to mention. Now we will talk about diagnosis. The diagnosis of all valvular heart disease for your practical as well as theory exam is pretty simple. All you have to do is investigation of choice. Clinically, it's based on symptoms and auscultation findings, but for confirmed diagnosis, we have to go for investigation, and investigation of choice is echocardiography, two-dimensional echocardiography. You can write it as 2D echo or echocardiography. But apart from that, if you want to write, you can mention what findings you are going to get on ECG in a patient with investigation of choice is echo. ECG alone is not enough for the diagnosis of aortic stenosis. But if I have done it, what am I going to expect? Because patients may present with angina. I don't know if it is MI or aortic stenosis. So I will do an ECG. If it is MI, ECG will show. If not, what findings I will get in aortic stenosis? We just learned in pathophysiology that there is left ventricular hypertrophy, and left ventricular hypertrophy can be recognized on the ECG. So LVH may be visible on the ECG. Nothing more we can probably see on the ECG, but we can see left ventricular hypertrophy. Okay, now if you have already watched my ECG series, you know how to recognize left ventricular hypertrophy. We follow a criteria which is called as Sokolov-Lyon criteria. You don't have to write it in your prop paper, but just for a quick recap, which basically is a simple mathematical formula. We are looking at the amplitude of S wave in V1, how many small squares the S wave takes in. Like if you look at the QRS complex, right, you have an S wave and you have a R wave. So we are looking at the depth of S wave in V1 and the height of R wave in V5 or V6. S in V1 plus R in V5 or V6. If it is more than 35 small squares, it indicates that you have left ventricular hypertrophy. You have left ventricular hypertrophy. Okay. Now in echo, 2 points I want you to write. If the opening is less than 2.6 centimeter square, normal I have already told you it is 3 to 4 centimeter square, we will call it as aortic stenosis. And if the opening is less than 1 centimeter square, we will call it as severe aortic stenosis. We will call it as severe aortic stenosis. Okay. Now the diagnosis is done. How am I going to treat this patient? I have a patient with aortic stenosis. He presented with angina, syncope, dyspnea as symptoms. On examination, I got this pulsus parvus et tardus. I have this ejection systolic, crescendo, decrescendo murmur with a ejection click to start with. I got an echo done and it showed that the orifice is narrow, confirmed that there is aortic stenosis. Now how am I going to manage? So when it comes to the management of any valvular heart diseases, you have to discuss it under two headings. First one is there any conservative way of managing this without doing any surgery or valve replacement? Second is definitive treatment. For all valvular heart diseases, the definitive treatment is going to be valve replacement. Okay, aortic valve opening is narrow, it's not opening completely, take it out, put a fresh valve which opens completely. It's as simple as that. But can I do something to avoid this surgery is the question. Okay, so if they ask what is the definitive treatment, the definitive treatment is simple. That is going to be aortic valve replacement. But is there any role of pharmacotherapy? Normally, like giving drugs like beta blockers or nitrates, is that useful for a patient with aortic stenosis? Well, so please remember, So Tapasamanta, the coronaries receive the blood from aorta itself, right? And in aortic stenosis, because the opening is narrow, I am ejecting the less amount of blood into the aorta. This opening is deciding how much blood I can eject. It's small, so less amount of blood comes to aorta. From the aorta, coronaries are originating. So if less amount of blood comes to aorta, less amount of blood comes to coronary arteries. Simple. So already, because of low stroke volume, less amount of blood is coming to coronaries. Second, concentric hypertrophy that we developed has increased the oxygen demand. So one side I want more oxygen, other side I can't give it, and that's why I'm getting this angina. Okay. So as such, in aortic stenosis, there is no role of pharmacotherapy. You can't manage any of these patient symptoms with drugs or diuretics. Why? Because if I give diuretics, it will reduce the congestion that I had in the lungs. So dyspnea will improve, but diuretics will also mean that end diastolic volume will decrease, stroke volume will decrease, right? So it will worsen the symptoms related to low stroke volume, that is angina and syncope. If I give beta blockers reduce the force of contraction of the heart. So it will again decrease the stroke volume. So there is no role of pharmacotherapy per se. The only definitive management is aortic valve replacement. So the point to note is we should avoid giving beta blockers and diuretics to a patient due to decrease in stroke volume, because both of them decrease stroke volume. I already have low stroke volume, so it can worsen the problem. So there is no role per se, right? The only thing I can do for these patients is definitive treatment, which is aortic valve replacement. There are refined indications when we should consider aortic valve replacement. At the prof exam or practical exam level, it's not required. Once you start preparing for the NEET PG, we will discuss those indications, how to remember that. We will have a flowchart. For now, just mention the definitive treatment is aortic valve replacement. The question is, the most common cause for aortic stenosis is age-related degeneration. So most of your patients are in their 70s or 80s, not very fit for the open heart surgery for valve replacement. No cardiac surgeon would love to do those cases because it is risky. So if the patient, and most of the times in your 70s or 80s, you have multiple other diseases. You're diabetic, you're hypertensive, you also have coronary artery disease, you have dyslipidemia, you have multiple other problems. You may not become very fit for an open heart surgery. So for those patients, what is the alternative I can offer? For patients deemed unfit for surgery of the murmur, I should mention the area and the best heard position, inspiration or expiration. Then management for all valvular heart disease, you are going to mention definitive treatment as aortic, as the valve replacement, mitral stenosis, mitral regurgitation, pulmonic stenosis, pulmonary regurgitation. Definitive is always valve replacement. For some valvular heart diseases, there may be a role of conservative management of pharmacotherapy. For some, it is not. For aortic stenosis, there is no. Other valves, I will tell you. So if you remember that, you can follow the same template and you can answer all the valvular heart disease questions. Even if it comes instead of aortic stenosis, it comes to pulmonic stenosis, you can write the same template there. Okay. So let us take the example of mitral stenosis as well. So the snap refers to the sound produced by the valves that open in diastole. As I've already told you, normally when valves open, they don't make any noise. Only stenosed valve, when there is stenosis while opening, they make a noise. That noise, either I will call it as click or snap. The valves that open in systole, if they make a noise, we will call it as click because it is much louder. And the valves that open in diastole, if they make a noise while opening, we call it as snap. So mitral valve and tricuspid valve open during diastole because blood moves from atria to ventricle during diastole. So when they are opening, if they make a noise, it is snap. Mitral stenosis, we will have snap. Tricuspid stenosis, we will have snap. But aortic valve and pulmonic valve open in systole because blood moves from ventricles to the arteries during systole. So while opening, if these valves make noise, that is AS or PS, we will call that noise as click. Okay. So Atul, eventually, because as the stroke volume decreases, the more and more blood is left behind in the ventricle. So eventually you will have increase in the preload, not to start with. To start with, you have increased afterload because of the narrow aortic valve opening. Because see, diuretics will make you excrete more urine. So the circulating blood volume decreases. So the amount of blood reaching the heart also comes down. Instead of 5 liter, my circulating blood volume became 4 liter because 1 liter I excreted in urine. So now if circulating blood volume is 4 liter, the amount of blood reaching the heart is less. So if the amount of blood reaching the heart is less, the heart will eject less. Already it is ejecting less because of narrow opening. Now it will eject further less because the amount of blood reaching the heart is less. So stroke volume further decreases if I give diuretics. A normal person can tolerate the diuretics, but not a patient of aortic stenosis because their stroke volume is already low. Further low stroke volume means it will complicate the syncope and angina symptoms. That's why we avoid beta blockers. Same story. Beta blockers reduce the force of contraction of the heart. So less the force of contraction, less is the stroke volume, and thus you will have again decrease in the stroke volume. Okay. Now we will talk about the mitral stenosis as well. So if I have to talk about mitral stenosis, we will begin with the mitral valve. Few points about mitral valve. And as you know, the mitral valve is the valve that is guarding the left ventricle and left atria. It is between left ventricle and left atria. So if this is my left atrium, this is left ventricle, this valve is the mitral valve. Its job is to allow the movement of blood from left atrium to left ventricle when during diastole, because I fill the ventricle during diastole, I eject from the ventricle during systole. So mitral valve opens in diastole so that blood moves from LA to LV. It remains closed in systole so that the blood does not move back. Okay. So mitral valve, just like the aortic valve, this will also have a connective tissue ring. And that connective tissue ring, we always call it as annulus. It is called as annulus. But my aortic valve had 3 cusps. But mitral valve has only 2 cusps. 2 cusps. Aortic valve was tricuspid. The mitral valve has only 2 cusps. You can call one of them as anterior mitral leaflet, the other one as posterior mitral leaflet. Only 2 leaflets or 2 cusps. But then mitral valve has an additional structure. What is that? Mitral valve has papillary muscles and chordae tendineae. Our aortic valve does not have them. But mitral valve has papillary muscles and chordae tendineae. So these structures, we will call them as papillary muscles. And these structures, these tendinous structures, we will call them as chordae tendineae, or in simple words, chordae. Aortic valve did not have it, but mitral has it. Why mitral requires it? Why not aortic? So you have to remember that in the cardiac cycle, the highest pressure phase is systole. Systole is where ventricle is contracting. Ventricle is strong and muscular. So it generates a lot of force. The intraventricular pressure in systole goes as high as 140 millimeters of mercury. Right? Okay. So during that time, the mitral valve is supposed to be closed and aortic valve is supposed to be open. So aortic valve need not stay closed in systole. It has to open. But mitral valve has to stay closed in the systole. It is supposed to open in diastole. And to make sure that it remains closed and does not open in the opposite direction because of high intraventricular pressure, we need these papillary muscles and chordae tendineae. So you can imagine this papillary muscle and chordae tendineae as the ropes tied to boats on the sea beaches or the river banks. Why ropes are tied? Not to pull, mainly to prevent so that the boats don't flow away. Right. So similarly, I don't want these mitral valve leaflets to open in the opposite direction during systole. So to hold them in position, nature has given us papillary muscles and chordae tendineae. So it has a connective tissue ring, 2 cusps, 2 sets of papillary muscles and chordae tendineae. This is the structure of our mitral valve. Now this mitral valve, its normal open orifice, when it opens, the open orifice is 4 to 6 centimeters square. The aortic valve was 3 to 4 centimeters square. This is 4 to 6 centimeters square. And when it is less than 4 centimeters square, we will call it as mitral stenosis. And when it is less than 1 centimeter square, traditionally it is called as severe mitral stenosis. But I also want you to be aware, you need not write it, but I want you to be aware that in Harrison, he mentions less than 1.5 centimeter square as severe mitral stenosis in the current edition. So there are logics and reasons behind that. At a UG level, you don't have to really bother, because generally mitral valve replacement or a procedure is considered when the orifice is less than 1.5 centimeter square. So that's why he labels it as severe. The traditional older textbooks mention 1 centimeter square as severe. So what your professor is going to think of as severe, I don't know. So you can go by the traditional answer, says sir, less than 1 centimeter square is considered as severe. He says no. Do you know about the latest update? Then you can say, sir, yes, current edition of Harrison says less than 1.5 centimeter square is considered as severe. So that you can handle the situation diplomatically without offending your teachers in the bedside. Okay, so this is about the mitral valve. Right now, let us talk about the mitral stenosis. The notes will be available on the Telegram as soon as the class is over. So we'll begin with the causes. So when it comes to causes, I want you to remember only one cause. I know there are n number of causes possible, but they're extremely rare. So in your theory exam, I just want you to mention the most common cause, that is going to be rheumatic heart disease. RHD is the most common cause for mitral stenosis. And in every probability, your practical case discussion will be centered around mitral stenosis only. If not, then aortic stenosis, if it is about valvular heart disease, because these are the two cases which your teachers can grab. They may be able to find some cases. The other, like pulmonary stenosis, pulmonary regurgitation, tricuspid stenosis, they're exceedingly rare. They're very difficult to find. So most likely you will not get those cases in your practical. If you're getting a valvular heart disease, it is either going to be mitral stenosis, because in India, rheumatic heart disease is still very common, though it is less from my days till now, but it's still very common. Or the second, aging. The population is aging and you may be able to find some aortic stenosis patients. Okay. The other causes, if you want to remember or mention, I want you to mention one, left atrial myxoma. What is this left atrial myxoma? There may be a tumor in the left atrium which may come and block the mitral valve opening and create a stenosis like picture. We will call it as a left atrial myxoma. So these are the two things, RHD and left atrial myxoma. Now, what symptoms it will lead to? To understand that, we have to understand the pathophysiology. So if I develop mitral stenosis, what all problems I'm going to face? Now let us say this is my left atrium. Its opening has become very narrow. And once its opening becomes narrow, will I be able to transfer the normal amount of blood that I transfer from left atrium to left ventricle? Opening becomes a deciding factor, right? If I have small opening, I can transfer only less amount of blood. If the opening was fully normal, completely open, I could transfer more amount of blood. Because of the narrow opening, the filling of the left ventricle during diastole decreases. So if the filling of the left ventricle during diastole decreases, I have less blood in the left ventricle at the end of the diastole. And what is that volume called as? End diastolic volume. So mitral stenosis leads to decrease in the end diastolic volume, because I could fill only less quantity of blood. And if the end diastolic volume is less, I already have less blood in the ventricle. And when I eject this blood into the aorta, I had less, I will eject less. So what will happen to the stroke volume? By default, whenever end diastolic volume decreases, we will have decrease in the stroke volume. Okay, can anybody tell me what is the relationship between end diastolic volume and stroke volume? Normally, not talking about mitral stenosis, but normally, what is the relationship? So Tapa, very good. So do you think all the amount that is there in the ventricle at the end of diastole gets ejected as stroke volume? No. So normally, in the ventricle at the end of diastole, we will have around 120 to 125 ml of blood. That is my end diastolic volume. But what is the usual resting stroke volume? We expect around 70 ml. Means some percentage of end diastolic volume gets ejected as stroke volume, and the remaining blood stays in the ventricle. It becomes part of the next diastole, and that blood that stays in the ventricle, we call it as end systolic volume. That is around 50 ml. That means I had 120 ml at the end of diastole, 70 I pushed out, 50 stayed. Systole is over. Now in the next diastole, again I receive 70 ml. It makes it 120. Out of that 120, again I eject 70, 50 stays back. So ventricle always have some amount of blood. It never becomes completely empty. Okay. So this is end systolic volume, this is stroke volume, this is end diastolic volume. Now if I express it in terms of percentage, how much percentage of end diastolic volume got ejected as stroke volume? We call that as ejection fraction. So ejection fraction is nothing but the percentage of end diastolic volume ejected as stroke volume. If I eject 50% of end diastolic volume as stroke volume, then ejection fraction is 50%. So in that case, like 120 ml was my end diastolic volume. I ejected 60 ml as stroke volume. How much percentage I ejected? Half, 50%. Then my ejection fraction is 50%, right? So this is the concept of ejection fraction. Percentage of end diastolic volume ejected as stroke volume is called as ejection fraction. Normally it is 60 to 70%. Now in mitral stenosis, what happened? My end diastolic volume itself is decreased. Instead of 120 ml, let us say it has become 80 ml. Because my mitral valve opening was narrow, it did not allow me to transfer good amount of blood. So I have only 80 ml as my end diastolic volume. So out of that, my normal ejection fraction is 60%. So I will eject 60% of it as stroke volume. 60% of 80 will be 6 into 8. So that will be 48. So 48 ml becomes my stroke volume. If I had same ejection fraction of 60%, but normal end diastolic volume, I would have got a stroke volume of 70. So now what happened? Because of decreased end diastolic volume, my stroke volume also decreased. So in aortic stenosis, the stroke volume was decreased because of the increased afterflow or the narrowing of the aortic valve opening. Here, aortic valve opening is fine, no increase in the resistance, but because I had less to start with. It's like in aortic stenosis, you have the money, but your dad is not allowing you to spend. In mitral stenosis, your dad is not stopping you from spending, but you're not able to spend because you don't have the money. You have less money, right? So I ended up with decreased stroke volume. And what symptoms I will get if I have decreased stroke volume? The decreased stroke volume will result in fatigue and syncope, right? The same symptom that we have already written. Fatigue and syncope. So syncope will come even in mitral stenosis patients. Okay. The next problem is what is going to happen to the left atrium. The opening is narrow. So to push the blood through this narrow opening, left atrium starts struggling, right? It has to do more work. So if it does more work, its muscle mass starts increasing. So it develops left atrial hypertrophy. So therefore I will repeat about ejection fraction one more time after I complete the discussion. Okay. So you will develop left atrial hypertrophy. Okay. What will happen to the pressure inside the left atrium? See, I have a bottle, I'm squeezing it, but the opening of the bottle is small. So inside of the bottle, pressure will increase, right? So let us say I have this bottle, I'm squeezing it, but opening is narrow. So pressure inside will increase. Now the nature does not want the pressure in this bottle to increase. So then what nature should do? If the opening is narrow, there is increase in left atrial pressure. But the nature doesn't want you to increase the pressure. So what should the nature do? So mitral stenosis leads to increase in left atrial pressure. Only one solution is there, Boyle's law. What Boyle's law says, if you want to bring down the pressure, you have to increase the volume. So to compensate for this increasing pressure, to make sure that it does not affect the heart, the left atrium dilates. So increasing left atrial pressure results in one left atrial dilatation. This is also called as compensatory dilatation because it is trying to compensate for the increasing pressure. Why should it compensate? The answer is simple. If left atrial pressure increases, then we know that pulmonary vein pressure has to increase. Then only blood will come from pulmonary vein to left atrium. So the left atrium does not want to burden the pulmonary veins. Pulmonary veins pressure should not increase. So then it dilates. As long as it can dilate, it keeps dilating so that the left atrial pressure remains low, so that the blood easily flows from pulmonary veins to left atrium. But there is a limit to dilatation. Left atrium is not going to become miles long. So once its limit of dilatation is reached, then pressure will start rising again. Once pressure starts rising, then the pulmonary vein pressure will have to rise. Pulmonary vein also does not want to burden the pulmonary capillaries. So what it should do? It will also dilate. As long as it can dilate, it will keep dilating so that the pressure is maintained. But once its limit is reached, it failed, then the pulmonary capillary pressure starts rising. The pulmonary capillaries also don't want to bother the pulmonary artery behind, so they will also dilate. When they dilate, they hold more blood, that is pulmonary congestion. We will have dyspnea. So whenever I start in the left heart, I end up in the lungs and I will have dyspnea. So dyspnea is going to be a standard symptom that you can write for all left heart diseases. But once the limit of pulmonary capillary dilatation is reached, it can't dilate anymore. Pressure will start rising. Now the pulmonary artery pressure has to go above the pulmonary capillary. And once the pulmonary artery pressure increases, we call it as pulmonary hypertension. If you remember from the yesterday lecture, the most common cause for pulmonary hypertension is left heart disease. And this is one classical example. So problem that started here will eventually end in the pulmonary artery. Eventually right heart will also fail. Right? So we can write this down. So compensatory left atrial dilatation, eventually that will lead to pulmonary congestion because the pressure keeps rising till it reaches the pulmonary capillaries. And from the pulmonary congestion, I will expect development of dyspnea. And pulmonary congestion will also lead to increase in the pulmonary artery pressure one day, and that will result in pulmonary hypertension. Pulmonary hypertension. Okay. Now, dyspnea is one symptom. What pulmonary hypertension will lead to? Pulmonary hypertension we have studied as a question yesterday. Mean pulmonary artery pressure more than or equal to 20 millimeters of mercury. The most common cause is left heart disease. Second most common cause is lung disease. That's what we call as car pulmonale. COPD and ILDs can cause. If left heart and lungs are not affected, you still have pulmonary hypertension, then it is called as pulmonary arterial hypertension or PAH. Okay. So what examination findings this pulmonary hypertension can lead to? It can lead to loud P2 and right parasternal, because pulmonary hypertension will lead to right ventricular hypertrophy, and that will lead to right parasternal heave or lift. Now why am I talking about this here? Because in the bedside discussion, if it is a mitral stenosis case, your teachers will ask, how will you get to know whether a mitral stenosis patient has developed pulmonary hypertension or not? You can say, sir, I will have loud palpable P2. This answer pleases your examiners, and generally they will move forward, right? So I want you to remember this point because they do ask. Okay, you say this is a case of MS. I want to know whether he has developed pulmonary hypertension or not. What is the gold standard investigation? Right heart catheterization. But your teacher says, I don't want to do right heart catheterization. Patient can't afford. Patient is not giving consent. Can you clinically identify whether he has got pulmonary hypertension or not? And you can say, sir, if loud P2 is there, I can be sure that he has got pulmonary hypertension. Okay, this is the answer that they are expecting. Now, one more thing that this left atrial dilatation leads to. This large left atrium, right? It may compress the left recurrent laryngeal nerve. So if you think back about anatomy, the left recurrent laryngeal nerve comes down, arches around the arch of aorta, and then goes up to the larynx. And because it has a close relationship with the aorta and the heart, this enlarged left atrium may compress it. And when it compresses it, its function is disturbed, and its function is vocal cord movement. So you end up with hoarseness of voice. And what is this manifestation called as? This will result in compression of left recurrent laryngeal nerve, right? This will result in, I will address that. and this manifestation is called as Ortner's syndrome. Okay, so imagine pulmonary hypertension means your pulmonary artery pressure is high, right? So imagine that you're closing a door. You're closing a door of a room in which pressure is already high. Like you might have imagined in seen in movies and all, some blast happens and all that blast particles are coming, and in this one particular place the hero and heroine are there and they want to shut that door. So pulmonary hypertension means pulmonary artery pressure is high, and this pulmonary valve is nothing but that door of that room. So when I shut a door against a high pressure chamber, it makes a louder noise. So indirectly, whenever you have pulmonary hypertension, your P2 becomes loud. In systemic hypertension, you can have the aortic valve closure also little louder. The A2 can become loud. Okay. So we call this hoarseness of voice as Ortner's syndrome. Okay. So your examiners are expecting you to talk about dyspnea, talk about syncope, and they may ask, what do you suspect if a patient of mitral stenosis develops hoarse voice? You can say, sir, probably left atrial enlargement has compressed the left recurrent laryngeal nerve, right? Sometimes they try to confuse you saying left recurrent laryngeal nerve or right. Be assured it is left. Right has no proximity to the heart. Okay. So from the pathophysiology, we have an idea what symptoms to expect, right? Now, let us talk about its diagnosis and management. So Tapasamanta, yes, you can hear that loud P2 through auscultation. Again, all these loud noises that we're talking about, soft S1, loud S1 and all. So please remember, they are appreciable only when you have heard hundreds of normal P2 and normal A2, normal S1. So make sure that every time you have a stethoscope and a patient in front of you, auscultate. Whether you find something or not, keep auscultating. That trains your ears and brain to pick up the normal. And next time when you hit a loud S1, loud S2 or loud P2, loud A2, soft S1, you will be able to recognize that it is not sounding normal, it is little different. Okay. We did not write about the clinical features, right? So let me first write about the clinical features and then we will talk about the diagnosis. As I've already told you, for all valvular heart diseases, you should focus on the BP, pulse, apex beat, and auscultation. Here stroke volume is less, so the pulse amplitude will be low. So you will have a low amplitude pulse, which you can also call it as pulsus parvus, or common terminology, the feeble pulse. The BP is expected to be low because of the low stroke volume, but it gets countered by RAS, so you're expecting it to be normal. Now, can anybody tell me what will happen to the apex beat? Will it be displaced or will it be found in the normal position? Med student, a very good question. Aortic stenosis can also cause pulmonary hypertension, right? Yesterday when we discussed about pulmonary hypertension, we said left heart disease, and we have mentioned it categorically that when we say left heart disease, it includes aortic stenosis as well. The reason I am talking more particularly about it in mitral stenosis is the chances of mitral stenosis causing pulmonary hypertension is much high than the chances of aortic stenosis causing pulmonary hypertension. The reason is pretty simple. See, further away the pulmonary artery is from a pathology, the involvement will become late. Like if I have developed aortic stenosis, first pressure in the left ventricle will increase, then pressure in left atria will increase, then pulmonary vein, then pulmonary capillary, then it will reach pulmonary artery. But if mitral stenosis, this chamber is eliminated from the circuit. So immediately left atrial pressure increases, then pulmonary vein, then pulmonary capillary. I will reach the pulmonary artery much earlier. So that's why chances of mitral stenosis causing pulmonary hypertension is much higher than aortic stenosis. It does not mean aortic stenosis will not cause. It can cause. Any left heart disease, aortic stenosis, aortic regurgitation, mitral stenosis, mitral regurgitation, all of them can cause pulmonary hypertension. This usually comes in the discussion of mitral cases because that is where we very often see it. Okay. The atrial hypertrophy does not cause the displacement of apex because apex is nothing but the tip of left ventricle. So if atria enlarges, the left ventricle won't get displaced. Left ventricle will stay there only. Only when left ventricle enlarges because of dilation or eccentric hypertrophy, we will have displacement in the apex beat. And because here we don't have that happening, left ventricle's work is not increased. In fact, by filling less into the left ventricle's work is reduced. So that's why we are not expecting it to be displaced. Apex beat is undisplaced because there is no eccentric LVH or dilatation. Okay. Now talking about its auscultation, I'm going to get a murmur, and by now I hope you have a clarity that we're expecting a diastolic murmur because the blood moves from left atrium to left ventricle during diastole. Through this mitral valve, the movement of blood happens during diastole, and if this opening is narrow, I will create a turbulence and I will hear a murmur. So I'm going to get a diastolic murmur. Zubi, that's a very good question. We will discuss about it in the complications. The rhythm need not always be affected. I will talk about it in the complications. So then whatever murmur I'm going to hear between S2 and S1 because S1 and S2 is systole, and a mitral stenosis murmur is going to be diastolic murmur. So I'm going to expect a murmur in the diastole. Okay. Now to understand, Dr. Is Ahmed, very good. So to understand this murmur, I want you to have a fair idea about the cardiac cycle with respect to diastole. So what do we do in diastole? In diastole, I transfer the blood from atria to ventricle, and the physics applies here also. Blood moves from high pressure to low pressure zone. So if the blood has to come from left atrium to left ventricle, then either left ventricular pressure should be lower than left atrial or left atrial should be higher than left ventricle. Okay. So then how do I change this pressure? Because when left ventricle was in systole, it was contracting. So at the end of systole, left ventricular pressure was very high. Left atrium cannot increase its pressure above that of ventricle because ventricle is strong muscular, atria is a thin sheet of muscle. Atria can never contract to build a pressure higher than the ventricular systolic pressure. So the responsibility is on the ventricle. Ventricle has to lower its pressure so that it can receive the blood from atria. So in systole it contracted, ejected, that ejected blood is stroke volume. Now I'm going to start the diastole. So before I start receiving the blood from left atrium, I have to lower my pressure by relaxing. That's going to be the first part of diastole. The ventricle that was contracted in systole relaxes itself to lower its pressure. This phase we call it as isovolumetric relaxation. Isovolumetric relaxation. Once it lowers the pressure, the mitral valve opens. And then the blood starts moving from left atrium to left ventricle. So first phase of diastole is isovolumetric relaxation. The role of isovolumetric relaxation is to lower the ventricular pressure lower than that of atrium. Okay, done. I have relaxed it. The pressure is lower. The mitral valve opened and the blood started moving from atria to ventricle. So as the diastole continues, blood is moving from atria to ventricle. So what is happening to the ventricle? Ventricle is getting filled. Atria is getting emptied. So if ventricle is getting filled, what will happen to the ventricular pressure? If I add blood into the ventricle, its pressure starts increasing. And what is going to happen to the atrial pressure? Blood is leaving the atria, so atrial pressure starts decreasing. So I will reach a point where the pressure in atria and ventricle are equalized. Can further transfer of blood happen from atria to ventricle once the two chambers are at equal pressure? Physics does not allow it. Physics says only high pressure to low pressure movement. No movement between equipressure zones, right? So this phase where blood moved from atria to ventricle because of the pressure difference, we call it as passive filling, because atria did not push the blood, ventricle lowered its pressure, and because of that it received the blood. That is passive filling. But after equalization of pressure, I may still have some amount of blood in the ventricle. and this blood has to be pushed down to the some amount of blood in the atria. This has to be pushed into the ventricle. Now the responsibility is on the atria. Atria has to contract so that its volume decreases and pressure increases, and that increased pressure will help me transfer that remaining blood from the ventricle, because at the end of passive filling both the chambers are at equal pressure. Atrial contraction should raise its pressure so that the blood moves. This phase we call it as active filling, because here atria is contracting actively. So diastole will have two phases of filling. Systole had two phases of ejection, rapid ejection and then slow ejection. Diastole has first isovolumetric relaxation for the ventricular pressure to be lowered, then mitral valve opening, and after that passive filling just because of pressure difference. And once the pressure is equal, remaining blood is pushed by active contraction, that is active filling. So in the diastole, the first phase will be isovolumetric relaxation. So do you think I will have a murmur in this isovolumetric relaxation phase? No. In isovolumetric relaxation phase, ventricle is still lowering its pressure. The mitral valve is not open yet. So in the systole, aortic valve opened after isovolumetric contraction. In the diastole, mitral valve will open after isovolumetric relaxation. So you learn one important point here. The valves open once then iso phase gets over. Aortic valve opened after isovolumetric contraction. Mitral valve opened after isovolumetric relaxation. So this is where the opening of the mitral valve happens. A normal valve makes no noise when it opens, but this is stenosed valve. It is stiff. While opening, it may make that noise. This noise, we will call it as opening snap, or in simple words, snap. Opening snap, or in simple words, snap. This noise is not as loud as the sound of opening of aortic valve. So that was loud, that's why we had called it as click. This is less loud, so we will call it as snap. After that, the valve is open. The pressure in the ventricle is now lower than that of atria because it has relaxed here. So blood starts moving. This phase we will call it as passive filling phase. And after the passive filling phase, the pressure becomes equalized between the two chambers, and then atria contracts to do active filling. So blood is moving only during this filling phase where I am filling the blood from atria to ventricle. So I will hear murmur only in the filling phase. Okay. So the murmur starts audible in the passive filling phase. But then tell me what will happen to its intensity in the active filling phase. Imagine that this is the left atria. Okay. Now I have lowered the pressure in the receiving chamber and opened this valve. Isovolumetric relaxation is done, valve is open. So initially filling happens because of the pressure difference. It is moving because of the pressure difference. So as the blood moves from this atria to ventricle, the pressure in the atria starts decreasing, ventricle starts increasing. Once they're at equal pressure, it stops. No more further movement. Passive filling is over. Now atria actively contracts to push the remaining blood. So now think about the turbulence at the level of this opening valve. In passive filling, there was no forceful push from behind, right? So I had some degree of turbulence. But in active filling, I'm forcefully pushing. So what will happen to the turbulence here? It will increase. So that increased turbulence in the active filling. So what should I call that as? Now, I have got this beautiful murmur, which is heard in diastole, but not in the first isovolumetric relaxation phase. So I can't call it as pan-diastolic, right? And I can't call it as late diastolic because it's not only restricted to active. It is running throughout the filling phase. So either you can call it as a filling murmur, but no such word has been used by any other cardiologist so far. For ejection, we have used ejection systolic, right? Nobody has called it as a filling diastolic murmur. The only other term that can fit the description is mid-diastolic murmur, because somewhere in the middle it is starting. It's not there throughout the diastole. It's not there in only early part. It's not there in only late part. Somewhere in the middle of the diastole it is starting. So I will call it as mid-diastolic. Okay, fair. Now in the explanation, I also have to account for this increase in the intensity in active filling. Why the intensity increase in active filling? Because in active filling, atria is contracting, trying to push the blood through a very small opening. So when I try to squeeze out any fluid through a small opening actively, the turbulence will be more. When I just let it flow, there is some amount of turbulence, that is passive filling. In passive filling, just the pressure difference is making the blood to flow from atria to ventricle. But in active filling, atria is contracting and pushing. So when I squeeze the blood through a narrow opening, turbulence is going to increase. So murmur intensity increases. So we'll call this murmur as mid-diastolic murmur. With this turbulence increase in active filling, we will call it as pre-systolic accentuation. Why am I calling it as pre-systolic accentuation? Because it is the last part of diastole. After this, I have systole. So just before systole started, the intensity of the murmur increased. So we'll call it as pre-systolic accentuation. So on auscultation, we are getting an opening snap and we are getting a mid-diastolic. I'm just leaving a little space to fill a word. I'll come back to that. Mid-diastolic murmur with pre-systolic accentuation. Pre-systolic accentuation. The increase in the intensity in the active filling phase or just before the systole starts is called as pre-systolic accentuation. Best heard in mitral area. Where is mitral area located? Can anybody tell me where is mitral area located? And because it is a left-sided heart pathology, it is best heard in breath held in expiration. And what should be the position of the patient? We generally don't use the term crescendo here. It's not wrong to use it, but traditionally what has been called is pre-systolic accentuation. Accentuation also means increase. So mitral area is at the apex, and the usual location of the apex is fifth intercostal space medial to mid-clavicular line. So if this is the mid-clavicular line, in the fifth intercostal space, medial to mid-clavicular line is where we have the mitral area. Okay, so that is our location. Now this area, this is here, right? Mid-clavicular line. So it's slightly off center. So this area can be brought more closer to stethoscope if you turn the patient leftward. While he is lying on the bed, if you turn him left side and then auscultate, you will bring the area more closer to stethoscope. So murmur can be better heard. So best heard in left lateral decubitus. It is called as left lateral decubitus. Okay. And the word that I wanted to fill here is rumbling murmur. So there is a pro tip here. If you are in a final practical exam and your PG or a SR tells that there is a case of mitral stenosis, right? Comment about the murmur only if you clearly heard it, because the diastolic murmurs are usually not very loud. This murmur that we are talking about here is very soft. That soft sound is called as rumbling. It's like whispering. So it needs trained ears to pick this murmur. So if you just say that, sir, I heard it, when your sir himself is struggling to pick that murmur, he clearly knows that you are bluffing, right? So if you hear it, then only mention. If you don't hear, no need to mention. For auscultation, I could not appreciate any abnormal sounds or murmurs. Or if you could only hear opening snap, you can say, sir, in the diastole, I heard an additional sound. I think it is opening snap, but I could not appreciate the murmur. To be able to appreciate this very slow, soft, rumbling kind of murmur, you need a very quiet room, and your examination hall is generally not that quiet room. So your teachers can easily guess whether you are making up the findings and telling it or whether you really identified it. So don't make a fool of yourself by trying to fit all the findings to a diagnosis that your PG has told this case belongs to. Present honest findings. Okay, you've appreciated, good. If not, it's fair enough. No teacher is going to fail you for missing out a murmur, but definitely they may fail you for bluffing about a murmur, right? But you should know how to examine. So most of the times final practical exam is all about methods. It's not about picking up the finding. So as long as you're doing the right methods, we know that it's a learning curve. It's all our hand skills, ear skills, auscultation skills. They keep getting better with time. So if your foundation is right, your methods are right, you will become pro in near future. So as a teacher, we know that. So we are only seeing whether you're studying and applying the methods, right? So just remember, if they ask you auscultate for the murmur of mitral stenosis, then make sure you ask the patient to turn left lateral decubitus, identify the apex beat, mid-clavicular line, and then keep the stethoscope there. Once you do that, your teachers know that, okay, you know the basics, right? Okay, so this is about the examination findings. For the diagnosis, of course, the investigation of choice is always going to be echocardiography. And as I've already told you, in the echo, if you want to write about it, you can also mention that less than 1 centimeter square is considered as severe MS. Bracket, you can also mention current edition or latest update, less than 1.5 centimeter square is also considered as severe according to some sources. So Samantha, the word pre-systolic refers to that phase of cardiac cycle that happens just before the systole starts. Systole starts after S1. So just before S1, that is called as pre-systole. That's basically active filling phase. So during active filling phase, the murmur intensity increases. So murmur intensity is directly proportionate to the turbulence of the flow of blood. So turbulence in active filling increases because see, imagine this is left atrium. I'm passing the blood from the left atrium to left ventricle through this opening. So in the passive filling phase, this valve is open and I'm just transferring the blood just because of the pressure difference. There's no active push from behind. So I don't get much turbulence here. So in the passive filling, turbulence is there, but it's not too much. But in active filling, I start squeezing this, right? So this thing that you're seeing here, I start squeezing it. So when I start squeezing it, I will create more turbulence, right? Just take any PET bottle, take a 200 ml bottle, right? And start pouring some water. You will see some degree of turbulence coming from that water coming out of that opening. But then start squeezing the bottle, you will create a lot more turbulence, right? So same thing here, turbulence increases because of active filling. In active filling, atria contracts. And that increased turbulence, we will hear it as much louder murmur. That's what we call as pre-systolic accentuation. Accentuation means increase. Okay, so echo is the investigation of choice for diagnosis. And once you're diagnosed, when it comes to management, remember what is the most common cause for mitral stenosis? The most common cause for mitral stenosis was rheumatic heart disease. And in rheumatic heart disease, the stenosis is not because of the calcification of the valves. You know, when we studied aortic stenosis, I told the aortic valve gets calcified because of the age-related atherosclerosis. That's the most common cause. But mitral stenosis, RHD is most common cause. In RHD, the two valve leaflets gets fused because of fibrosis. It is because of this fusion. It's not because of calcification. So I don't have to jump to replace this valve. I have more simple solution. What I can do, I can pass a balloon through this valve and then dilate it. Dilatation is possible. In aortic stenosis, it's not possible because the valve is calcified. How will you dilate it? Even if you dilate it, it is calcified. It will narrow down quickly. But in RHD, calcification is not the main pathophysiologic process. It is the fusion of the two cusps because of adhesions or fibrosis. So I can make those adhesions break by passing a balloon through this and opening it. So that's why the definitive treatment is not the valve replacement. It is the dilatation with the help of balloon. Only when balloon dilatation is not possible, we go for the valve replacement. So definitive treatment is called as balloon mitral valvotomy. There is a possibility of restenosis even after balloon. So in such cases, again, we have to go for valve replacement. But the restenosis mostly happens if patient has further attacks of rheumatic fever. And that is preventable if we give the rheumatic fever prophylaxis, that is penicillin G or erythromycin or other antibiotics. So to some extent, it is preventable. So most patients we may be able to manage with 1 or 2 sessions of balloon dilatation itself. But for them, for those patients where the restenosis is a big problem, we can go for the valve replacement. So definitive treatment is balloon mitral valvotomy. It's usually abbreviated as BMV. See, in mitral stenosis, the two leaflets have developed some adhesions or connections. So if I pass a balloon across this and dilate it, I can break those adhesions. It's like, two shirts, they are glued together. But if I somehow break that glue, fine, my shirts, now I can open it, right? It's like a button which is now bringing the two sides of the shirts together. If I remove the button, the problem is solved, right? So same way, the fibrotic bands or adhesions connect the two cusps together, and that's why the opening is between them is small. They're not able to separate. But if you pass a balloon and dilate, you will be able to separate them. And because that's a more not conservative but less invasive procedure than opening and replacing the valve, we will go ahead with the balloon valve valvotomy, or breaking down these adhesions. And mitral valve replacement is considered in patients with contraindications for balloon mitral valvotomy. Otherwise, most patients we try to manage with balloon mitral valvotomy itself. Okay. Now in mitral stenosis, especially bedside discussion, they do ask you about certain complications. So what are the complications? We have already discussed one complication, that is compression of the left recurrent laryngeal nerve leading to Ortner's syndrome. So that is one complication. Then second complication, this enlarged left atrium increases the risk of developing atrial fibrillation. So there is increased risk of atrial fibrillation. And again, remember this, the risk of atrial fibrillation is directly proportionate to the size of left atrium. Bigger the left atrium, higher the chance of developing atrial fibrillation. So in mitral stenosis, left atrium is dilating to compensate for the pressure rise that is happening there, right? The dilated left atrium is responsible for compressing the recurrent laryngeal nerve, giving rise to Ortner's syndrome. The same dilated left atrium is also a risk factor for atrial fibrillation. So in your bedside discussions, your teachers do ask you, how do you recognize whether a mitral stenosis patient has developed atrial fibrillation? So in atrial fibrillation, you will have a pulse which becomes variable or irregular. So you will have a irregular pulse. And second, you will have varying loudness of S1, For mitral stenosis also, there is no role of pharmacotherapy per se, because there is low stroke volume. So if you try to give any drugs to reduce the congestion of the lungs that is causing dyspnea, like diuretics, it will worsen the low stroke volume related symptoms. So it is like you have to pass a balloon, dilate it, problem is solved. So please tell the teacher, if he asks, how do you recognize that a patient of MS has developed AFib or not clinically without doing the ECG, you can say, sir, the pulse becomes irregular. That's a classic finding of atrial fibrillation. And the loudness of S1 starts varying. It's not same in each cycle. Sometimes S1 is loud, sometimes it is soft, sometimes it is normal. So these are the clues towards atrial fibrillation. Then one more thing, this is very important. Your teachers very often expect you to answer this. That is loss of pre-systolic accentuation of murmur. So now tell me, why did we get this pre-systolic accentuation of murmur? The murmur increased because of the atrial contraction or active filling. In atrial fibrillation, atria does not contract. It only fibrillates or shakes. So if it is not contracting, it is not squeezing the blood. If it is not squeezing the blood, it is not increasing the turbulence. So you will not get that accentuation, right? So that is also one more important. So if you're able to answer these three, your teachers will be more than pleased to give you full marks, close to full marks on your bedside. And if you've written this in your theory paper, your answer is complete, right? Mitral stenosis, it was only syncope and dyspnea, no angina, right? So similarly for AR, MR, PR, PS, TS, we will have symptoms. Then examination findings, what you should write for pulse, what you should write for apex beat, and what you should write for auscultation. And management for all the valvular heart diseases, if you can't write about pharmacotherapy and all, just write about definitive management, valve replacement. That's more than adequate. So with that, you will be able to squeeze 5 or 6 marks minimum comfortably for a 10-mark question. And if you remember more precisely, if you can sketch the phonocardiographic image of the murmur and all, you will squeeze in 1 or 2 marks more. So you don't have to do a very detailed study of valvular heart diseases to be able to write questions on valvular heart disease. So the question that we will be discussing now is the heart failure. Heart failure, time and again across universities, had been one of the important and repeatedly asked questions, like real for real. Right. So the question on heart failure may go like this: define heart failure, discuss classification, pathophysiology, diagnosis, and management. What particularly teachers are interested in looking at when they are assessing the answers is mainly whether you write the classification properly, whether you have an idea of pathophysiology. Management wise, as long as you're able to list the pharmacological intervention and non-pharmacological intervention, that's more than enough. And as I've told you, for all long questions, I would expect you to write a brief 1 or 2 sentence introduction. And if the question itself is asking you to define a condition, then you don't need to write the introduction. You can directly start with the definition. Okay, so what is heart failure? The conceptual definition of heart failure is heart has to work. Mainly, we are concentrating on ventricles, and ventricle is supposed to contract and eject the blood, right? And to be able to eject the blood, first it has to receive the blood. So yesterday in the class, I have told you that we have something called as isovolumetric relaxation and diastole that enables the ventricles to lower its pressure below atria, and then it can receive the blood. So receiving the blood by ventricles is an important function. Similarly, ejection of blood by ventricle is also important function. Both of them are functions of heart. If any one of them is not happening properly, I would call it as heart failure, right? So how many of you agree with my conceptual definition of heart failure? Crazy loser, we would be covering the important topics. So the definition wise, I would define as impaired, because as I just told you, heart has 2 functions: receiving the blood, that is filling of the ventricles, and ejection. So one of them impaired is failure of heart. So impaired ventricular filling, or ejection, or both, then we will call it as heart failure. Okay, now this is a conceptual definition. What is the technical definition? The technical definition is patients with signs and symptoms of heart failure. Later I will discuss the signs and symptoms of heart failure. For now, just understand, anyone with signs and symptoms of heart failure plus a biomarker suggestive that these symptoms are because of heart failure. See, one of the symptoms of heart failure is shortness of breath. There are n number of causes for shortness of breath, right? Can anybody list the important causes for shortness of breath apart from heart failure? Like pneumonia, then pleural effusion, pneumothorax, pulmonary embolism, severe anemia, high altitude, all of them, right? So when I can link the patient's shortness of breath to the failure of the heart with the help of a biomarker, then you can say, this person has got heart failure. And that biomarker is N-terminal proBNP. So if there are signs and symptoms of heart failure with elevated biomarker of heart failure, that is equal to heart failure. Then you have heart failure. This is a technical definition. Okay, now that we know the definition of heart failure, let us look at its classification. So there are various ways of classifying heart failure. The first classification that I'm putting out is mainly looking at the heart as right heart and left heart. So we can classify heart failure as right heart failure and left heart failure. Now, traditionally speaking, most of the cases of heart failure that we are going to encounter in our clinical practice are going to be left heart failure. Right heart failure is much less common. So that's why if any teacher during the ward rounds randomly discuss about heart failure, he is mostly pointing towards left heart failure. Okay. But now that we are writing a prof answer, we will classify it as right heart failure and left heart failure. So when I say right heart failure, the right ventricle has either impaired filling, it's not able to fill the blood, or it's not able to eject the blood. When I say left heart failure, I'm referring to left ventricle not able to fill the blood or not able to eject the blood. So left heart failure and right heart failure. Now in terms of the clinical features, or you want me to mention some causes? Okay. The causes for right heart failure and causes for left heart failure. The causes for right heart failure, most common cause of right heart failure is left heart failure. That's what we have been discussing from yesterday as well, right? So when we talk about heart per se, anything that affects the left side of the heart eventually will come to right. That's what we learned yesterday, right? Whether we had aortic stenosis, mitral stenosis, aortic regurgitation, mitral regurgitation, and left heart failure. All of them have one common feature, that is increase in the left atrial pressure. And when left atrial pressure increases, the pulmonary vein pressure increases. And if pulmonary vein pressure increases, eventually pulmonary capillary pressure increases. Then pulmonary artery pressure has to increase. And once pulmonary artery pressure increases, there are some compensatory changes happening in the right side of the heart, right? Can anybody tell me what are the compensatory changes happening in the right side of the heart if pulmonary artery pressure is high? Well, pulmonary artery generally offers some degree of resistance for the ejection of blood by right ventricle. That's what we call as, what do we call it as? The resistance given by the blood vessel for ejection of blood into it by the ventricles. On the left side, when left ventricle tried to eject into aorta gave a resistance. We called it as afterload of left ventricle. So similarly, right ventricle will also face afterload, which is the resistance given by pulmonary artery. If pulmonary artery pressure is already high, it is going to give more resistance. So afterload increases. And remember yesterday, what did I tell you? Whenever there is increase in afterload and ventricles do more work to overcome that, they do develop hypertrophy. Increase afterload leads to what kind of hypertrophy? Concentric hypertrophy, right? And I don't want you to get confused. Where do you get concentric and where do you get eccentric? If there is increase in the preload, you get eccentric hypertrophy. But if there is increase in the afterload, you get concentric. How do I remember it? Remember ACP. P means pulmonary embolism. AC means air conditioner. Right now, most of you may be sitting in air conditioned environment. So when afterload increased, you get concentric. When preload increased, you get eccentric. ACP. That's what I want you to remember. So now, here in this scenario, because of increase in the pulmonary artery pressure, right ventricular afterload increased, right ventricle developed concentric hypertrophy. And once right ventricle developed concentric hypertrophy, what happened to its volume? Ventricular volume decreased. If volume decreased, do you think I can fill the sufficient quantity of blood into the right ventricle? Smaller, see, earlier I used to drink, I don't drink, but just imagine that earlier I used to drink in liters glasses. Now I have tiny cups because doctor said drinking too much is not good. So now can I fill 1 liter of alcohol, madira into my tiny cup? No, I can only fill 150 ml because the cup size itself is decreased. If you give me a 1 liter bottle, I'll pour 1 liter and drink, right? Simple. Ventricular size decreased. So the amount of blood I can fill decreases. So what impaired now? Filling got impaired. And yesterday we learned that if I fill less, I will be able to eject less only, because if I'm getting less, I can eject less only. If I'm not getting sufficient, how can I eject more than what I'm getting? Not possible. Simple. So impairment of right ventricular filling happened. And what did we define heart failure as? Impaired ventricular filling or ejection. So the problem that started in the left eventually resulted in impaired right ventricular filling. So right heart failed. Got it? So the most common cause for right heart failure is left heart failure. Most common cause for overall right heart disease is left heart disease. When left gets affected, somehow the problem reaches the right. So left heart failure is the most common cause. Apart from that, we have cor pulmonale. What is cor pulmonale? Respiratory disorders causing right heart failure. Yesterday we discussed about it. We have discussed about it in COPD as well. Especially chronic bronchitis patients, whom we call as blue bloaters, are prone to develop cor pulmonale. Why? Because in chronic bronchitis, alveolar hypoventilation is there, hypoxia is there. Because of the hypoxia, pulmonary capillaries constrict, and once the pulmonary capillaries constrict, once these capillaries constrict, behind that the pressure starts building up pulmonary hypertension. And once you have pulmonary hypertension, afterload of the right ventricle increased. And once the right ventricular afterload increased, I have concentric LVH. Once I have RVH. Once I have concentric RVH, I have less space to fill. Filling of the right ventricle reduced, and impaired filling is heart failure, right? So cor pulmonale is second cause. Okay, apart from that, what other causes I can list for right heart failure? Pulmonary arterial hypertension. Then right-sided valvular heart diseases. Valvular heart diseases on the right side, like pulmonic stenosis, pulmonic regurgitation, tricuspid regurgitation. They can also cause right heart failure. So these are all causes for right heart failure. Now, what are the causes for left heart failure? Of course, I can't say the most common cause for left heart failure is right heart failure. The problem of right does not reach the left. Only the problem of left reaches the right. So overall, the most common cause for the left heart failure is hypertension. Now you may be wondering, how, sir? How hypertension becomes a cause for heart failure? Simple. If you have hypertension, your pressure inside the aorta and its branches is high. Just like how I had pulmonary hypertension. Pulmonary hypertension resulted in increased afterload of the right ventricle. Systemic hypertension increases the afterload of left ventricle. And when afterload is increased, you develop concentric LVH. The most common cause for left ventricular hypertrophy is hypertension. Now that I have developed the concentric LVH, I have less space available for ventricular filling. So during diastole, I can't fill sufficient quantity of blood into the ventricle. And because of that, the amount of blood ejected or the stroke volume comes down. Now again, I can call this as heart failure, impairment in filling. Simple. That's most common cause. The second most common cause is ischemic heart disease. Now you may be wondering why ischemic heart disease causes heart failure. Now just look at this heart. This ventricle is a muscle, right? It is able to contract because it is muscle, and for it to contract, it needs blood supply, which comes from the coronary artery. Now if coronary arteries get blocked, this ventricular myocardium is not going to get sufficient blood supply. If it does not get sufficient blood supply, can it contract? No, its contraction will get affected. Just to give you an example, let us say someone developed this lateral wall MI. So this part of the ventricle is what we call as lateral wall, right? So here he has developed this lateral wall MI. This part of the myocardium is dead, infarcted. It can't contract. So only interventricular septum and the right side of the heart is contracting. This part, lateral wall, is not contracting. So do you think the amount of force that this ventricle can generate to eject the blood will be same as before? Of course not. Like, think of this. This is ventricle. It is the interventricular septum. This is lateral wall. Both contract to eject the blood. Now, only interventricular septum is contracting. The lateral wall doesn't. So then how will I eject the blood? Right? The force of contraction comes down. The amount of blood I would be able to eject will also come down. So stroke volume is less. Now what got affected here? Ejection got affected. So this is also heart failure. Impaired filling or impaired ejection is heart failure. So now I have ischemic heart disease also as a cause for heart failure, right? Apart from that, what if the left ventricular muscle mass starts thinning out or getting atrophied? That is also heart failure, because then ventricle cannot contract and generate sufficient force. So that can happen in patients with dilated cardiomyopathy. Okay. What if I develop hypertrophy of the left ventricle, just like how I got it in hypertension, but without hypertension? Yes, that can happen in hypertrophic cardiomyopathy. So similarly, the restrictive cardiomyopathy causes mainly right-sided heart failure. So I want you to remember this. R for R. Restrictive cardiomyopathy causes mainly right-sided heart failure. Dilated and hypertrophic cardiomyopathy mainly cause left-sided heart failure. Dilated cardiomyopathy, the left ventricle is thinned out. Muscle mass is less. That's why ventricle is dilated. So its force of contraction comes down, ejection get affected. In hypertrophic cardiomyopathy, the force of contraction is good because muscle is hypertrophic. But because it is concentric type of hypertrophy, the space available in the ventricle for filling is less, so filling is less. That's also impaired filling, and that's also heart failure. Okay, so these are causes for left and right heart failure. Now that we know the causes, if I am assessing the paper, I would definitely expect that you do mention about the clinical features of left heart failure and right heart failure. And particularly if you want to catch the attention of your paper corrector, do mention or highlight the most common cause for right heart failure as left heart failure. Examiners are very much fond of asking this question. Now, if the right side of the heart fails, basically either I'm not able to eject sufficient blood or I'm not able to fill. So one of the outcome of that is the stroke volume that is coming out from the right ventricle will come down. In the left side, the stroke volume coming out from the left ventricle will come down. What other problems we are going to face? The other problem is the impaired filling. So if the filling is less, the pressure in the right atrium increases, because right atrium is getting blood, but it is not able to transfer to the ventricle because ventricular cavity size is already small because of concentric hypertrophy. So then if I'm not able to transfer blood from right atrium to right ventricle, right atrial pressure will start increasing. And if right atrial pressure increases, all the structures behind it in the hierarchy, their pressure will also increase. So superior vena cava pressure will increase, inferior vena cava pressure will increase. And if the superior vena cava pressure increases, you will see that as raised JVP. So raised JVP is a classical finding that you get whenever right side of the heart gets affected. Inferior vena cava pressure getting elevated also manifests as congestion in the liver. Why congestion in the liver? Again, that's pretty simple. You should know that liver receives the blood supply from two sources, the dual source of blood supply to liver. So liver gets blood supply from hepatic artery, that is from the systemic circulation, means that blood is coming from the aorta as a branch of aorta, that is hepatic artery, right? But there is one more source of blood supply, that is portal veins. And you know that portal vein is formed by fusion of, let us say this is a portal vein. It is formed by fusion of splenic vein that brings the blood from spleen and superior mesenteric vein. The superior mesenteric vein is bringing the blood from your intestine after the, it's like post-absorptive blood is what I call it as. Now what do I mean by this post-absorptive blood? We eat food. Our food contains toxins, useful nutrients, unwanted stuff, everything, right? Now it gets digested and we absorb, and when we absorb, we are absorbing nutrients as well as toxins. The toxins needs to be metabolized. Nutrients also need to be subjected to metabolism. And there is need for various conversions or change in chemical composition of those substances. And who is the major metabolic organ in the body? Liver. So these substances that are absorbed from the diet or from the food should not directly go to systemic circulation because they may be having toxins, and even nutrients may not be in the final form that body needs. First it has to go to liver. So from the intestine, blood goes to liver, and the responsibility of bringing that blood from the intestine to liver through superior mesenteric vein is with the portal vein, And you may ask me, sir, what about inferior mesenteric vein? Inferior mesenteric vein joins the splenic vein. So all your intestinal blood is going to liver. And once the blood comes to the liver does all the metabolic process. And once the metabolic process is completed, now the ready blood is transferred to the systemic circulation through what we call as hepatic veins. So if the inferior vena cava pressure is already high because the right atrial pressure was high, then hepatic vein pressure will also be high. So if hepatic vein pressure is high, on one side blood is coming into the liver from the intestines, but it's not able to leave the liver easily to go into systemic circulation because ahead of it, everywhere the pressure is high. So the blood starts stagnating or congesting in the liver. And because blood is stagnating, the liver starts increasing in size. And this is what we call as congestive hepatomegaly. In pathology, you study it as CVC, chronic venous congestion. Nutmeg liver that they teach you. Why is this happening? It's happening because the pressure in the right atrium was elevated. So what are the findings we are getting when there is right heart failure? Superior vena cava pressure increases, that manifests as raised JVP. Inferior vena cava pressure increases and that manifests as congestive hepatomegaly or nutmeg liver or chronic venous congestion. Okay. This may eventually lead to the liver dysfunction. You may see jaundice, right upper quadrant pain and all, and it may even lead to cirrhosis if it is long running. Eventually what happens, if pressure inside the liver builds up behind that portal vein cannot push the blood into the liver because liver is already loaded with blood. So eventually the portal vein pressure will also increase, and when portal vein pressure increases, that's what we call as portal hypertension. So right heart failure can lead to portal hypertension. Portal hypertension is not always about cirrhosis of liver, right? Okay. So is that clear? So let me write down the findings that you should write for the right heart failure. So right heart failure will present with raised JVP, hepatomegaly because of the congestion in the liver, ascites is happening because of the portal hypertension, and you will also have pedal edema because inferior vena cava pressure is high. So you have difficulty to drain the blood from the lower limb veins. So you will end up with pedal edema. These are classical symptoms of right heart failure. Now, if the left heart fails, what am I going to expect? If the left heart fails, just like how right heart failure resulted in right atrial pressure going high, left heart failure results in left atrial pressure going high. And if the left atrial pressure starts going high, eventually pulmonary vein pressure will increase, pulmonary capillary pressure will increase, and the congestion, just like how right heart failure resulted in congestion of the liver, the left heart failure will result in congestion of the lungs, right? So now you have congestion of the lungs presenting as dyspnea or shortness of breath. And this dyspnea or shortness of breath generally gets worse on lying down in supine position. And what do we call it as when you have shortness of breath on lying down or supine position? What do we call it as when you get shortness of breath on lying down or supine position? I'm covering the cardiomyopathies. Yes, we call it as orthopnea. So you may end up developing orthopnea. Another manifestation the congestion of the lungs can lead to is PND or paroxysmal nocturnal dyspnea. Now I have little lack of time because I have other major questions to cover. But don't worry, as of now, just remember orthopnea and PND are symptoms of right heart failure. Left heart failure. I will discuss the mechanisms behind that elaborately in another video where we will be taking up more detailed discussion on heart failure. For now, just let's focus on writing the answer for Prof. Exam. Okay, let me tell you in simple terms instead of being an elaborate discussion. In simple terms, when you have left heart failure, you already have congestion of the lungs. Pulmonary capillaries are loaded with blood. Okay. On top of that, when you make the person lie down supine, the gravity is eliminated. So the blood that was there in the lower limb veins gushes to the right side of the heart. And from the right, where it will go? It will go to the lungs, right? Through pulmonary artery. So the blood coming to the lungs increases when you lie down because all the lower limb blood, which was in the lower limb because of gravity, is now coming back to the systemic circulation and reaching the lungs. So already lungs are congested. Add more blood and make more congestion, you will become more short of breath, right? That's why lying down in supine position makes you short of breath in orthopnea. When I make myself upright, immediately there is gravitational pooling of blood in the lower limb. So the blood coming to the right heart comes down. So blood going to the lungs comes down. So congestion of the lungs decreases a little bit and the breathlessness feels little relief, right? PND has a little complex mechanism. In PND, what happens is the lungs get more congested when you go to sleep, and the congestion becomes worse 90 to 120 minutes after you have gone to sleep. Not immediately lying down. If immediately on lying down, if I become short of breath, that is orthopnea. But if I lie down and I go into sleep and 90 to 120 minutes later, if I feel short of breath, then it is PND. It's there in the name, right? Paroxysmal means intermittent. Nocturnal means nighttime dyspnea. This happens because the congestion increases that time, and that increase in congestion is not because of the venous blood coming back to the circulation. It's because of the edema fluid, right? You have edema in heart failure, and that edema fluid slowly, because when you lie down, where do we get edema generally in most of the patients? Pedal edema, gravitationally dependent areas. So During the daytime, patient was ambulant, walking around, so he developed pedal edema. But then night he sleeps. Now the gravity is not trying to pull the blood into the lower limb. Gravity's direction is tangential now. So the lower limb edema starts returning back to circulation, but edema does not return to circulation as quick as the venous blood returns to the heart. Venous blood will return to heart as soon as you change the position. But edema fluid will come slowly. So slowly it will come to circulation, goes to lungs, cause congestion. Second, 90 to 120 minutes later, after going to sleep, patient probably hits his first REM phase of sleep. And in REM phase of sleep, we start dreaming, and dreams often are accompanied by sympathetic nervous system overactivity. And whenever sympathetic nervous system is overactive, adrenaline is all peaking, your heart rate increases. Increased heart rate makes it difficult for me to fill the ventricle. You may ask me why. You know, when heart rate increases, either I have to cut short the duration of systole or diastole, then only I can see. Let us say I am having 60 contractions or 60 cycles, cardiac cycles in each minute. 60 times it is contracting per minute. Now I have to, so in that case, I have 1 second time available for each cycle. But now I have increased the heart rate to 120. So now I have only half second available for each cardiac cycle. So when time available for each cardiac cycle comes down, I have to either cut short the systole time or the diastole time. You know what nature does? It first cuts down the diastole time. Only later systole time starts shrinking down when heart rate further increases. So initially the diastolic time gets shortened. So time available for me to fill the ventricle, because we fill in diastole, that is coming down. So I have less time to fill. So if I have less time to fill the ventricle, I'm transferring less blood from left atrium to ventricle. So more and more blood is staying back in the left atrium. So left atrial pressure will start increasing more. So pulmonary vein pressure will start increasing more. Pulmonary capillary pressure will start increasing more. So two things are there for the PND. The edema fluid slowly returns to the lungs, and 90 to 120 minutes later, you start dreaming, your sympathetic nervous system activity is high, diastolic time comes down, so transfer of blood from atria to ventricle comes down, atrial pressure starts going up. All add up to worsen the congestion of the lungs, and that's why you wake up with dyspnea 90 to 120 minutes after you have gone to sleep. In orthopnea, if I make myself supine and short of breath, the moment I make myself upright, I feel good. I feel better. But in case of PND, the onset of dyspnea is not immediate, 90 to 120 minutes later. And when I wake up from shortness of breath, I'm not going to feel relieved immediately, because the edema fluid that returned to circulation is not going back to the lower limb immediately if I wake up. It takes time, right? So usually you feel relief 30 to 45 minutes after you've woken up, took an upright stance. Most of the time patient walks to the window, because the shortness of breath, general perception is lack of air. They feel air hunger. They stand next to the window, try to feel comfortable, and 30-40 minutes later they feel comfortable, they go back to sleep. But the cycle might repeat. 90 to 120 minutes later again, same story keeps repeating. That's why it is called as paroxysmal or intermittent nocturnal dyspnea. I want you to remember one important point. This is more of an MCQ point or a bedside discussion point. Among the symptoms that I've listed for the left heart failure, PND is the most specific symptom of left heart failure. Most specific symptom of left heart failure. If at all you have a heart failure bedside case, your teachers are very much likely to ask what is the most common cause for right heart failure. They are also very much likely to ask the mechanisms behind orthopnea, PND, and what is the most specific symptom of left heart failure. Orthopnea can happen in patients with diaphragmatic palsy, massive ascites, massive obesity, or even sometimes after heavy meal. Most of you might have experienced it. So orthopnea is not specific, but PND is specific to left heart failure. So this is one classification, heart failure into right and left. But as I have already told you, majority of right heart failure are because of left heart failure, and that's why in a general discussion, heart failure means we are talking about left heart failure. So there is another classification of heart failure which is centered around left heart failure, and that is based on the ejection fraction. So you can put a title saying classification based on ejection fraction. And to understand that, first we need to understand what is ejection fraction. So normally in the ventricle, we fill the blood, like let us say this is the left ventricle we are looking at. And in the left ventricle during diastole, I fill the blood and I eject it during systole. So the amount of blood ejected during each systole is called as stroke, right? Amount of blood filled during each diastole is called as filling volume. And the amount of blood that is there in the ventricle after each systolic ejection is called as end systolic volume. And both end systolic volume and filling volume combined together is called as end diastolic volume, right? So let me put some mathematical terms here. End diastolic volume is the amount of blood present in the ventricle at the end of diastole. And how much is present? One, I just completed a systole, so I ejected some amount of blood, something is remaining with me, and then some amount is filled by the atria. So that is filling volume. This is end systolic volume. Both together is there at the end of diastole in the ventricle. So it is the end systolic volume plus the filling volume. Okay. Now out of this, I eject some percentage of, like normally the resting end diastolic volume is around 120 ml, 120 to 125 ml. Out of it, some amount of blood gets ejected in each systole, and that is approximately around 70 ml. Now if I express in terms of percentage, what percentage of blood that was there in the ventricle at the end of diastole got ejected as stroke volume, then we will call that percentage expression as ejection fraction. So ejection fraction is nothing but EF stands for percentage of end diastolic volume ejected as stroke volume. So what will be the formula? EF is equal to stroke volume divided by end diastolic volume, but I want to express it in percentage, so I have to multiply it with 100. So that gives me the ejection fraction. So normal ejection fraction ranges from 60 to 70%. That means if I give 100 ml of blood to the ventricle, at the end of diastole, ventricle has 100 ml of blood. That includes the volume that got filled from the atria and the volume that was already there remaining from previous systole. Combined is end diastolic volume. Out of it, if my ejection fraction is 60%, then I will be able to eject 60 ml out of it, right? 100 ml is there as end diastolic volume. 60% of that is 60 ml. That becomes stroke volume. 60 ml becomes stroke volume, right? Got the gist of what is ejection fraction. Now tell me, what is the biggest determinant of ejection fraction? Who decides how much is the ejection fraction? Simple. Okay. Let me take this bottle. Okay. So this is some talc bottle. In this, let me fill water. Okay. Let us say I fill 100 ml of water and then I squeeze it. How much ml comes out? 100 ml is there when filling is over. Or there already 30 ml was there. I filled 70 ml as filling volume, 30 ml end systolic. All that's fine. I have 100 ml at the end of diastole. Now I am doing systole, right? I contract, I push or squeeze, and then some amount of water got ejected from this bottle. That water is your stroke water. Okay. If I squeeze hard, more amount of water will get squeezed out. If I squeeze less hard, less amount of water will get squeezed out, right? 100 ml was there. If I squeeze hard, I may be able to bring 90 ml out. In that case, what will be my ejection fraction? 90%. If I squeeze less hard, 30 ml will come out. Then my ejection fraction becomes 50%. So what decided how much will come out of this chamber? Force that I am applying. In the heart, who is applying the force? Left ventricular muscle mass. So if muscle contracts more forcefully, I will have more ejection fraction. If the muscle's force of contraction is less, I will have less ejection fraction. So it is the muscle that determines the ejection fraction. And when I said 60 to 70%, right, is that fixed? No, it is the resting ejection fraction. If I start running, I need more stroke volume, right? If end diastolic volume is fixed, how will I get more stroke volume? If ejection fraction is also fixed? No, ejection fraction is not fixed. At a resting condition, your muscle is able to contract with some force, and that force is giving you 60 to 70% ejection fraction. But when I start exercising, sympathetic nervous system gets activated, right? So adrenaline, noradrenaline, dopamine, they will come and stimulate the heart to contract with more force. So when heart contracts with more force, ejection fraction increases. And that is how I'm able to get more stroke volume, more cardiac output during physical activities, exertion. But then also we learn one more point here. The muscle is the biggest determinant. What if I kill the muscle? Ejection fraction will come down. So because of that, stroke volume will come down. Even if you give me 120 ml end diastolic volume, I've killed the muscle, so it can't generate sufficient force. So because of that, instead of 70 ml, I may be able to eject only 50 ml, 40 ml or 30 ml as stroke volume. So why I got low stroke volume? Because the ejection fraction is now less, right? So what does this indicate? Whenever ejection fraction is less, the problem is in ejection. I'm not able to eject well. If I have heart failure where ejection is fine, means muscle is fine, its force of contraction is good, but still I have heart failure, that means the problem was not in ejection, problem was in filling. So ejection fraction helps you to identify whether the patient you're seeing with the signs and symptoms of heart failure, whether he has a problem in ejection or whether he has a problem in filling. Now tell me, I'm waiting for your comments. Tell me whether if I have a problem in ejection, can I call it a systolic heart failure? And if I have a problem in filling, can I call it as diastolic heart failure? Perfectly makes sense, right? We eject in systole. So if that is where is impaired, then I have systolic heart failure. If filling is the problem, that happens in diastole. So it's a diastolic heart failure, right? So impaired ejection can also be called as systolic heart failure, and impaired filling can also be called as diastolic heart failure. Got it? So that's why ejection fraction is a very important tool for the classification of heart failure, not for diagnosis. Because diagnosis is based on the biomarkers and the clinical features. But to understand whether it is systolic or diastolic, or whether it is impaired ejection or impaired filling, we need to look at the ejection fraction. So if ejection fraction is less than 40%, we will call it as heart failure with reduced ejection fraction. And if EF is more than 50%, more than or equal to 50%, we will call it as heart failure with preserved ejection fraction. If the EF is between these numbers, we can call it as heart failure with mid-range ejection fraction. Okay. Now, as a UG student, as long as you are able to quote preserved and reduced, fair enough. It's more than enough. Okay. So heart failure with reduced ejection fraction is usually abbreviated as HF-REF reduced, REF, HF-REF, and heart failure with preserved ejection is usually abbreviated as HF-PEF. Some books may quote it as HF-NEF, normal ejection fraction. Ejection fraction is not low. That's what preserved means, right? So heart failure with reduced ejection fraction is equal to systolic heart failure. And heart failure with reduced ejection fraction is equal to diastolic heart failure. Now, if you ask me what is the most common cause for systolic heart failure, it is ischemic heart disease. You kill a muscle, it can't contract well, ejection fraction will come down. That's why you might have had relatives or your family members, elderly, diagnosed with IHD with low EF. Very often they develop congestion of the lungs. You have to take them to the hospital, give a diuretic job, put a very strict restriction on salt and fluid intake, and then eventually the condition progresses. We might have to start, the doctors might start talking about cardiac transplantation and all of that, right? The most common cause for diastolic heart failure is hypertension. The other cause for diastolic heart failure is hypertrophic cardiomyopathy. The other cause for systolic heart failure is dilated cardiomyopathy, right? So these are methods of classifying the heart failure. Okay, now that we know the two classifications of heart failure, let us also look at the pathophysiology of heart failure. Exactly what happens when heart fails. So two things happen when heart fails. Number one, the ejection is impaired or filling is impaired, and outcome of both of them is reduced stroke volume. If the ejection is impaired, then force of contraction generated is less, ejection fraction is less, so less stroke volume. If filling is impaired, force of contraction is good, but then amount available in the ventricle to eject itself is less. So in both cases, I have low stroke volume. So whenever there is heart failure, one of the things you can expect is a decrease in the stroke volume. And when stroke volume decreases, I do expect this to lead to decrease in BP, because systolic BP is directly proportionate to stroke volume. But as we know, even from our valvular heart diseases, there's a counter-regulatory mechanism in the body, that is RAS. RAS will get activated. So decreased BP lead to increased RAS activity. And once RAS gets activated, right, so you have angiotensin 2 and aldosterone coming into picture. And what angiotensin 2 does, angiotensin 2 will try to normalize the BP. How? By causing vasoconstriction. So angiotensin 2 causes vasoconstriction. And vasoconstriction means we're talking about the constriction of aorta and its branches, that is systemic blood vessels. And if they get constricted, pressure inside the aorta and systemic blood vessels increased. Now left ventricle has to put more effort to push blood into a high pressure vessel. So work done by the left ventricle increased. What increased? Afterload or preload? Preload is end diastolic wall. Afterload is the resistance given by aorta and its branches. And now that pressure inside the aorta and its branches is high, they are giving more resistance. So afterload increased. Now, is this good for the heart? No, your heart is already failing. It's not able to handle the workload. And you increase the workload, it fails more. Simple, right? Now, aldosterone, at least that will give me a rescue. No. What aldosterone does? It increases sodium and water reabsorption at kidney. So because of that, the circulating blood volume increases, because more and more water and sodium is reabsorbed. If circulating blood volume increases, more blood reaches the heart. If more blood reaches the heart, then at the end of diastole, heart will have more blood, because more blood is coming to the heart. And end diastolic volume is nothing but our preload. So there is increase in preload. So already heart is failing, it's not able to eject it, or there is no space to fill this blood, but you are increasing this blood. So both increase in afterload and preload because of this RAS are harmful to a failing heart. Unfortunately, it happens. It should not have happened, but nature is not perfect. But then there's also one more change happens. As we just learned, what are the symptoms of right heart failure? Raised JVP, hepatomegaly, all of that. Why is it happening? Right atrial pressure got increased. What are the symptoms of left heart failure? Orthopnea, PND, dyspnea. Why is it happening? Congestion of the lungs. Why lung got congested? Because left atrial pressure increases. So whether it is right or left, atrial pressures increase. So there is increase in atrial pressures. Increase in atrial pressures. And when atrial pressures increase, atria have a mechanism of unloading their pressure. You know what they do? They will tell the kidneys, pressure on us is very high. Just like how you express your stress to your close friend, hoping that he will help you. Similarly, atria is telling the kidneys, we are loaded with pressure, please unburden us. You excrete more urine so that the pressure on us comes down. And what is that signaling molecule that they send? Natriuretic peptides, right? Like ANP, BNP. We will call them as natriuretic peptides. Like ANP, BNP, and these do exactly opposite of RAS. RAS causes vasoconstriction, natriuretic peptides cause vasodilatation. So by doing vasodilatation, they decrease afterload. So they unburden the failing heart. Second, they increase sodium and water excretion. It's there in the name, no? Natriuretic peptides. Natrium means sodium. Uresis means lose. These are the peptides which make you lose sodium, and you know sodium will never go alone. It will always take water with that, being an osmotically active substance. So you have increased sodium and water excretion. So because of that, there is decrease in circulating blood volume. So you will have decrease in end diastolic volume. You will have decrease in preload. So these changes are beneficial for a failing heart. They slow down the failure because they're reducing the burden on the right. So now you might be wondering why sir is talking about pathophysiology. Of course, it has a relevance to the pharmacological management, because now that we know RAS is harmful, what should I do with RAS if I have a patient with heart failure? Block it. Agree? But what should I do with these natriuretic peptides? They are beneficial, right? So I want to support it, facilitate its action. So either I can use natriuretic peptide analogs, or there's one more pharmacological way of dealing with drugs. If I want to increase the activity of any of the drugs, like for example, I want to increase the activity of acetylcholine, then what do? Do I actually give acetylcholine to the patient? No, right? So then what do? We identify something that breaks down the acetylcholine, right, to choline and acetate. What is that? Acetylcholine esterase. We block it. By blocking it, we can increase the duration of availability of acetylcholine. Simple. So same thing we can apply here as well. So with the research, we have found out that the natriuretic peptides like ANP, BNP that are produced in the body, they are broken down to inactive peptides by an enzyme called as neprilysin or neutral endopeptidase. So if I block this, I can increase the ANP and BNP activity. I can make the patient pass more urine, lose more sodium, lose more water, cause vasodilation, and reduce the burden on the heart. So that's why if you look at your pharmacology books and look at the drugs used for heart failure management, it's like RAS blockade, ACE inhibitors or ARBs, spironolactone, and neprilysin inhibitors, right? Clear? So now that we know the pathophysiology, let me quickly jot down the diagnosis and then management. Diagnosis and management. So in the diagnosis, just write simple, keep it plain and simple. The diagnosis is based on signs and symptoms of heart failure plus elevated BNP or pro BNP levels. And if you want, you can highlight the BNP or pro BNP level. They are considered as the biomarkers for heart failure. Biomarkers for heart failure. Clear? Now that we know about the diagnosis as well, let us talk about management. Okay, I will keep the management simple. I will not get into the goal directed management now because it's for the theory exam. So what is expected from you on a written answer for heart failure? Number one, treat underlying cause. If there is ischemic heart disease, like if someone presented with MI and that has caused heart failure, do an angioplasty, open the blocked blood vessel, re-establish the blood flow. Hopefully some amount of myocardium starts functioning again, ejection fraction improves, and the symptoms of heart failure will come down. So treat underlying cause for sure. Okay, apart from that, what else you need to do? Pharmacotherapy. And when it comes to pharmacotherapy, the first thing I want you to write is ACE inhibitors or ARBs. Why? Because RAS is harmful, we are blocking them. Second, I forgot to actually address one more important point. The decreased BP also leads to activation of sympathetic nervous system. And sympathetic nervous system mainly brings adrenaline, noradrenaline, right? So they also cause vasoconstriction. So don't you think that's also harmful? That needs to be blocked. How do I block it? Beta blockers. Beta blockers for blocking the sympathetic nervous system. Third, I can give spironolactone to block aldosterone because it's part of RAS and that is harmful. Okay. Fourth, very important, your examiners are keenly looking for this in your answer. New class of drugs, nothing to do with cardiology directly. They were introduced as antidiabetics, but studies have shown that they reduce the cardiovascular mortality in IHD as well as heart failure patients, and they are beneficial. And what am I talking about? Antidiabetic drugs? Yes. SGLT2 inhibitors. Good. SGLT2 inhibitors. So these are the standard drugs used for heart failure patients. Apart from that, we can consider ARNI. ARNI. So what ARNI refers to? ARNI refers to angiotensin receptor plus neprilysin inhibitors. Means a combination of drugs that inhibit angiotensin receptor, that is ARB, right, plus neprilysin as well. Currently, the one combination that is available in India, and you should write it, is valsartan. Valsartan is an ARB, as you know, plus sacubitril. Sacubitril is the neprilysin inhibitor. Is it for all heart failure patients? No. So you can mention that it is for heart failure with reduced ejection fraction with EF less than 35%. Normally less than 40% is how we define as heart failure with reduced ejection fraction. But if EF is less than 35%, then we have to give ARNI instead of just AC inhibitors or ARPs. If it is 35% plus, then you can just try to manage with AC inhibitors or ARPs. Okay. Now that's about pharmacotherapy. Remember one standard point mainly for your Viva OSCE discussion. They asked you which drugs are known to increase cardiovascular mortality in heart failure. That includes inotropic agents like digoxin and milrinone. They generally increase the mortality because they are burdening the heart. They are improving the symptoms but burdening the. Okay, so that's for your Viva OSCE. No need to write in a theory exam. Okay, now advanced treatment. This is what some of the university papers include, like define heart failure, discuss classification, diagnosis and management, write a short note on the advanced management of heart failure. So what else we have, like despite these medications, if the condition progresses, what else we can offer? So one of the things we can offer for these patients is ICD. ICD, you know, it stands for implantable cardioverter defibrillator and cardiac resynchronization therapy. Cardiac resynchronization therapy. Okay, I'm not discussing the indications, contraindications and all right now. It's only for the MCQ exam. For the theory, just write it. See, I'll tell you the logic behind this. The most common reason why patients of heart failure die is not hypoxia. Many of them die outside of the hospital because of development of ventricular tachycardia and ventricular fibrillation. So lower the ejection fraction, higher is the risk of developing VT and VF. So to prevent that, we implant a defibrillator so that if they develop a VT or VF, it will shock and correct it. And some of them may be having left bundle branch block. And that left bundle branch block disturbs the synchrony between right ventricle and left ventricle. So we try to bring that synchrony back by using a pacemaker-like device. We call it as cardiac resynchronization therapy, right? For now, as long as you remember this much, it's enough. Second is, we have something called as left ventricular assist device. It stands for LV, left ventricular assist device. So if your left ventricle is not able to eject the blood, we will hook it to a device, means a tube connected to left ventricle that will take the blood from the left ventricle, and we will not ask the left ventricle to eject it. We will make this tube to eject the blood into the aorta. It's like, let us say this is aorta and this is left atrium, this is left ventricle, as you know. So what I will do is, I will connect a tube between left ventricle and aorta, which is now connected to a pumping system. So what this will do is, once the blood comes to the left ventricle, this system or this device will take it and it will pump the blood into the aorta. So left ventricle's job is eliminated. It's called as left ventricular assist device. If you Google, you will be able to see beautiful images of this. On YouTube, there are influencers who are living with left ventricular assist device. They often keep posting their updates. Okay, and one more solution we can offer for these patients of heart failure is cardiac transplantation. This heart is failed. If someone gives you another heart, good. Of course, people will say, I'll give you the heart, but nobody gives. A living person, of course, cannot donate a heart. It has to be a brain dead individual. Then we can do a cardiac transplantation, right? So this is about heart failure, right? So I'm quickly giving you the summary, the points that you need to mention. The conceptual definition you should write: impaired ventricular filling or ejection. Technical definition: heart failure ke symptoms and elevated biomarker like elevated NT-proBNP. Classification: right versus left, and then also write the classification into reduced and preserved ejection fraction. Numbers are important. Don't jumble the numbers. Keep that clearly mentioned. Pathophysiology basically mentioned that one side stroke volume decreases, other side atrial pressure increases. Decreased stroke volume activates RAS and sympathetic nervous system, and atrial pressure increasing activates ANP-BNP. ANP-BNP is beneficial, so we want to increase their action by inhibiting neprilysin. RAS and sympathetic nervous system are harmful, so we block them with ACE inhibitors, ARBs, aldosterone receptor blockers, spironolactone, and the beta blockers. Okay. Now the next topic that I'm going to discuss is cardiomyopathy. Define cardiomyopathy, describe different types of cardiomyopathies, right? So we'll follow the same template that I followed so far. Here they are directly asking definition. So let me begin with definition. Even if there is no definition, I would like you to write 1 or 2 sentence introduction to make the entry into the answer beautiful. Okay. So what is cardiomyopathy? Myo means muscle, cardio means heart muscle, pathy means pathology. It's simple, right? So the pathology of heart's muscle. Now, can I say yesterday we discussed about aortic stenosis. There we had concentric LVH. What is getting affected? Muscle. Left ventricular hypertrophy. Muscle is hypertrophy. So can I call that as cardiomyopathy? So today also we discussed about concentric hypertrophy because of hypertension, pulmonary hypertension on the right side. Can I say that the ventricular hypertrophy should be called as cardiomyopathy? No. Then what is cardiomyopathy? Okay, another example. If I have ischemic heart disease and blood supply to a ventricular muscle area is down and that muscle dies. Who died? Muscle died. Muscle pathology. Can I call that as cardiomyopathy? No. If muscle dies because of lack of blood supply, that is ischemic heart disease. If muscle becomes hypertrophied because of a obstruction or valve problem, it's a valvular heart disease. We will not call them as cardiomyopathies. The muscles change is just a remodeling or a manifestation of the other major pathology. But what if the muscle becomes atrophied or hypertrophied without such causes, without coronary artery disease, without the obstruction or valvular heart disease? Then we will call it as cardiomyopathy. So the definition is disorders of cardiac muscle in the absence of ischemic heart disease, valvular heart disease, and hypertension, including pericardial disease and hypertension. Then we will call it as cardiomyopathy. So if the muscle gets affected without hypertension causes the LVH, that's hypertensive heart disease. Aortic stenosis causes LVH, it is valvular heart disease. Ischemic heart disease causes dilatation of the left ventricle, it is ischemic heart disease. But nothing of this is there, but still either heart is dilating or becoming hypertrophied or it's not able to relax. Something is wrong with the cardiac muscle, but these problems are not responsible. Then we will call it as cardiomyopathies. Now, how do we classify cardiomyopathies? The cardiomyopathies are classified into 3 major groups. So what are those 3 major groups? The first one is dilated cardiomyopathy or DCM. The second one is hypertrophic cardiomyopathy or HCM. And the third one is restrictive cardiomyopathy or RCM. Okay, hypertrophic cardiomyopathy and the dilated cardiomyopathy are very common. Dilated cardiomyopathy is most common clinically apparent cardiomyopathy, and hypertrophic cardiomyopathy is overall most common cardiomyopathy, though patients are asymptomatic and they are not usually diagnosed. That's why I don't say clinically apparent. Restrictive cardiomyopathy is relatively rare. Okay, here only I want you to know one important point. The restrictive cardiomyopathy mainly affects right ventricle more than left ventricle. Hypertrophic cardiomyopathy affects left ventricle more than right ventricle. Dilated cardiomyopathy also affects left ventricle more than right ventricle. So you can think of it like this. The dilated and hypertrophic cardiomyopathy are diseases of left ventricular muscle, and restrictive cardiomyopathy is mainly a disease of right ventricular muscle. Okay, clear? So you can mention this as the most common cause, and most common cause for clinically apparent cardiomyopathy. So we will begin discussing first the dilated cardiomyopathy. What do I mean by dilated cardiomyopathy? So when your left ventricular dilatation happens, usually ventricles dilate because of the increasing volume or pressure inside them. To compensate for the volume increase in the ventricle or pressure, they dilate. That's what we learned, right? Boyle's law. But if ventricle dilates in the absence of any increase in preload, afterload, any increase in volume, no obstruction, no problem, but still it just goes on dilating, then we will call it as dilated cardiomyopathy, right? So left ventricular dilatation in the absence of IHD, valvular heart disease, and hypertension. So what can cause left ventricle to dilate? Basically, it is because of the atrophy of the left ventricular muscle that it is dilating, and if it is atrophying, the force of contraction is going to come down. So they will present with impaired ejection. So basically, that's a form of heart failure. The causes wise, the most common cause is a toxin, and that is alcohol. Alcohol. So some of you may be planning that, okay, sir, exam khatam, last day of the exam, I'm gonna drink nicely. So be informed that every drink that you consume is taking you a millimeter closer to development of dilated cardiomyopathy. So if you keep accumulating alcohol-induced myocardial injury, eventually one day you will have dilated left ventricle, right? So think about it. Alcohol is the most common cause. It can also be familial or inherited. And when it is familial or inherited, the most common mutation responsible is mutation in a gene called as titin. Titin is coding for the gene is called TTM. The protein is titin. Titin is a muscle protein. Apart from that, other toxins are also known to cause dilated cardiomyopathy. That includes cocaine, a natural upgrade from alcohol for many people, right? Cocaine is also going to cause dilated cardiomyopathy. Okay, what else I can quote here? The peripartum or puerperal cardiomyopathy that we call is also a form of dilated cardiomyopathy. So the list can go on and on and on. Like hemochromatosis is one more. You don't have to write an elaborate list. What is expected from you is you should mention alcohol, you should mention familial, you should mention cocaine. Drugs is something that you should mention. And when it comes to drugs, cardiotoxic drugs like doxorubicin, basically cancer chemotherapy drugs, daunorubicin. And I'll tell you a hack that many of students used to use during my days is like keep writing all these chemotherapy drugs as the causes for dilated cardiomyopathy. Your teachers will not be able to question you or refute, because most of the chemotherapeutic agents, there will be some or the other published study saying that there are at least case reports of patients presenting with heart failure or dilated cardiomyopathy. But at least the minimum expected from you is doxorubicin, daunorubicin. If some other drugs come to your mind from the chemotherapy, omit it. Teachers may not object to it. So these are causes. Now, what are the clinical features that I'm expecting in dilated cardiomyopathy? The clinical features are basically the left ventricle dilates because of the atrophy or thinning of the left ventricular muscle mass. So its force of contraction comes down, ejection comes down, stroke volume comes down. You have the same symptoms of heart failure. So you can write the clinical features similar to left heart failure. Basically, the patient present with left heart failure. Remember, in heart failure itself, I mentioned that dilated cardiomyopathy can present as left heart failure. So it's like a patient presents with left heart failure. We will think of hypertension, IHD, dilated cardiomyopathy, hypertrophic cardiomyopathy. These are the causes. I will investigate to find out the cause. And if I do coronary angiography and it does not show any IHD, and BP is recorded and it's not suggestive of hypertension, and the telltale signs of long-standing hypertension like LVH are not there, then I would come to the conclusion that okay, I may be dealing with dilated cardiomyopathy when LV is dilated and visible on the echocardiography. So in terms of management, again, for all cardiomyopathies, just mention two statements: treat underlying cause and treat heart failure. So treat underlying cause. What is the underlying cause? Alcohol is the most common cause, so try to do a de-addiction service for the patient, refer to a psychiatrist, let him try to come out of alcohol. That will help him. Plus right now he has got heart failure, so I have to follow the standard heart failure treatment, that is ACE inhibitors, ARBs, beta blockers, all of that, and if required, cardiac transplantation. So treat underlying cause and heart failure. So no specific treatment for dilated cardiomyopathy as such. Okay, next I will talk about restrictive and then we will go to the hypertrophic. So when we talk about restrictive cardiomyopathies, you have to remember only one thing here. Restrictive cardiomyopathy refers to restriction of ventricular filling. Now that restriction of ventricular filling can happen because of two things. See, I want to fill the blood into the ventricles, left and right ventricle, from right atrium to right ventricle, left atrium to left ventricle. And to fill that blood, ventricle has a prerequisite. What is it? It has to do isovolumetric relaxation and lower its pressure. Then only blood will move from atria to ventricles. Now, who can stop its isovolumetric relaxation? One thing that can stop its isovolumetric relaxation is pericardium. If pericardium is stiff and it's not letting the ventricle expand, it will restrict. And that condition we will call it as constrictive pericarditis. When pericardium restricts the ventricular filling, we call it as constrictive pericarditis. In fact, the term constrictive pericarditis is a misnomer. Pericardium is not constricting the ventricle. It's just becoming stiff, not letting the ventricle expand. The second thing that can stop the ventricle from expanding is ventricle itself. What if the muscle is stiff and it is not letting ventricle relax? So when muscle is the problem, not the pericardium, we will call it as restrictive cardiomyopathy. When muscle becomes a problem, one condition it can become a problem, not let muscle relaxes. If it is fibrosed, we term it as endomyocardial fibrosis. The endocardium that is lining inside and the myocardium both get fibrosed. So it is stiff. It's not a muscular tissue anymore. So it can't dilate well. Right? Then the other condition that can lead to the restriction of the muscle relaxation is, what if I load this muscle with substances that are not supposed to be there in the muscle? Then it may not be able to relax. So the cardiac muscle is not a storage organ. Your skeletal muscle is also a storage organ. It stores the glycogen. But what if I use cardiac muscle as a storage organ and I store glycogen here? Yes, your glycogen storage diseases, where we start storing the glycogen in liver, abnormal amounts and abnormal forms of glycogen in liver, and sometimes in cardiac muscle. So in your biochemistry, you might have studied that various glycogen storage disorders present with heart failure or cardiac myopathies, right? And it need not only be glycogen storage disorder, it could be lipid storage disorder, it could be other storage disorders like iron storage disorder, that's hemochromatosis. All of them, when the cardiac muscle is abused as a storage organ, which it is not, it may not be able to relax. And you have restrictive cardiomyopathy. So what you have to remember is storage disorders. That's it. Whatever storage disorders come to your mind, write down. Some of them may not be causing, but it's fairly okay. The teachers will still give you the decent amount of marks. So restrictive cardiomyopathy is basically impaired and it affects right side of the heart more than left, because the left side of the heart is quite muscular. So it takes larger amount of stuff to be stored in them to make them dysfunctional. The left ventricle, the right ventricle is not as muscular as left. So a minimal amount of storage and it loses its function. That's why right is affected more easily. So impaired right ventricular relaxation in the absence of, usually what stops the right ventricle from relaxing isovolumetric relaxation, it is the pericardium, that is constrictive pericarditis, in the absence of pericardial disease. Pericardium is stopping the right ventricle from relaxing, then it is constrictive pericarditis. It's not restrictive cardiomyopathy, right? So in terms of causes, you can mention storage disorders. Examples you can quote: glycogen storage disorders, hemochromatosis. Hemochromatosis can present with both dilated as well as restrictive cardiomyopathy. Then amyloidosis. So that is one. Another example we can mention is endomyocardial fibrosis. Endomyocardial fibrosis. I still have lag on your comments. So I might have missed some of your queries. Please don't hesitate. My Instagram ID is Dr. Santosh P. You can search for it and you can shoot a message on my Instagram, and I'll find time tomorrow or day after tomorrow and I'll reply to all of your queries. Okay. So these are the causes I wanted to mention. Storage disorders. If you can name some glycogen storage disorders, mention it. And then endomyocardial fibrosis. Okay. Now in terms of clinical features, they present with right heart failure. So what are the symptoms of right heart failure? You can elaborate. Raised GVP, hepatomegaly, ascites, perilectomy. You can elaborate. Management, treating the underlying cause. Means for some diseases we have treatment. Like for some glycogen storage disorders, enzyme replacement therapies are there. For some forms of amyloidosis, treatment exists. So if it is treatable, treat the underlying cause. If you don't have a treatable underlying cause, you have cardiac transplantation as a choice. Though the problem is, because if you're not solved the underlying cause, then even the transplanted heart may end up developing the disease. So that will also eventually develop restrictive cardiomyopathy. But at least for a few years, they can expand the survival of the patient. This is about your restrictive cardiomyopathy. Restrictive cardiomyopathy is what? Dilated cardiomyopathy is where without a clear cause, your left ventricle starts atrophying and dilating. Restrictive cardiomyopathy is what? Without a pericardial pathology restricting, the right ventricle fails to relax during diastole. Right? So here you will have impairment in right ventricular filling, resulting in reduced right ventricular stroke volume. So that is classical right heart failure. That to diastolic failure. Here it is systolic failure. The ventricle is atrophied and dilated. It fails to contract and eject the blood well. So they will have heart failure with reduced ejection fraction. Okay. The next one we have is hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy. Interesting topic indeed. So I want to begin by mentioning few important epidemiological points that your teachers are interested. It is most common cardiomyopathy overall, though most cases are asymptomatic. Most cases are asymptomatic. That's why among the diagnosed cases, what is the most common? Dilated cardiomyopathy. But if you screen the whole population, you will find out that hypertrophic cardiomyopathy is more common. How common it is? It affects 1 in 500 births. And this cardiomyopathy cannot be acquired. Your restrictive and dilated can be acquired. You want to dilate the heart, either you should be born with the titin mutation or other mutations, or you drink. You drink heavily and you will have dilated cardiomyopathy. Bada dil mil jayega. You want restrictive cardiomyopathy, either you have to be born with those glycogen storage disorders, or you can load yourself with iron and you will develop hemochromatosis and you may have restrictive cardiomyopathy. But hypertrophic cardiomyopathy is purely inherited. You can't acquire it. It affects 1 in 500 births. It is most commonly due to mutation in beta myosin. Titin mutation was responsible for dilated. Beta myosin heavy chain gene mutation is responsible for hypertrophic cardiomyopathy. So what happens in hypertrophic cardiomyopathy? You have a concentric type of LVH. Normally when we get concentric LVH, when there is increase in afterload, remember that. AC, PE. Afterload increase, concentric. Preload increase, eccentric. AC, PE. So in the absence of increased afterload, afterload increases when aortic stenosis, systemic hypertension, right? Those conditions. But those are not there. But still you develop concentric hypertrophy. It's like I have not gone to gym, but still I'm developing muscle. That's what is happening with the left ventricle. Concentric hypertrophy in the absence of increased afterload, like hypertension, aortic stenosis, coarctation of aorta and all. So what other points I want you to write here is, see, genetic, only one cause, that is beta myosin heavy chain mutation. And those who are born with this, slowly left ventricle start developing hypertrophy, concentric type of hypertrophy, and it will lead to some problems. We'll discuss about that. The point I want you to mention here is that the hypertrophic cardiomyopathy is the most common cause for sudden cardiac death in young individuals, and athletes. And I also want you to remember that the sudden cardiac death refers to the death because of a cardiovascular problem without major forewarning symptoms. It's like I had heart failure multiple times. I was getting admitted every second week, third week. Story was going on for last 1 year, and then I died. Now it's not sudden cardiac death. I went to sleep. Next day morning, family finds out that I'm no longer there. That's sudden cardiac death. And the sudden cardiac death, overall, the most common cause is MI or ischemic heart disease. Right? The story you hear that Dadaji went to sleep, and next morning when we went to wake him up, all his limbs were cold. He was not responding. Mostly he died because of a massive MI during the sleep. So ischemic heart disease is the most common cause for sudden cardiac death overall. But in young, where IHD is now increasing, but it's not still a leading cause. So in young people and athletes, sudden cardiac death mostly happens because of hypertrophic cardiomyopathy. Young individuals and athletes. So can anybody tell me what are the other causes for sudden cardiac death in young individuals and athletes? You keep hearing these stories, right? Like he was just 30, 25, died suddenly. Like a 25-year-old PG, did the ward rounds, and then he was in the nursing station writing the notes, he collapsed there and died. Hypertrophic cardiomyopathy is one cause. Yes. So you have other causes like the congenital long QT syndrome and arrhythmogenic right ventricular dysplasia. So the list goes on. Okay. So what happens here is patients slowly develop concentric LVH with asymmetric septal hypertrophy. So I'll tell you what exactly that means. So these people, like let us say that I'm looking at the left side of the heart. This is the left ventricle. This is aorta, and this is left atrium, right? This is how I usually sketch my heart. Here you will have the mitral valve. Here you will have the aortic valve. And in this ventricle, no, the part of the ventricle which leads into aorta, this part of the ventricle is called as left ventricular outflow tract. Left ventricular outflow tract. And this part of the ventricle where blood actually comes from the atria is called as left ventricular inflow tract. Okay. Now what is happening? Slowly these people are developing concentric hypertrophy. So inside the ventricle, the muscle mass gets added, making the ventricular cavity smaller. But then this hypertrophy affects the septum asymmetrically. Means if I do a septal hypertrophy symmetrically, this is how it is going to look like. Everywhere the uniform increase in the thickness. This is what is expected. This is what I see in most of the concentric LVH because of hypertension, aortic stenosis and all. But here the septum becomes asymmetrically hypertrophied. It usually hypertrophies more in the left ventricular outflow tract region. Hypertrophies more in the left ventricular outflow tract region. And because of this, it will create the obstruction of blood from LV to aorta. It will start obstructing, right? So what are the changes we are noticing here? One, we are getting concentric LVH with asymmetric septal hypertrophy, usually abbreviated as ASH or ASH. Usually abbreviated as ASH. And because of this asymmetric septal hypertrophy, it may lead to left ventricular outflow tract, that area where blood actually moves out from LV to aorta, getting obstructed, left ventricular outflow tract obstruction. And whenever it results in left ventricular outflow tract obstruction, that time when it causes obstruction, I will call it as HOCM. So what HOCM refers to? Hypertrophic obstructive cardiomyopathy. So HOCM is not a different disease per se. It is just an extended version of hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy, where the septal hypertrophy has resulted in obstruction of blood from moving from left ventricle to aorta, then we will call it as HOCM. Okay. So they are not two different entities. Okay. So that's why in many of your MCQs, the most common cause for sudden cardiac death in young individuals and athletes is mentioned as HOCM. They are often used interchangeably by authors. Okay. And this hypertrophied ventricle becomes prone for ventricular tachycardia and ventricular fibrillation. So these deaths that I mentioned are generally due to VT or VFib. Okay. Now, when it comes to its diagnosis, it may lead to obstruction, and once it leads to obstruction, I will have obstructive symptoms. That is nothing but, once there is obstruction, right, you can call it as, it is similar to aortic stenosis, right? Do you agree? In aortic stenosis, what happens? This opening is narrow, so I'm having difficulty to push the blood into the aorta. Here that opening is fine, but below that there is an obstruction. So can I call it as subaortic or subvalvular aortic stenosis? Same like AS, but the problem is below the valve, not at the level of valve. So we'll call it as subvalvular AS. It's also known as subvalvular AS if it causes HOCM. Okay. So for the diagnosis, patients who haven't yet developed HOCM, they may not be symptomatic. Once they develop HOCM, they will have the same symptoms as aortic stenosis. So then how do I diagnose? Ideally, all athletes and young individuals who are into adventure sports should be screened for this to prevent those sudden cardiac deaths. So for diagnosis, the investigation of choice is going to be echocardiography. And echocardiography is going to show some findings. So what are those findings? Number one, you will have concentric LVH. And because the left ventricular muscle mass is high, the force of contraction increases, ejection fraction increases. Ejection fraction will decrease only when HOCM develops, where I start obstructing, so I will not be able to eject sufficient. But before that, before the obstruction, only when I had little hypertrophy, I will have good ejection fraction. Ejection fraction may be increased, maybe more than 70%. Okay. Third, asymmetric septal hypertrophy, ASH or asymmetric septal hypertrophy. Okay. One more change you notice is on this interventricular septum, you will have a papillary muscle with a chordae attached to the anterior mitral leaflet. So now that this interventricular septum is more muscular, it contracts with more force, and that forceful contraction pulls this anterior mitral leaflet down during systole. Normally the contraction force is sufficient enough to keep the leaflet in position so that it does not open in opposite direction, but now the force is increased, it pulls it down, and we will call it as systolic anterior motion of the mitral leaflet, or SAM. SAM stands for systolic anterior movement of mitral valve leaflet, or anterior mitral leaflet, movement of anterior mitral leaflet. These are important terms that teachers are looking for, that is asymmetric septal hypertrophy and systolic anterior motion. And now if you look at this ventricle, because of this asymmetric septal hypertrophy and concentric hypertrophy, the ventricle shape kind of looks like a banana, right? This looks like a banana fruit. So we will also mention it as banana shaped ventricle. Banana shaped left ventricle. So these findings help us to diagnose the case as hypertrophic cardiomyopathy. Now that we have diagnosed it, how are we going to manage? So there are two things. Number one, to prevent, because these people are at risk of sudden cardiac death due to VT and VF. To prevent VT and VFib. And second, if HOCM develops, how do I relieve the obstruction? So to prevent VT or VF, we can use beta blockers. And second, we can use implantable cardioverter defibrillators. Apart from that, in a bedside discussion, do mention, or you can here also you can write, we advise these people to avoid vigorous exertion. So vigorous extreme sports and all, because the exertion activates sympathetic nervous system that increases the chance of developing VT and VF. So they are already prone. Physical activities give that boost and VT VF happens and they can die. So they should avoid vigorous exertion, though they should do modest exercises, not like be lazy and just lie down, because you also need to condition the heart's other chambers and muscles and your metabolic health. But vigorous exertion should be avoided. And further, if at all some vigorous exertion happens and they are prone to develop VTVA, we should give them beta blockers or ICD. If they develop HOCM, there are some pharmacological drugs available, but what is expected from an undergraduate student in the management is basically the key management, definitive management is cutting this obstructing part of the muscle. How can I cut it? Either through the surgical mode, cut this and remove. If I cut this and remove, we'll call it a septal myomectomy. From where I'm cutting? Septum. What I'm cutting? Muscle. So we'll call it a septal myomectomy. That is one choice. So if I cut this part of the muscle, the obstruction is relieved. Now the blood can easily move. So HOCM is sorted. The second option is, instead of doing this invasive surgery, I can introduce a catheter or wire into the heart and inject alcohol into this part. Alcohol causes atrophy of the cardiac muscle, and that's why you're developing dilated cardiomyopathy. Whenever you drink, your cardiac muscle starts atrophying and you will end up with dilated cardiomyopathy. So we know that from the DCM. We will use that knowledge here. Inject alcohol into this septum and it will get atrophied. Now we have even more advanced. We can induce atrophy of this with the help of laser also. We will call, when we use alcohol or laser for inducing the atrophy of the asymmetrically hypertrophied septum, we will call it as ablation, laser or alcoholic ablation. So if there is HOCM, the choices of treatment we have is septal myomectomy, that is surgically cutting the muscle, or alcoholic or laser ablation, right? So these are the choices we have. So that completes our discussion on the cardiomyopathies. So again, key points that teachers are looking for is, for the dilated cardiomyopathy, you should mention that it is left ventricle which is getting dilated. Presentation is similar to heart failure. Management is treating underlying cause and similar to heart failure. Causes wise, you should mention alcohol, titin mutation, cocaine, maybe some pharmacological drugs. Restrictive cardiomyopathy, it's all about storage disorders. One additional thing, endomyocardial fibrosis. You should mention it affects right side of the heart more. Symptom wise, mention right heart failure symptoms. Management, treating the underlying cause, cardiac transplantation. Hypertrophic cardiomyopathy, all the points that we discussed, teachers are expecting. You should mention the beta myosin heavy chain gene inherited. You need not mention the prevalence, but at least inherited mutation in beta myosin heavy chain gene, where LVH develops in the absence of increased afterload. Most common cause for sudden cardiac death in young and athletes, and it may eventually lead to left ventricular outflow tract obstruction. In that case, we call it as HOCM. Diagnosis, echo. You can also screen for the beta myosin heavy chain gene mutation, but echo is what we generally use in India. Echo findings, main thing teachers are looking for is asymmetric septal hypertrophy and systolic anterior movement of anterior mitral leaflet. Management, to prevent sudden cardiac death. Sudden cardiac death happens due to VT and VF. So to prevent sudden cardiac death due to VT and VF, we should ask them to avoid vigorous exertion, beta blockers, ICD, and if HOCM ever develops, septal myomectomy or alcoholic or laser ablation, right? So that's what I had for the part 2 of cardiology. Now, what are the other topics from cardiology? Let me mention important questions that I want you to do from the Furray notes available on the MEDED. So the first one is the systemic hypertension. It's a pretty simple pharmacology based question. Second thing I want you to do is cardiac tamponade. Third thing I want you to do is constrictive pericarditis. And the fourth thing is ischemic heart disease. So these are the major questions that we're expecting from the cardiology on the theory exam. And from the clinical corner, what are the important topics that I want you to do? I've already addressed the key questions that your teachers might ask on AS, MS, heart failure, cardiomyopathies. But of course, you need to know the approach. So I want you to do dyspnea as a symptom. Okay. Then in the dyspnea, I definitely want you to be familiar with orthopnea, PND, right? Whatever history you need to elicit. Then heart failure as a case. Then valvular heart diseases. Heart diseases. Okay. Then the other major, see, most of your major cases from cardiology are going to be valvular heart diseases or heart failure, be it right heart failure or left heart failure. Okay. Some usual discussion during bedside often spills into peripartum cardiomyopathy. You may find it in your OBG section. So if not, let me know. I will share a quick note on the Instagram and you can use that for knowing basics about the peripartum cardiomyopathy. So these are the important things that I want you to do from the clinical corner. You should know the approach to dyspnea. You should know the approach to heart failure. You should know the areas of auscultation, different types of murmurs, and the presenting symptoms of all the valvular heart diseases, and a little bit about peripartum cardiomyopathy. I forgot to mention another important thing, though unlikely to be kept as a case. Unlikely to be kept as a case because it's a bit difficult to find the cases nowadays on rheumatic fever, but often discussion spills. If it is a valvular heart disease, somehow teachers go to rheumatic fever, and it may also be a 10-mark theory question. We will be talking about some of the important questions from infectious diseases and the hematology. Well, first let me list what are the important topics from this so that you don't miss out anything, because given the time available, I will not be able to cover all the important questions from ID as well as hematology. But from infectious diseases, according to me, the most important topics are HIV, dengue, tuberculosis, malaria, and leptospirosis. Malaria and leptospirosis. Some of the universities have also seen frequently asking a long question on enteric fever. So as long as you cover these, you're kind of sorted for infectious diseases. And today I will be addressing two of them, HIV and dengue, from the infectious diseases. The remaining questions you can do from the further section of the MEDED. And from the hematology, of course, you know that anemia is the most frequently asked long question. So from hemat, mostly you can expect questions on anemia, clinical features, evaluation, management, and might be asking you to give a detailed description of a subtype, either iron deficiency anemia or B12 deficiency anemia. And then leukemias is likely to be a long question. Lymphomas are likely to be a long question. And leukemias, sometimes a specific subtype may be a long question, like AML, CML, ALL, or CLL. And lymphomas, you have the Hodgkin's lymphoma and non-Hodgkin's lymphoma. Any of them can be independently asked as long question. Okay. So today from the hematology section, we will concentrate on leukemias. We'll try to cover AML and CML. If time permits, we will go beyond that as well. Okay. But anyway, all these questions are there in the further section, and you can definitely go through the further section to cover whatever questions we're not able to address today. Okay. So let us first start with the infectious diseases, and the most important question from the infectious diseases is going to be on HIV. The structure of the question may go something like this. write a short note on HIV and its complications, explain immune reconstitution, inflammatory syndrome, and current management of HIV. Okay. Now, the first point, many universities have started asking clinically oriented questions or a clinical STEM story, and then asking you to diagnose based on the story and then you elaborate further. So if the question is about the HIV, most likely, if it is clinically oriented, most likely it will go like this. A person with promiscuous behavior or high risk sexual behavior. Sometimes in the past, questions used to mention a particular profession. Of course, I do not want to comment about it now, but at least high risk promiscuous or high risk sexual behavior, or visit to commercial sexual workers, or IV drug abuser. That is how the story begins. After that, they may elaborate some symptoms pointing towards one of the opportunistic infection of HIV. So from there, you get to know that this is the question about HIV, and then you can elaborate further. Okay. So what is HIV? HIV is a virus, of course. It's a single-stranded RNA virus which belongs to the Retroviridae. What is the mode of transmission? There are several modes of transmission. Among the modes of transmission, the highest risk of acquiring HIV infection is through blood transfusion. Apart from that, it can also be transmitted through the sexual route, and we know that the most common route of transmission reported worldwide is through sexual contact with an infected individual. Apart from that, needle prick can also cause, but one should remember that the risk of transmission through solid needle prick is very less. So it is usually less than 0.3%. That means if 1,000 people get pricked by a needle which was already pricked to an HIV positive individual, 3 of them may turn positive. The remaining 997 do not get the HIV. So this is about the mode of transmission. Highest risk is with blood transfusion, sexual route, needle prick. We forgot to mention one more, the mother to child transmission. Mother to child transmission or parent to child transmission. So these are the modes of transmission for HIV. Now, when someone gets infected with HIV virus, what all clinical manifestations it can lead to? So HIV has a natural course of illness. So once there is an HIV infection, usually 2 to 3 weeks after acquiring the HIV virus, some patients, I'm not saying all the patients, usually less than 50% of patients develop something called as acute HIV syndrome, and another 50% or more patients will not develop any of them. So they directly go to become what we call as chronic HIV infection. So today, if I inoculate HIV virus in somebody, in a group of people, 50% or lesser than that will develop an acute illness. Remaining 50% don't develop any acute illness. They directly become chronically infected. Those who develop acute illness, we will call it as acute HIV syndrome. What is it? It's nothing but an acute febrile illness. Means, and just like how you get viral fever or enteric fever, this also looks like a febrile illness. When does it occur? Usually occurs 2 to 3 weeks after the infection, and quite rare after 1 month of acquiring the infection. So during this period, the HIV virus starts targeting the CD4 cells. So CD4 cells start going down during this period, and it's just 2 to 3 weeks after the infection. So body hasn't mounted an immune response yet, or a strong immune response is not mounted yet. So you don't detect any antibodies against the virus. Patient has got infection, virus is replicating, virus is targeting the CD4 cell, but you don't get any evidence on the conventional immunological studies. Body hasn't produced IgM antibodies yet, IgG antibodies yet. So if you go by any IgG or IgM antibody tests, they will turn negative. So then if I have to diagnose this in the acute phase, how can I diagnose? Only P24 antigen of the HIV may be detectable during this period. Okay, or you can also do the HIV PCR, which may be positive, but there will be no antibodies during this phase. Okay, and what are the clinical features of this acute HIV syndrome? It resembles infectious mononucleosis. Means in infectious mononucleosis, patients often have fever. They will have fever. Then they may have sore throat or throat pain. They may have tender lymph nodes. tender lymphadenopathy. And apart from that, a good number of the patients may develop a rash. So it is basically a fever with rash occurring in less than 50% of the patients. Remaining 50% of the patients, they don't get to know that they have got infected with the HIV. Okay. Now, regardless of whether they experienced an acute HIV syndrome or not, eventually all patients who got infected with HIV will enter into a chronic phase. Now, what happens in this chronic phase? In the chronic phase, serially, see, acute HIV syndrome, you had all this fever, lymphadenopathy and all, it all settles, right? And after that, it's a phase of quiet, means no other major symptoms are there. So during this period, majority of the patients are generally asymptomatic. So if patient did not have acute HIV syndrome and he has entered the chronic phase, he will not be even aware that he has got HIV virus in him. So majority of them are going to be asymptomatic. Some of them may have generalized lymphadenopathy. Because in the lympho-reticular system, the HIV viruses are replicating. So some of them may have generalized lymphadenopathy. But again, only if a doctor examines for the generalized lymphadenopathy, it will be detected. Otherwise, they may not have any evidence that they have got infected with HIV. But during this chronic phase, the antibody production would have started and you can start doing the antibody tests to detect the HIV infection. But during this period, unknown to the patient, silently the CD4 count progressively decreases. And when the CD4 count goes catastrophically low, generally less than 200, patients develop significant opportunistic infections. And when the CD4 count goes less than 200 and patients develop major opportunistic infections that we call as AIDS defining illnesses like cryptococcal meningitis, then we will call that condition as an advanced HIV or the yesterday's term called as AIDS. So where you will have CD4 count less than 200 or what we call as AIDS defining illnesses. So what is the natural course of HIV? HIV infection happens, then patient HIV starts incubating. Some patients may manifest with an acute febrile illness resembling infectious mononucleosis 2 to 3 weeks after the infection. Majority patients don't even manifest that. So whether you had an acute febrile illness or not, eventually enter into chronic phase. During this chronic phase, HIV starts replicating. So the HIV viral load goes on increasing. The CD4 cell count goes on decreasing. And when CD4 cell count becomes critically low, generally less than 200, you start seeing major opportunistic infections. And once that happens, we will call that as AIDS. So this is the natural progression of HIV. Now, what systemic manifestations HIV can produce? Because when we talk about HIV, we say it is the modern days great mimicker. It can mimic like various other disorders. That means it affects multiple organs, right? So what all organs get affected by HIV? I'm not only talking about opportunistic infections. HIV itself is organ toxic. Means HIV virus itself can cause damage to various organs apart from opportunistic infections. So when it comes to the cardiovascular system, HIV accelerates the atherogenesis. And because of this accelerated atherogenesis, and HIV also causes endothelial injury, there is increased risk of coronary artery disease. Coronary artery disease. So a lot of older generation HIV patients who did not develop major opportunistic infections still died early because of the coronary artery disease. In fact, the coronary artery disease is the most common serious complication of HIV. Means cardiovascular complication, the most common cardiovascular complication of HIV is going to be development of coronary artery disease, which is due to accelerated atherosclerosis. And it is also partly contributed by a side effect of various antiretroviral drugs which are known to cause dyslipidemia. What else it can cause? The HIV also causes HIV cardiomyopathy. So what is this? It's nothing but a form of dilated cardiomyopathy. So when we study about dilated cardiomyopathy, we study various causes like familial and all. And one of those causes is also HIV infection, and this dilated cardiomyopathy may lead to heart failure. Okay. Now, will HIV affect the central nervous system? Yes. So HIV increases the risk of cryptococcal meningitis or fungal meningitis, in other words, you can say. And not just that, HIV also increases the risk of developing tuberculosis. So there is also, you can say, increased risk of TB meningitis. And apart from that, HIV virus is toxic to the neurons, and with progression of HIV and the viral replication, eventually the neurons start declining in number, and you end up with what is called as, older times we used to call it as AIDS dementia complex, or today we call it as HIV encephalopathy. So HIV is affecting heart, it is affecting brain, and when it is affecting brain, it is causing severe dementia. Okay. Will HIV affect kidneys? Yes. It causes something called as HIV associated nephropathy. Or HIVAN. So technically, what is it? It is nothing but a form of focal segmental glomerulosclerosis, and it presents usually as nephrotic syndrome. It presents usually with nephrotic syndrome. Particularly more common in Africans infected with the HIV. Okay. What GIT manifestations I can expect in a patient with HIV? First of all, there is increased risk of oral and esophageal candidiasis, one of the very common complication of HIV. Increased risk of oral and esophageal candidiasis. And HIV is also known to cause something called as HIV enteropathy. So what is this? There is also increased risk of opportunistic GIT infections. Apart from that, there is something called as HIV enteropathy. So particularly these pathies you need to mention: HIV encephalopathy, HIV enteropathy, HIV cardiomyopathy. So what is this HIV enteropathy? It's a form of chronic intestinal inflammation without any other opportunistic infection, purely caused by HIV. And how these patients present? They present with chronic diarrhea. Yesterday we defined what is chronic diarrhea, right? What is chronic diarrhea? Diarrhea of more than 4 weeks with negative workup. What do I mean by negative workup? Means you have evaluated for underlying cause and everything turned out to be negative. Patient doesn't have tuberculosis, amoebiasis, or tropical sprue, or any of these common causes for chronic diarrhea, IBD, all of them are ruled out. Patient is HIV positive, he has chronic diarrhea, and we are not finding any cause. Then we call it as HIV enteropathy. Okay. Then skin. So more than 50% of HIV patients have seborrheic dermatitis. They have seborrheic dermatitis. And they also have T-cell leukemias infiltrating the skin. So these are all common manifestations of organ involvement in HIV. This is a very brief list. It's not an extensive list. In a prof exam, if you are able to write these many, is more than enough. With the time available for you to write an answer sheet, this is more than enough. Okay. But I definitely also want you to write a small table mentioning important opportunistic infections, because CD4 count as declines, the risk of opportunistic infections goes on increasing. So what are the important opportunistic infections? Well, the first thing you have to mention here is the most common opportunistic infection in HIV. Most common opportunistic infection in HIV. So the Samantha, dermatitis herpetiformis, it's there in the name. It's dermatitis, means skin inflammation. Herpetiformis is called because you get those herpes-like lesions on the skin, means small vesicular and pustular lesions, which is usually encountered in patients with celiac disease. Okay, the most common opportunistic infection in HIV is tuberculosis. Okay. So first of all, seborrheic dermatitis, yes, it's a very common skin condition, but it is more frequently encountered in HIV patients. More than 50% of HIV, like I would say that many times when HIV patients walk into the OPD, especially those who are not yet started on the antiretroviral drugs, when they walk in the OPD itself, most of the doctors sense that there is something wrong with the patient, and that's related to the appearance, and partly that's because of the extensive seborrheic dermatitis, like face everywhere there is dermatitis and peeling. So it is more extensive in an HIV individual than a normal seborrheic dermatitis patients, but the only way you can differentiate is by testing for the HIV. Okay, so tuberculosis is the most common opportunistic infection in HIV patients. Okay, now these opportunistic infections do correlate with the CD4 count. So when CD4 count is more than 500, the risk of opportunistic infection is very minimal. So they are prone to infections as much as a normal individual is prone. But once it drops below 500, tuberculosis starts, like the risk of tuberculosis increases. And when it is less than 200, especially the respiratory system gets affected by pneumocystis jirovecii. We used to call it as the pneumocystis carinii. So pneumocystis jirovecii infection, GIT infection by Cryptosporidium, or oral candidiasis, or fungal pneumonias, including cryptococcal pneumonias, occur when the CD4 count is less than 200. But when it drops below 100, you can develop the CNS toxoplasmosis, then the esophageal candidiasis, or CMV esophagitis. And when it is below 50, you can develop the cytomegalovirus retinitis, cryptococcal meningitis, then infection by MAC or Mycobacterium avium complex, and even the primary CNS lymphoma associated with the Epstein-Barr virus. What are the important ones that your teachers are particularly looking for that you should remember? Tuberculosis, pneumocystis jirovecii, toxoplasmosis, cryptococcosis, Mycobacterium avium complex, and CMV retinitis. These are the ones you need to remember and replicate in the exam. Okay, so now we have a fair idea about HIV, right? HIV is a single-stranded RNA virus which usually gets transmitted through blood transfusion, sexual route, or mother to child, or through needle prick. The risk is least with the needle prick. And once they get infected, they may go through, like initially 2 to 3 weeks later, they may get a short period of fever and lymphadenopathy, sore throat and rash, or they may not develop any of this, but they get into a stage called chronic phase where the virus keeps replicating, the CD4 cell progressively keeps going down. So during this period, only investigations can diagnose. They may not have any symptoms, or some of them may have generalized lymphadenopathy. When CD4 count critically drops, that is where the problem starts. They start developing opportunistic infections. So we have already covered what are organ manifestations to expect and what are the opportunistic infections to expect. Now, once you recognize that this individual is going through what we call as HIV, how are we going to manage? Well, the more the virus replicates, more the destruction of CD4 cells, more the destruction of CD4 cells, more the complications. It's as simple as that. So what is the best way? Of course, the best way to treat is to get rid of the virus completely from the body. As of now, the currently approved drugs are not able to achieve that. They can only suppress the virus to almost non-detectable levels, which itself is a great achievement of medical research. And if I'm able to suppress the viruses to bare minimum levels, non-detectable levels, then the CD4 cell destruction stops. And once the CD4 cell destruction stops, the immune system bounces back, and the risk of all these opportunistic infections come down. So that's why we have to treat all HIV patients with antiretroviral drugs. When I was an MBBS student, there were some indications for starting ART. So all patients detected with HIV. So today, a lot of HIV patients get detected even with the acute HIV syndrome, because we could do P24 or HIV PCR. Remaining patients get detected in the chronic phase. So during my times, when we detect an HIV individual in the chronic phase, we were not directly starting with the antiretroviral drugs. So we used to wait for the CD4 count to drop below 200. But by that time, they would have already developed organ dysfunctions, or they would be at extreme risk of opportunistic infections, or they might have developed opportunistic infections. So today we don't wait for all those things to happen. The day you diagnose the case as HIV, you start antiretroviral drugs. And what is the currently recommended regimen? What is the currently recommended regimen? So NACO recommends TLD regimen. So you will have a single pill containing 3 drugs that they should take on a daily basis. 1 pill a day containing 3 drugs. So T stands for tenofovir disoproxil fumarate. Simple words, you can write tenofovir or TDF. L stands for lamivudine. And D stands for dolutegravir. And since the advent of dolutegravir, the outcome of HIV patients has improved significantly. So this is one of the best treatment we could offer for the HIV patients, right? So this is the standard preferred regimen. We call it as single tablet regimen or STR containing TLD, tenofovir, lamivudine and dolutegravir. Okay, but many times what happens is HIV patients, because by the time we detect, their CD4 count might have dropped below 500 and they might have developed a tuberculosis infection. So there comes the important question. What should I do if there is HIV TB co-infection? Should I start the ATT first or the ART first? The answer is ATT first. Why? So can anybody tell me why I am preferring to choose the ATT first instead of ART? Why not control the HIV infection first? Because there is risk of something called as IRIS. So what IRIS stands for is immune reconstitution inflammatory syndrome. This can be so severe that sometimes it can be life-threatening. This can be life-threatening. So what exactly happens here? So let us say there is an HIV patient, right? I'm just giving you a hypothetical example. So someone got infected with HIV, he got into chronic phase, and during this phase, his CD4 count started declining. The HIV viral load started increasing because HIV is replicating like anything. And then one fine day, his CD4 has, let us say, dropped to, let us say 100. Okay. And once his CD4 count is less than 100, he will certainly have opportunistic infections, and even before reaching the 100, he might have developed tuberculosis. So let us say he has developed pulmonary tuberculosis. If he was in India or Africa, definitely he would be exposed, or he was already having a latent TB infection. It gets reactivated once his CD4 count drops below 500. In this case, it's 100, so TB is definitely going to be reactivated. Now he has pulmonary TB. But this patient may not come to you with florid symptoms of TB. Why? Because most of the infections symptoms are related to inflammation. Like if I have meningitis, right, I will have headache, I will have nausea, vomiting, but they're related to inflammation of the meninges. But if my immune system is so weak that it cannot mount an inflammatory response, then all the inflammatory symptoms will be suppressed. I may have meningitis, but I may not have the headache and other symptoms. I may have some abscess, but I may not have fever. I may not have the redness and swelling of that side because my immune system is not able to mount an inflammatory response because it is that weak by the HIV infection. So the symptoms are masked, but still, okay, I diagnosed the HIV here and started ART. Once I start ART, what happens? The immune system starts reconstituting, right? Because the virus starts coming down, the CD4 count starts increasing, so immune system starts becoming stronger and stronger. And with that, we start seeing a strong inflammatory attack on all the sites where other opportunistic infections were there. So there will be worsening of the opportunistic infection symptoms. Like let us say I had cryptococcal meningitis. I wouldn't be probably having any meningeal inflammation. I have cryptococci causing the infection of the meninges, but signs of inflammation were not there. So there is no raised intracranial tension because meninges are not swollen. But once you start ART, immunity is bouncing back. It starts mounting inflammatory responses. Suddenly meninges start getting inflamed, swollen, intracranial tension starts raising. Patient will start projectile vomiting, decreasing sensorium, and severe rise in intracranial tension may kill him. Similarly, pulmonary TB, I may not have any symptoms, but once you start ART, my immune system reconstitutes and strong inflammatory response. So now I may even present with ARDS because of an intense inflammatory attack. So once the immunity reconstitutes, the inflammatory attack on the infected organs worsens. This phenomenon is what we call as immune reconstitution inflammatory syndrome. And to avoid getting into this, the first thing you should do is first start to kill the opportunistic infections. If I have pneumocystis carinii pneumonia, first I should treat that. If I have, let us say, TB, I should treat that. And then start the ART so that I am saved from iris, right? So that's why we are starting the ATT first. And then we are starting the ART. And once I have started the ATT, after how many days of starting ATT, then I can start ART? That's a question. And that depends on the CD4 count. If the CD4 count is less than 50, then I can't wait too long, because you may be able to avoid iris, but on the other hand, you are letting the virus replicate further and invite other opportunistic infections. So if CD4 count is less than 50, then within 2 weeks of starting ATT, I should start ART. But if CD4 count is more than 50, then maybe I can start after 2 months of starting the ATT, right? So iris, how do I manage iris? The iris can be managed by ATT first, if TB, then ART. Treat opportunistic infections first, and if life-threatening inflammation happens, you may consider giving steroids. You may consider giving steroids to suppress the inflammatory cascade. See, ART takes time to bring down the HIV. ART is not treating the opportunistic infection. See, remember here, you have opportunistic infection and HIV in your body, okay, and your immune system. Your immune system, whenever there is an infection, should mount an inflammatory response. Its job is to mount an inflammatory response against opportunistic infections. Okay, but unfortunately, your immune system is weakened by the HIV. Your CD4 count was low. That's why it was not able to mount the inflammatory response. So now you have opportunistic infections without inflammation. But once you start ART, HIV starts coming down. And HIV starts coming down, the CD4 count starts increasing. Your immune system becomes strong, and it starts mounting the inflammatory response for the presence of opportunistic infections. But that inflammatory response is going to cause organ infections, inflammation. So if I cause meningeal inflammation suddenly, intracranial tension increases. So same happens at various organs. So if there is an opportunistic infection in any organ, there will be intense inflammatory response against that. And that intense inflammatory response cause organ dysfunction, because once organs are inflamed, like lungs inflamed, that is ARDS, they are going to become dysfunctional, hypoxia, they can lead to death. So that's why when we suspect that there is a possibility of iris, we first treat the opportunistic infection. So if there is no source for triggering the inflammation, then there won't be inflammation. So first clear the opportunistic infection, which is a source for triggering the inflammation, and then start treating the HIV, right? That's the approach. Okay, so after the HIV, now let's go to our next topic, which is going to be dengue. So HIV is definitely a very important question. Many universities have asked it as a long essay, but then depending on which season of the year the exam is being conducted, many universities give emphasis on the dengue as well. Particularly if the exam is conducted beyond April towards May, June, a lot of universities conducting exam there, they start asking questions on dengue, right? So the question may go like this. Write a short note on dengue, describe danger signs of dengue, and elaborate on monitoring and management of dengue. See, HIV is an important question for university, but for every doctor, dengue is an important question. Whether your university paper asks something about dengue or not, you will definitely face a dengue patient once you complete your MBBS and start internship or start practice. So you should know everything objectively about dengue, right? So just like HIV, our answer will have a similar structure. We will mention what is the causative agent. We know that it is dengue virus. There are 4 subtypes of dengue virus, which we will label as dengue virus 1, 2, 3, and 4. Usually abbreviated as DENV1, DENV2, dengue virus 3, and dengue virus 4. And its mode of transmission, it is vector borne. And what is the vector here? The Aedes aegypti mosquito is the vector. And we all know that it is common during rainy season. Why is it common during rainy season? Because of course, wherever there is mosquito breeding, the risk of having these Aedes aegypti mosquitoes, and thus the transmission of dengue also increases. So typically we see majority of the dengue outbreaks happening during the rainy season. Okay. Now when someone gets infected by this dengue virus through the mosquito bite, what all clinical manifestations it will lead to? So just like HIV, the dengue also has a natural course of the illness. So once you get Aedes aegypti mosquito bite, virus is instilled into our body. For first 7 to 10 days, you may not see any signs or symptoms because the virus is incubating. So the incubation period of dengue virus is around 7 to 10 days. So after this 7 to 10 days, just like how HIV patients got into an acute febrile illness, at least some of them, dengue also gets into an acute febrile illness. So from day 1 to day 4, the patients will develop fever. So during this phase, means day 1 to day 4, day 1 of symptom to day 4, it's called as febrile phase, where fever is the dominant symptom. Before that, it is incubation period for 7 to 10 days after the mosquito bite. So during this period, patients develop high grade fever, very often 102 to 104 degrees Celsius or sometimes even higher. Along with that, musculoskeletal pain. And because there is musculoskeletal pain, which is very severe, in the past we used to call it as breakbone fever, right? Your teachers, especially your elder teachers, like to hear this word breakbone fever. Breakbone fever. Okay. Apart from that, they may have abdominal pain and generalized malaise, nausea, vomiting. These are the common symptoms. So it resembles like any other acute febrile illness, right? At this stage, without investigations, you can't tell whether it is malaria, enteric fever, dengue, or any of the other infections. Okay. And this day 1 to 4 is not actually the major problem. Patients feel the symptoms are bothersome. So patients are really worried about this phase. But as a doctor, I'm worried about what happens after day 4. So day 4 later, like day 5 and day 6, sometimes day 7, this phase is called as critical phase. So what happens in this critical phase? In the critical phase, the platelet count starts dropping. So during the fever period, the platelet may not fluctuate much. A minimal drop may happen, but it's generally insignificant. When the fever starts settling down, that is where you start seeing a significant drop in platelet count. So platelet count starts decreasing in the critical phase. So day 4, day 5, day 6, day 7, this is a period where platelet count start dropping. Now, as a doctor, should I be worried about Sutapa? Because the intensity of musculoskeletal pain is so severe that it feels like someone is breaking their bones. Well, this is what the books describe. I have seen at least 300 to 400 patients of dengue over last 10 years. And none of my patient was so much bothered about the bone pains or joint pains or musculoskeletal pain. They complain about pain, but I don't think like truly we should be calling it as breakbone fever. Or maybe it was seen commonly in the past, but today we have readily available analgesics and patients take analgesics, so probably they do not experience that intense pain. But yeah, books mention, old teachers are particularly fond of this term, breakbone fever. Okay, so in the critical phase, platelet count start dropping. As a doctor, should I be worried about it? The truth is that in whatever number of patients I have seen, I have no mortality in dengue cases. But yeah, I know friends, colleagues who lost dengue patients. Of course, it's not their mistake. I'm not saying that. But none of them, as far as I know, died because of the low platelet. They bled to death. It can happen, but it is rare. But the critical phase, deaths are very common. Then why does the death happen if it is not because of low platelet and bleeding? So in presence of dengue virus, in the critical phase, there is capillary injury. So fluid starts leaking from the capillaries to whatever spaces it can leak into the peritoneum, into the pericardium, into the pleural space. So we will call it a third spacing of fluid or fluid extravasation. So there will be capillary leak, and this capillary leak will lead to pleural effusion, ascites, even pericardial effusion. Okay, these effusions are also not a concern. But the problem is, as I start leaking fluid from the capillaries, what will happen to the circulating blood volume? I'm losing water from the blood, right? Because of these capillaries, they're leaking. So the circulating blood volume starts coming down. And because of this severe decrease in the circulating blood volume, patient can go into a state of shock. That is what you call as dengue shock syndrome. So majority of the dengue deaths happen because of dengue shock syndrome and not because of thrombocytopenia leading to bleeding. Because as long as platelet count is more than 10,000, the chances of bleeding is very less. Until and unless you have additional risk factors, nobody bleeds. In centers where I practice, we have never transfused platelets when the platelet count was more than 10,000. There are doctors and centers where they transfuse at higher platelet counts, 20,000, 30,000. But if I see no bleeding tendency and platelet count is 10,000 plus, we don't transfuse because that's what the national guidelines recommend. So we don't need 1 lakh platelet count for a normal individual who is going through dengue to prevent bleeding. 10,000 plus is more than enough. Yeah, if the patient is going for surgery, I need higher platelet count. But someone who is just hospitalized or staying at home, as long as platelet count is 10,000 plus, it is unlikely to be a reason for death. But this capillary leak leading to dengue shock syndrome is an important reason for death. So this capillary leak happens, and can I identify that this patient has started leaking the fluid from the capillaries? If you can do ultrasound to see the presence of pleural effusion, ascites, and pericardial effusion, you already know that leaking of fluid from the capillary is happening. But then how easily it is available? In metros, major cities, it is available, but in small, remote places, ultrasound may not be feasible for you to do it every 2 hours, 4 hours in a patient to see whether capillary injury has started or not. So then can I predict the capillary leak happening? Yes. So as the water starts leaving the blood through capillaries, what will happen? The concentration of the blood starts increasing, and that I can easily monitor through what we call as hematocrit. So we start seeing increasing hematocrit, and that's why monitoring hematocrit is very, very important when you are monitoring a patient of dengue. More important than monitoring the platelet count, because if you see hematocrit has jumped more than 20% from the previous value or the baseline value, you know that significant hemoconcentration has happened, significant the plasma leak has happened through the capillary dysfunction. So you need to give them adequate fluid resuscitation. If you do not give sufficient fluids, they will get into dengue shock syndrome and you may end up losing them. Okay, so during this critical phase, you also start noticing that the liver may start becoming little dysfunctional. So that you may have increase in liver enzymes, that is SGOT and SGPT. Now, after this, if during this period patient does not die, platelet count does not lead to a critical low value and he doesn't bleed and die, or he doesn't get into dengue shock syndrome and die, then recovery starts. So the recovery phase may last for 3 to 7 days. During this period, the platelet count starts improving, hematocrit stabilizes, patient symptoms resolve, he starts feeling well, he starts tolerating food, he is no longer nauseated, he is no longer bothered by pain. And then eventually the platelet count will normalize, hematocrit will normalize, and the normalcy is re-established. This is the natural course of illness of dengue. So the most important period is day 4 to day 6 or day 7. That is the critical phase where platelets drop, hematocrit rise because of the capillary leak. Okay, so the same thing that we have discussed, I have put a small graph for you to replicate. So as the graph says, the days of illness and the symptoms. So temperature, usually fever is high grade in first 4 days. That's the febrile phase. After that, fever settles. Sometimes there may be a bounce back of fever, but most patients remain fever free after first 4 days of fever. So in the first 4 days, maybe dehydration is a potential clinical issue, but nothing beyond that. But during the critical phase, shock risk is high. And if the platelets drop, bleeding risk is high. And just like I mentioned, if patient goes into shock, they may get into acute kidney injury, the pre-renal type, right? They may also have ischemic hepatitis, liver dysfunction, rising enzymes. Those things are expected. And if the critical phase is over, that is day 5, 6, or sometimes 7, then the recovery starts. But in the recovery phase, there is a possibility of complication, which is one of the common mistakes done by doctors per se. What is it? So during the critical phase, because of the capillary injury, the fluid has left the blood vessels and gone into the tissues, right? Pericardial space, peritoneal space, pleural space, third spacing of fluids. During this period, because the blood volume is down, we are giving fluids. But once you recognize that the recovery has started, you have to cut down or stop giving the fluids. Why? Because during the recovery period, the reabsorption of fluid happens. The fluid which has leaked into all these spaces starts coming back to the blood. So the blood volume will start rising. And if I also keep giving external fluids, I will expand the blood volume so much that I will cause fluid overload. Patient may develop pulmonary edema. So that's why we have to be very cautious in giving fluids after the critical phase. So on day 6, 7, 8, we need to be watchful of the patient's fluid parameters. With respect to laboratory changes, the platelet count start dropping after the febrile phase, remains low, may reach a very low level during the critical phase, and then eventually starts rising during the recovery phase. And because capillary leak happens in the critical phase, the hematocrit starts rising in the critical phase and then gets normalized during the recovery phase. Now, with respect to the serological studies, during the febrile phase, the first 4 days, the dengue virus is replicating like anything, but then body isn't mounting an immune response yet. It takes some time. So you don't detect the dengue antibodies in the first 4 days. If you want to detect, you have to detect the dengue virus antigen, that is NS1. But after 4 days, you start detecting the antibodies. The initial antibody is going to be IgM, eventually IgG. So IgM always indicates the acute dengue infection. IgG may be pointing towards past dengue infection, right? So this is about the natural course of dengue illness. Now comes the real part. Objectively, what your teachers are looking for if there is a question on dengue. They want you to mention differences between dengue fever, dengue hemorrhagic fever, and dengue shock syndrome. 3 terms. They are all not same. Dengue fever is like any case who has been infected with dengue, who has fever of 2 to 7 days duration, and has any 2 of the following manifestation. That includes headache, retroorbital pain, muscle pain, or joint pain. But there should be no evidence of plasma leakage. If there is evidence of plasma leakage through capillary injury, then we will start considering it as dengue hemorrhagic fever. Okay. And how do we recognize that? There is no rise in hematocrit by more than 20%. The rise may be less than 20%. Okay. There is no pleural or pericardial effusion or ascites. then you can say that there is no plasma leakage. Patient has been infected with dengue, is getting fever and symptoms related to that, but there is no plasma leakage. Then we will call it as dengue fever. Now, if a patient of dengue fever has hemorrhagic tendency, what do you mean by hemorrhagic tendency? You have developed petechiae or ecchymosis, gum bleeds, or any active bleed. Along with that, you have also developed thrombocytopenia, that platelet count is low. Platelet count is decreased. And you have the evidence of plasma leakage. What is the evidence of plasma leakage? Increase in hematocrit by more than or equal to 20%. So what was the previous baseline value? Over and above that, the hematocrit is increased by more than or equal to 20%. Or patient has developed clinically significant pleural or pericardial effusion, or ascites. Mild pleural effusion, pericardial effusion, and ascites are common. Clinically significant values encountered, then there is evidence of plasma leakage. So let me summarize what you should remember, because of course objectively you can't remember all the words that I'm mentioning here. So dengue fever is just fever and related symptoms, no evidence of plasma leakage. What is dengue hemorrhagic fever? Hemorrhagic tendency is there in the name itself. So dengue hemorrhagic fever refers to a patient with dengue fever, but additionally he has tendency to bleed in the form of petechiae, ecchymosis, gum bleeds and all. Platelet count is low, and there is also evidence of plasma leakage. Okay. The next entity is called as dengue shock syndrome. So what is dengue shock syndrome? Dengue shock syndrome is nothing but a dengue hemorrhagic fever. That means dengue fever with evidence of plasma leakage and thrombocytopenia, who has now gotten into a state of circulatory failure or shock. Now the shock definition here is clinical, because the WHO had to create definitions which are applicable to resource limited countries. Then sitting in Nigeria, if I have to diagnose dengue shock syndrome, right, I can't diagnose it by measuring the plasma lactate values and all, not possible. So that's why it's very simple, clinical. So any patient with dengue hemorrhagic fever, if he has weak rapid pulse, means what we call as steady pulse, very weak, difficult to palpate pulse with increased rate, or the pulse pressure. What is pulse pressure? Difference between systolic and diastolic pressure less than 20 millimeters of mercury, or evidence of hypotension, or even if I can't look at that, even cold, clammy skin, or patient being restless, we will count this as a dengue shock syndrome. Particularly a tip from a practicing physician that I want all the MBBS students to know: if you see a dengue patient with restlessness, count it as a red flag sign. In fact, I can give you an example that I had a junior colleague who had just completed his post-graduation and started the practice along with me in a hospital. And during the rounds, we were chit-chatting, and he was standing next to a patient, and the patient was a bit restless. And he asked me, like we were talking about, I asked him, what is this case, man? Looks a little restless. He says it's some fever and abdominal pain. That was a season of dengue. Bangalore was going through outbreaks of dengue. So I just told him, like, if he's dengue and restless, man, it looks bad, man. So he's like, yeah. I told him, just call the attenders and counsel about all possible negative outcomes, because he's quite restless, and that's not a good sign, because he has just got admitted. We don't know his platelet count, his hematocrit and all, but once we monitor, I'm very sure if you're so restless, the hematocrit will be rising, his platelet count will be dropping, and that's what eventually turned out to be. Unfortunately, that fellow gotten into the dengue shock syndrome, and lucky enough to survive with the resuscitation and medical management. But if that restlessness was not taken seriously and ignored and just treated like any other simple dengue fever, there could be a possibility of mortality, and my colleague would have also gotten into trouble with the family. So please remember, you see any patient with dengue who is restless, take it as a serious case. Even if the current BP is fair, even if everything appears good, take it as quite a serious case. Okay. So this is about the case definitions. What is dengue fever? What is dengue hemorrhagic fever? And what is dengue shock syndrome? Okay, now that I have recognized the dengue, how are we going to manage? So when it comes to the, I forgot to talk about the diagnosis itself. So first let us address the diagnosis. So if clinical symptom wise, especially rainy season, lot of dengue patients reporting in the hospital, and I got one more patient with fever. Dengue is always a suspicion. I have to investigate. So in the first 4 days, that is the febrile period, body wouldn't be mounting an immune response. So IgM, IgG will be negative. So during this period, you can test for the dengue antigen. NS1 antigen. NS stands for non-structural. So dengue has some structural and non-structural proteins. So we are looking for the presence of this non-structural protein 1 or NS1. Now after 4 days, we can go for the dengue serology. Dengue serology, looking for IgM and IgG antibodies. And as we know, IgM always indicates acute infection. If IgM is negative and only IgG is positive, it may be pointing towards a past infection. If both are positive, it's again acute infection. But if only IgG is positive, it is pointing towards a past infection. Once you're diagnosed that this is a case of dengue, how are we going to manage it? So for management, the first thing is you need to monitor. See, dengue virus is not directly killing the individual. It is our own body's immune responses which are causing the inflammation of the capillaries, capillary leak, and loss of fluid is responsible for majority of the patient's death. So we don't give any antivirals to the dengue. We will just try to manage our own system. And the main worry is about patient getting into the dengue hemorrhagic fever or dengue shock syndrome and dying. So I need to monitor the possibility of this patient progressing. So please monitor two things you need to monitor: the platelet count and hematocrit or PCV. We have to monitor them serially, means not one value like, okay, patient got with fever and I checked hematocrit, right now it appears fine, platelet count appears fine. No, you have to serially monitor hematocrit and platelet count to see the trend. Okay, and if hematocrit is rising and if it is gone beyond 20% above the previous value, then you know that there is significant capillary leak happened. You need to have good fluid resuscitation for that patient to prevent shock happening in them. IV fluids are considered as the mainstay of treatment that reduces the mortality. Mainstay of treatment that reduces the mortality. If you use IV fluids judiciously, when required, give aggressively; when not required, withdraw. You will save the patients. Okay. Then third comes, okay, we are managing IV fluids and we are guided by hematocrit. If hematocrit is rising, once I start giving IV fluids, it should start coming down. So then I know that IV fluids are adequate. Next is platelet transfusion. When should I transfuse? Less than 10,000 platelet count, less than 10,000, prophylactic transfusion. Means if the platelet count is less than 10,000, the chances of spontaneous bleeding is there. So then transfuse prophylactically. But if platelet count is more than 10,000, you don't have to transfuse prophylactically. Then you should transfuse only if there is bleeding. And spontaneously bleeding is unlikely to happen when the platelet count is more than 10,000. But if there is trauma or other risk factors, they may be bleeding, transfuse. So the rule is simple. If a patient is bleeding and he has low platelet count, regardless of platelet count, transfuse. But if the patient is not bleeding, then as long as platelet count is more than 10,000, do not consider the transfusion, right? So this is about the dengue. So the dengue management is simple. It's all about IV fluids and platelet transfusion if required. Okay. Now let's go to the hematology part. I told you sometimes some universities ask about so-called red flag signs in dengue. Means what are the signs that you need to monitor in dengue which are pointing towards things not going well for the patient or pointing towards patient going into hemorrhagic fever or dengue shock syndrome. So the first one is rising hematocrit. Rising hematocrit. And I won't emphasize more. By now you should know that restlessness in a patient is a very bad sign. Okay. Then third, hypotension. Fourth, severe abdominal pain. And fifth, bleeding. So these are considered as the red flag sign. Okay. So that completes our discussion on the dengue. So apart from these two infections, I also want you to go through the thorough section on the MEDED app, which covers other important infections like tuberculosis, malaria, leptospirosis. Okay. Now let me take you through the hematology. Hematology, according to me, these are the important questions that are going to come as long essays: anemia, leukemias, and lymphomas. With the available time, I will try to cover the leukemias with an emphasis on the AML and CML. But I will give you a table which covers all the leukemias, and as long as you are able to remember this table, and you should be able to answer the questions coming from any of the leukemia, right? So let us start with the basic understanding of leukemias. Okay, the question may go like this: define leukemias, classify leukemias, and discuss about the clinical features of AML and CML, and write briefly on their management. Okay, so what are leukemias? I know most of you know that it is blood cancer, right? This much we already know. But then what are the differences between these terms, lymphomas and leukemias? And within that, we have AML, ALL, CML, CLL in leukemias, and we have Hodgkin's and non-Hodgkin's in lymphoma. So what are the technical differences between them? Okay, so before defining leukemias, let us understand all these blood cancers or hematological malignancies. How are they classified? The classification of hematological malignancies or blood cancers depends on the origin of those cancer. Where is that cancer originating? Because when we talk about blood cells are first formed in the bone marrow. They go through phases and then eventually they become mature cells, mature RBCs, WBCs, right? And then they are released into the peripheral circulation. So what we get in peripheral circulation is mainly mature cells. But if I look into the bone marrow, I will have some mature cells which are to be released to the peripheral circulation, and plenty of the stem cells which have to go through the maturation to become final mature cells, right? You can call them as immature cells or blasts, myeloblasts, lymphoblasts. So whether the origin of this cancer happens from the immature cells, that means inside the bone marrow, or whether it happens from the mature cells, that means outside the bone marrow, that is the basis for classifying. So if the origin of the cancer is inside the bone marrow, that means it is originating from hematopoietic stem cells. Hematopoietic stem cells, or in other words, immature cells or precursors of the blood cells. Then we will call them as leukemias. We will call them as leukemias. Okay, and if the blood cancer originates from the mature cells are present in the lymphoreticular system, means lymph nodes, blood, liver, spleen. So if they originate, that means they are originating from mature cells. Then we will call it as lymphomas. Then we will call it as lymphomas. So when you talk about Hodgkin's, non-Hodgkin's, B lymphoma, T cell lymphomas, these are originating from mature B lymphocytes or mature T lymphocytes. But if a cancer originates from the lymphoblasts, means immature cells, it is originating in the bone marrow, then we will call it as leukemia. And depending on which progenitor cell is leading to development of cancer, we will classify them. If it is originating from myeloblasts, then we will call it as myelogenous leukemias. And if they are originating from lymphoblast, then we will call it as lymphogenous leukemias. And myeloblastic leukemias can be of two types: acute myeloblastic leukemia and chronic myeloblastic leukemia. Similarly, lymphoblastic leukemia can be of acute lymphoblastic leukemia and CLL, chronic. Okay, how do I differentiate between acute and chronic? Simple. The patient is likely to develop acute florid manifestations, significant severe manifestations, if there is too rapid proliferation of these blasts. And if there is too rapid proliferation, the amount of blast cells will be more. If there is slow proliferation, the amount of blast cells will be less. So the percentage of blasts in the bone marrow is a deciding factor whether I will call it as acute or chronic. So if the number of blasts is more than 20%, let us say there is a cancer originating in the bone marrow and it is originating from myeloid lineage, myeloblasts. And when I look at the bone marrow biopsy, more among overall cells present, more than 20% are myeloblast. So if the blast percentage is more than 20%, then it is AML. But if the blast percentage is generally less than 20%, then it is CML. Same applies to the ALL as well. So if the blasts are more than 20%, it is ALL. And if the blasts are less than 20%, but it is lymphoblast, then it is CLL. So you're getting the point. The blood cancers are classified into lymphomas and leukemias. Lymphomas originate in the periphery from the mature blood cells. Leukemias originate in the bone marrow from the precursor cells or the stem cells, what we call as blast cells. If they are originating from the myeloid lineage or the myeloblast, then it is either AML or CML, depending on how much percentage blasts are there. More than 20% acute, less than 20% chronic. Same applies to the lymphoblast. More than 20% blasts ALL, less than 20% CLL. Okay, I hope this clarity we have. And then lymphomas, we have further classified them into, as we know, Hodgkin's lymphoma and non-Hodgkin's lymphoma. Okay, I definitely want you to read about Hodgkin's and non-Hodgkin's as well. It is there in the methods for a note section. You can quickly glance through and you should be able to write. So today I'll give you just how we can write questions on AML and CML. Okay, so AML is what then? AML is a blood cancer. So when you have to define, how will you define? AML is a hematological malignancy originating, it's a leukemia, right? It's a hematological malignancy originating in the bone marrow from myeloid precursor cells or myeloblasts. What problems it will lead to? The myeloid blasts will start replicating in large number, and when they're not going to mature, they fail to mature, they don't become mature myeloid cells in the final path. So they are just replicating in premature form and large numbers, but they fail to mature. So what will happen? These cells start accumulating where in the bone marrow, and when bone marrow is full, they'll also like spill over to the peripheral circulation. They go to different tissues. They start accumulating in the tissues. So what problems they are going to cause? One, at the level of marrow. Second, because of the tissue infiltration. So what will happen to the marrow? If all these premature myeloid cells start accumulating in the marrow, the mature cells, we are not maturing them, so the number of mature cells starts coming down, and because of the marrow infiltration, even the space available for other marrow cells to proliferate is all compromised, because all of that is being taken by these cancerous cells. So because of that, you end up with pancytopenia. What do I mean by that? All the three cell lines that we see in the peripheral blood is going to decrease, because the bone marrow, the production factory is all occupied by these myeloblasts. So you will have anemia or decreased RBC count, right? Then you will have decreased WBC count, and you will also have thrombocytopenia. And all of these manifestations can lead to their own clinical consequences. Anemia can lead to fatigue, heart failure, pallor. Decreased WBC count can increase the risk of developing infections. Thrombocytopenia can increase the risk of bleeding. Okay. Apart from that, these myeloblasts from the marrow, they are coming to the blood and they are reaching different tissues and they are infiltrating tissues. So tissue infiltration can lead to various manifestations. One of the manifestation which is typically asked as an MCQ as well is that these patients, when these myeloblasts infiltrate the gum, they can cause gum hypertrophy. Gum hypertrophy. And when these myeloblasts, or not just myeloblasts, when blast cells, even in like lymphoid leukemias, when the blast cells accumulate in a tissue like a tumor, like let us say they come to the skin and they all collect there and it appears like a tumor, that tumor like presentation of a conglomeration or a collection of blast cells, we call it as chloromas. So they may end up with chloromas. Chloromas are nothing but aggregation of blast cells in various tissues. Wherever some tissue has an aggregation of blast cells, that will be called as a chloroma. So what all AML is leading to? It is causing the failure of the marrow because it is taking up all the space available in the marrow. Second, it is coming to tissues and depositing here. It is causing gum hypertrophy and chloromas. Like you see in this picture, this patient is a classical case of AML who has developed gum hypertrophy. Okay. Apart from that, all these premature cells, they will also die. Means they will keep replicating, but they will also die. But when they die, they leak the content of the plasma into the blood. I mean, content of the cytoplasm into the blood. And the cytoplasm is high in potassium and uric acid. All of that gets leaked into the plasma. So the plasma level of potassium increases, uric acid increases. And we will call this as, so you can have hyperuricemia, hyperkalemia, and you may sometimes have hypocalcemia. And collectively, these manifestations can be called as tumor lysis syndrome. Tumor lysis, because these symptoms are coming because of the lysis of these tumor cells, so breakdown of cancer cells. It could happen naturally because of the cancer cells dying, or sometimes it can also happen because of chemotherapy. Because I give some chemotherapy medication, they will kill the cancer cells, leaking high amount of uric acid, potassium into the blood, giving rise to so-called tumor lysis syndrome. So these are the manifestations we are expecting because of AML. Marrow failure and related consequences, infiltration of blast into the tissues, and the death of blast cells, leaking uric acid, potassium into the blood, causing tumor lysis syndrome. Okay, so now if I'm suspecting it as a case of AML, potential clues could be the pancytopenia. So when we talk about pancytopenia, we have some number of causes. So as we keep ruling in, eventually we may come to the conclusion that this could be AML. Gum hypertrophy is again a good clue. So if you see chloromas anywhere, that's a good clue. Now you want to confirm it. So how will I establish the diagnosis of AML? So if you do peripheral smear, you may get pancytopenia, but apart from the pancytopenia, you will see there is increased number of myeloblasts. Increased number of myeloblasts. In the periphery need not be 20% plus, but if it is 20% plus in the periphery, it's very sure that in the marrow it will be even more. So in that case, it's anyway, you know, it is AML. So increased myeloblast, and some of these myeloblasts, particularly in some variants of AML, will have azurophilic needle-like inclusions in the blast cells called as R rods. So if R rods are seen, it is highly diagnostic of this needle-like inclusion that you see here is called as R rods. So this is what your teachers are particularly looking for in your answer. You should be able to mention R rods. Okay. Then if I do bone marrow, what are the findings I'm going to get? Now you only tell me, bone marrow will be hypercellular or hypocellular? I have pancytopenia in the blood. In the blood, all the 3 cell lines are decreased because the precursors of those cell lines in the bone marrow are dying because all these blasts are taking up the space. But because blasts are there, the bone marrow will not be hypocellular. It will be hypercellular. Hypercellular. The number of cells in the marrow is increased because all these cancer cells are replicating. Hypercellular marrow with more than 20% myeloblasts. More than 20% myeloblasts. Okay. Apart from that, we are in the era of more advanced diagnostics. So you can also look for cytogenetic abnormalities like translocation between 821 or inversion of 16 or translocation between 15 and 17. And there are also molecular studies identifying mutations responsible for development of AML like FLT3 mutation and NPM1 mutation. Not important for you to write in your proc exam, but this is an important MCQ per se. This is the most common. NPM1 mutation is the most common mutation in AML. It's a new field per se, because now we have targeted treatments available for different mutations. At a UG proc level, you don't have to comment about it. As long as you're able to mention that in the bone marrow, the marrow is going to be hypercellular with more than 20% myeloblasts, and the myeloblasts may show what we call as or rods. Your teachers are more than pleased, and they will move forward to the remaining part of AML, that is about management. Okay, now when it comes to the management of AML, it's an acute hematological malignancy. So first thing is, all these myeloblasts which are taking up the space in the marrow and stopping the other marrow cell lines from growing, and then they're infiltrating the tissues and causing the tissue damage. The first thing is, I have to bring down the number of blasts that are there in the body right now, so that all these complications come down. And after that, the relapse rate is very high, so I need to make sure that the relapse does not happen. So that's why the treatment will be divided into two phases. Initial induction phase, where we want to destroy these cancerous blast cells, and after that, a consolidation regimens where we are trying to prevent the relapse of this cancer. So what we can use for this induction regimen? So there is something called as 7:3 CD regimen. What does it stands for? So we give the treatment for 7 days. So day 1 to day 7. So in that, for all the 7 days, the C here stands for cytarabine. So for all the 7 days, we are giving this patient an infusion of cytarabine. So from day 1 to day 7, he is getting daily infusion of cytarabine. But from day 1 to day 3, also he gets an additional drug, that is going to be daunorubicin or doxorubicin. So this regimen is what we call as 7-3 CD regimen. So 7 days of cytarabine, 3 days of daunorubicin. So first 3 days he gets both cytarabine and daunorubicin or doxorubicin, but the remaining 4 days, means day 4, 5, 6 and 7, he only gets cytarabine. This regimen is what we call as induction regimen. This like literally destroys most of the blasts. So now the patient's symptoms improve, bone marrow functions will start improving, but the chance of relapse is there. So we have to prevent that relapse. So whatever treatment we give for prevention of relapse, we will call it as consolidation regimen. Consolidation regimen. So what I can do here, either you can continue cytarabine for a long period of time. This is now considered as the first line treatment. But if feasible, you can also go for the bone marrow transplantation or hematopoietic stem cell transplantation. Bone marrow transplantation, more technical term is hematopoietic stem cell transplantation. This is considered as the second line treatment. So one of them can be offered to prevent the relapse of AML, right? So let me quickly summarize what we have discussed. AML is a leukemia, means it is originating inside the bone marrow, and as the name says, M means myeloid, so it is a myeloid leukemia with more than 20% blasts in the bone marrow. And because of this increased number of blasts, bone marrow failure happens and blasts infiltrate the tissues, giving rise to gum hypertrophy and chloromas. And if the blast cells die, they will release their intercellular components, causing hyperuremia and hyperkalemia. Now, if I have to establish diagnosis, I have to go for the bone marrow biopsy, where I will get hypercellular marrow with more than 20% myeloblasts. Pathologist, if required, they will try to identify CD markers for the myeloblasts to ensure that what they are seeing as increased in numbers are indeed myeloblasts. What examiners are looking for? You mentioned that it's hypercellular marrow with more than 20% myeloblast with OR rods. Now, when it comes to the management, we follow an induction regimen and a consolidation regimen. Induction regimen is 7-3-CD. So 7 days of cytarabine, 3 days of doxorubicin or daunorubicin. And consolidation is with just cytarabine or bone marrow transplantation. But there is one extra point I want you to write. There is a subtype of AML called as acute promyelocytic leukemia or APML or APML. So for that, you need not go for this induction regimen. Instead, you can use a drug called as all trans retinoic acid or ATRA. This is again more of an MCQ point. If you can write in a prof exam, good. If not, as long as you're able to write the induction and consolidation regimen, it's more than enough. Now there is a subtype classification of AML, which at a final prof MBBS medicine, you're not expected to write, mostly from the pathology as well as in MCQs, they expect. During my time, we used to follow FAB classification. Now it is WHO. I'm just leaving a table here of that WHO classification. If you find time to remember it, go through it. Otherwise, you can skip it. Okay. Now let me take you through the next part, that is CML. AML is what? Acute leukemia of myeloblasts having more than 20% blasts. When the blasts are less than 20%, but they are myeloblasts, we will call it as CML. AML had various causes, like a lot of cytogenic abnormalities were contributory. Translocation between 821 or 1517 or inversion of chromosome 16, FLT3 mutation, NPM1 mutation. When it comes to CML, it's all about one cytogenetic abnormality. What is that? A reciprocal translocation between chromosome 9 and 22. And this reciprocal translocation leads to fusion of two genes, like components of chromosome 9 and 22 are fused to form what we call as a BCR-ABL fusion gene. When these genes fuse, they express, or there is increased production of tyrosine kinase. And acting through the RTKs or receptor tyrosine kinase. These are the receptors for tyrosine kinase. These tyrosine kinase will lead to suppression of apoptosis, and because of this there is increased proliferation of myeloblasts or myeloid precursor cells. So because of that, there is slowly accumulation of myeloblasts in their immature form. They fail to mature as such. So this is similar to AML, but the number of blasts will be less than 20%, right? And the reason for this is the reciprocal translocation between chromosomes 9 and 22, bringing BCR and ABL together and causing the BCR-ABL fusion gene. And this is what we call as Philadelphia chromosome. And that has resulted in increased activation of the tyrosine kinase, and that has resulted in increased proliferation of myeloblasts. A very, very important point to learn here. If I want to suppress the myeloblast proliferation, what should I do? I should block this tyrosine kinase. Right? If I block the tyrosine kinase, then the proliferation of myeloblasts will come down. So that's why when we talk about treatment of CML, we use the tyrosine kinase antagonist or blockers. So see, if you have a case of AML or CML or anything, so if the patient's hemoglobin is less than 7, we might have to give for blood transfusion. Blood transfusion is not therapeutic. What we're talking about is bone marrow transplantation. We are not transfusing blood. We are doing the bone marrow transplantation. See, what bone marrow transplantation does is it instills normal, without genetic seed, no cytogenic, the precursor cells or hematopoietic stem cells with no cytogenic abnormalities. this patient had cytogenetic abnormalities which has resulted in development of AML, like those we mentioned here. These chromosomal anomalies or mutations were there in these patients' stem cells. That's why they were replicating uncontrollably. But if some healthy donor who does not have these cytogenetic abnormalities, if their marrow cells are transplanted, then this marrow will start producing cells which will mature finally. And anyway, we are giving the chemotherapy or immunosuppressant to suppress the abnormal cancer cells. Okay, so now the CML. Let us say someone developed this reciprocal translocation or Philadelphia chromosome, BCR ABL genes fused, and now there is increased activity of tyrosine kinase. So blast starts replicating. So how will they present? The clinical features of CML present in phases. So the first phase is chronic phase. 90 to 95% of the cases when they get diagnosed, they are in the chronic phase. In this chronic phase, mostly they are asymptomatic. They are asymptomatic. They may have some vague symptoms, means some fatigue, malaise, or sometimes they may develop splenomegaly. But otherwise, they're not specifically much symptomatic. Many of them get accidentally discovered as having CML, means someone does a complete blood count, peripheral smear, and then they start noticing abnormalities because there is increased proliferation of myeloblasts. So that leads to marked leukocytosis. So when someone sees high amount of WBC count, then they start investigating, sometimes as high as 1 lakh or higher. They start investigating and then they may come to the conclusion that, oh, this is a case of CML. But in terms of symptoms, they may not have any symptoms. But some of them, either at the time of presentation or eventually progress to what is called as accelerated phase. So what is this accelerated phase? See, chronic phase is a typical CML where patients have blasts which are less than 20%. And these blasts are not giving rise to any symptoms as of now. But if the blast starts increasing in number, we will get into this accelerated phase. In the accelerated phase, we diagnose it by presence of any one of the following parameters. What is it? WBC count more than 10K, platelet count less than 1 lakh, or sometimes platelet count more than 10 lakh, or more than 20% basophils, or development of massive splenomegaly, or blast cells in the marrow in the range of 10 to 19%, and patient not showing response to first generation TK. It may be confusing to you. I'll clarify. Just let me go through the points first. If any of these features appear, we will call it as accelerated phase. Okay. But then eventually some of these patients can go into what we call as blast crisis. So what is this blast crisis? Blast crisis refers to a patient of CML progressing to AML. That's as simple as that. A CML becomes AML, then it is called as blast crisis. How did we define AML? Myeloblasts more than 20% in the marrow. CML less than 20%. But one day, if the blast either in the peripheral blood or bone marrow, if they become more than 20%, that is similar to AML, right? Then we will call it as CML going into blast crisis. Indirectly, CML progressing into AML. Or if you get extramedullary blasts, means blasts outside the marrow and the blood system or the blood vessels or the blood. Outside means in the tissues. And when blasts accumulate in the tissues, what do we call it as? Chloromas. So if you get any patient of CML with chloromas, it is considered as equivalent to AML, and we will call it as blast crisis. Okay. So now, how do I recognize CML? CML is recognized mostly they are in asymptomatic stage. When you get high WBC count, when they present with some vague symptoms, you get high WBC counts and you see that there is increased blast, but certainly not more than 20%. Then it is the CML with chronic phase. Now, when they are in chronic phase, we start treating them. What should be the treatment of CML? There is increased activity of tyrosine kinase, so I should treat them with tyrosine kinase blocker like imatinib. imatinib mesylate is considered as a drug of choice. Recently concluded FMGE exam has a question on it. So once you give imatinib, you expect these splenomegaly, blast cells to all settle down. They all should settle down. But if despite treatment, if their WBC count remains high, despite treatment, or despite treatment, if their platelet count remains low or high, or their basophil counts, which are one of the end products of myeloid lineage, despite treatment, if their basophil count becomes high, or you have splenomegaly which is not shrinking despite treatment. Despite treatment, the blasts in the peripheral blood or marrow remain more than 10%. See, if I had diagnosed it as a chronic phase and if I had started them on imatinib, if they are responding, the blast should be less than 10%. If they remain more than 10% despite treatment, then it is accelerated phase. So they are not responding to the tyrosine kinase inhibitors, what we call as the first generation tyrosine kinase inhibitors. We are going to call it as accelerated phase. Now, eventually, if the blasts increase beyond this number and go more than 20%, or I start seeing accumulation of blasts in the peripheral tissues, that is chloromas, then we will call it as blast crisis, which is equivalent to AML, right? I hope now you understood. They present with some vague symptoms, leukocytosis, the count may be even more than 1 lakh, the WBC count, and basophils high, all of these will be there, the hematological parameter abnormalities, that is your chronic phase. And you start them on first generation tyrosine kinase inhibitors. Expectation is all these things resolve, but if they fail to resolve and they continue to have WBC count more than 10k despite treatment, or platelet count low or high despite treatment, or basophils more than 20% despite treatment, splenomegaly persisting or progressing despite treatment, or blast remaining more than 10% up to 20% despite treatment, more than 20%, we will call it as blast crisis. Then we will call it as accelerated phase. From accelerated phase, if the blasts increase to more than 20% or chloromas appear, then it is a blast crisis. Clear? Now let us look at how do we diagnose them. If you do complete blood count and peripheral smear, you will notice leukocytosis. The leukocyte count may be even more than 1 lakh per cubic millimeter at the time of presentation. But as I've already told you, with imatinib, you're expecting it to come down to less than 10,000. When it doesn't come, it is accelerated phase. So blasts will be generally less than 20%. More than 20%, it is a crisis. You can have increased basophil count as well as eosinophil count, because all of these are derived from the myeloid lineage. And in the bone marrow, we are going to get hypercellular marrow, because there is increased production of myeloblasts, but myeloblast percentage will be less than 20%. Less than 20%. If you want, you can make a note. If more than 20%, in a case of CML, we will call it as blast crisis. So this is the peripheral smear and marrow findings. What cytogenetic studies will show? You can either do PCR or fluorescent in situ hybridization to identify BCR ABL fusion gene. This is considered as the investigation of choice, because it can clearly prove that there is an underlying Philadelphia chromosome or BCR ABL fusion. Okay. So that's about our diagnosis. And once you have established the diagnosis of CML, how are we going to manage? So if it is a chronic phase where you have less than 20% blast, patients are not grossly symptomatic, but you have abnormal peripheral smear, bone marrow studies, and the the markers. In this case, you will start treating with the first generation tyrosine kinase inhibitors. Tyrosine kinase inhibitors. Examples for first generation tyrosine kinase, it is imatinib mesylate. All the drugs that end with nib are tyrosine kinase inhibitors. Imatinib, mesylate. So this is what I start. But despite starting this, if the blasts remain more than 10% up to 19%, or WBC count remains more than 10K, platelet less than 1 lakh or more than 10 lakh, basophils more than 20%, then it is accelerated phase. So once someone gets into accelerated phase, the first generation tyrosine kinase inhibitors are no longer considered suitable for treatment. So then we have to go for second generation or higher. So now we have third generation, they are preferred. So treatment will be with third generation tyrosine kinase inhibitors. These are more effective inhibitors of tyrosine kinase so that myeloblasts don't replicate uncontrollably. An example for this is bosutinib. Okay, fair, if they respond to this, good, but if they don't, they will end up with what we call as blast crisis, where the number of blasts will jump from 19% to higher, 20, 25, 30, 35% higher. Once they get into the blast crisis, it is equivalent to AML, and we treat it just like how we treat AML. So treatment of AML in CML in blast crisis is similar to AML. How did we treat AML? We followed a 7-3 CD regimen, cytarabine, doxorubicin or daunorubicin based regimen, 7 days of cytarabine and 3 days of doxor or daunorubicin. Same thing, that is induction phase. Followed by that, we had a consultation with cytarabine or the hematopoietic stem cell transplantation. Exactly same thing we are doing if patient ends up with blast crisis. If they respond to chronic phase, first generation tyrosine kinase inhibitors, well and good, beautiful. If not, if they get into accelerated phase, the third generation tyrosine kinase inhibitor like bosutinib. But if they end up with a blast crisis, we treat it exactly how we treat a case of AML, right? So this is going to be our how we are going to approach the management of CML. So by these two questions, I hope you have got a gist of how we are going to write answers for the leukemias, and similar template will be followed for lymphomas. So key points you have to mention is keep in mind the basic pathophysiology, means exactly what is happening in these cancers. So in leukemias, the premature hematopoietic stem cells are replicating uncontrollably. In lymphomas, the mature blood cells, T lymphocytes, B lymphocytes, they are replicating uncontrollably. So lymphomas originate in the periphery, the lymphoreticular system. Leukemias originate in the bone marrow, but of course they can spread to the peripheral organs. And based on the leukemias, whether they are originating from lymphoblast or myeloblast, we will call them as myeloid leukemias and lymphoid leukemias. And based on percentage of blast cells, we will differentiate them as acute and chronic. So if more than 20% blast cells, it is acute. Less than 20, it is chronic. If it is lymphoid, then ALL, CLL. If it is myeloid, AML, CML. But all these malignancies have their own underlying cytogenetic abnormalities responsible for the cancer to develop. For example, translocation between 821 was one of the cytogenetic abnormality, mutation in NPML1 or FLT3 for AML. Then Philadelphia chromosome or fusion of BCR-ABL for CML. So if you remember these points, you will be able to replicate the answers. So to make it easier for you, on the note sheet, I will leave a table which compares all the hematological malignancies side by side. So if you kind of remember this table, then you can replicate the pattern of answer that we have discussed for the hematological malignancies, right? So that's it from me today. Today we have got a gist of how you will answer infectious disease questions. The simple template of answering infectious disease questions is try to remember the causative agent. If possible, try to write the route of transmission. And most importantly, please remember the natural course of illness and describe the clinical features under each phase, be it HIV, be it dengue, be it malaria, be it leptospirosis, be it enteric fever. And similarly, when you write about the diagnosis, make sure that you mention appropriate investigations according to the phase of the infection or the days after the infection. Like if I have to diagnose HIV in the acute HIV syndrome phase, only P24 or HIV PCR. After that, antibodies. Right? So similarly, if I were to diagnose dengue in first 4 days, only the antigen NS1, but after that antibodies. So keep that in mind. For example, enteric fever, viral only after first 7 days. In the first after first 7 days, in the first 7 days, viral test is not suitable. If you can do a serial monitoring, you can, but otherwise it's not suitable. So it is blood culture. So that is what teachers are specifically looking. They know they will assess whether you know which investigation should be done on what day of a infection. And with respect to the treatment, mostly they are keen to see whether you write the drugs appropriately. You don't have to remember the dose. You don't have to even, if not possible, no need to write the duration. But the drug of choice should be mentioned. And the key pathophysiological manifestations, like if you talk about HIV and respiratory system, pneumocystis carinii pneumonia, they are definitely looking for it. If you miss that, you lose some marks. And when it comes to hematological malignancies, they won't ask you to write a 10-mark essay on just AML or just CML or just ALL or just CLL or NHL. It will be part of a longer question asking you to write more things like classification of hematological malignancies or defining leukemias, and then also asking you to write a short note on the tumor lysis syndrome. So all you need to know for writing the hematological malignancies is what is the cytogenetic abnormality, what is the key pathology, like in AML, increased myeloblasts in the marrow more than 20%. CML, increased myeloblasts in the marrow less than 20%. ALL, increased lymphoblast more than 20%. CLL, increased lymphoblast but less than 20%. Non-Hodgkin's lymphoma and Hodgkin's lymphoma originating from the mature B or T lymphocytes, not from the premature cells in the marrow. So if you are able to write these key points in the definition or introduction, that opens the answer very well. Remaining points that you need to write, it is there in this table. So just by heart the table and you will be sorted for writing a 10-mark question on hematological malignancies. So that's it from me today. I'll be signing up because okay. So why viral is not done? See, the titer reaches. Okay, there are two, three things you need to remember. Viral is one of the extremely misused, abused test by coax and nowadays even MBBS doctors. So when you get infected with enteric fever, you have this bacteremia. The bacteria are now circulating in the blood for initial 1 week or so. Okay. After that, the antigens reach a load of detectable value. And then that's why we need to do it after 7 days. Before 7 days, if you do viral, if it is a non-endemic zone, it will come negative. And if it is endemic zone, even when you don't have enteric fever, you may have higher titers because you would have got some exposure and you will have higher titers and it may still come positive. So in country like India, which is endemic for enteric fever, you will have higher titers even in the first week of fever. Ideally, you should not have higher titers in the first week of fever. The titers will be higher significantly higher in the second week. But in endemic countries, it will be higher in the first week. So if you go by the standard cutoff, any patient with any fever will turn out positive in the first week of fever. So you will label everyone as enteric fever, and that is what happens when you see in the practice. You go to any quack or a non-modern medicine doctor with fever. On day 2, day 3, they do vital. They get some higher titer and they label it as enteric fever, give antibiotics. So they use it as a license to give antibiotics. If you want to use viral test within 7 days for the diagnosis, as I've already told you, India is endemic, so all of us have titers higher than what is seen in the non-endemic region or Western world. So if you are following the Western cutoff, invariably, even if I'm having dengue, my titer will be positive. So the best way, if you want to use it in the first week, is have a rising titer. Like do a titer on day 2, do a titer on day 4 or day 6, and then you see that the titer is rising, then you can use it as a diagnostic for enteric fever. But more convenient way to diagnose in the first week would be rather go for the blood culture. If blood culture detects, you have enteric fever. And second week, if it is positive, and again, the interpretation of viral is that I can't give you a standard number. So say that if titer is 1:40, 1:80, or 1:160, I can call it as positive, because you need to be aware of locally prevalent general population titer. And only when the titer is higher than that, then you can count it as positive. So if I'm practicing in Karnataka, Bangalore, I should know what is considered as a normal vital titer in general population. And when it is higher than that, then it is positive. The normal titer of this population may be higher than the Western standards that we study in the books. So that's why Vidal is a bit of a cumbersome, complex test to interpret in real practice. So that's why, like if I get a patient with fever, I would certainly investigate in the first week itself. And if I'm going with the investigation in the first week, it's the blood culture which is the investigation of